stochastic modeling of genetics and demography, also statistical analysis of clinical trial, a topic which is also a subject of our exploration today. So without any further delay, let us extend a resounding applause for our chief guest and welcome him.
Thank you. Thank you.
I would like to request Dr. Madhav Digavi sir to felicitate our guest of honor today.
Thank you. Thank you.
I would request our chief guest and Madhav Digavi sir to light the lamp and inaugurate the function.
Okay, sure. Thank you. Sure.
Thank you, sir. Now I request Dr. Gangabore sir to take on the dais and begin with the workshop session.
Thank you. Thank you very much. Do you have the pointer? Slide more and pointer if you have. Do you have the pointer? Slide more and pointer. Mouse not possible. Move around. It is okay. I forgot to bring it. It's okay. It's okay. Okay. Good morning to all of you. I request those who are sitting in the back side to come and occupy the front. Come. Okay. Let us start the first session. I would like to project a quote. This quote is taken from Park's textbook of social and preventive medicine. Before going to this, may I know how many of you have joined or preferred medical college and why? Please speak out. Please speak out. Why did you opted for medical course and why? There must be some reason, right? I just want to know that. Yeah, please tell me, what is your opinion about why did you join, opted for medical, why not engineering? Or any other course for that matter?
Due to interest in more towards biology.
More towards biology.
Yes.
What about your interest in mathematics and engineering?
I was not interested in mathematics.
Were you scared of it?
Yes,
Yes, you were scared of it. Yeah. Let me ask the second girl, the green dress. Why did you join this course?
Social services was my first thing.
Okay. Then what about your interest in mathematics?
Mathematics, I was good at mathematics, so that was my interest.
Okay.
Social services.
Okay. Oh, that's good then. Yeah, right. Please. Try to find one point. My experience I've been taught more than 70,000 students in a span of 45 years of varied disciplines, right from degree colleges, postgraduate in statistics, mathematics. Now currently I'm teaching for MTech data science students of Manipal University and Birla Institute of Technology, and of course medical many. But I speak to medical students. Why did you opt for joining medical college or medical science? The first answer they give is, sir, we are scared of mathematics, scared of numbers, scared of formulae. So we wanted to shift over from mathematics to biological sciences. Based on that experience, this quote was created by Park JE, right? Probably if you have read community medicine or community textbook written by J.E. Park and K. Park, this quote is given in that textbook, which clearly says that, you know, there was a belief that without mathematics I can learn medicine, or without statistics I can learn medicine. But currently, are you doing it? Are you not using any calculations in your study? Are you doing it or not doing it? Say, for example, GFR. Are you calculating or not? Is it not a mathematics? So that means that things have changed now. Things have changed. Wherein, that is where he says that he is comparing medicine, right, to a ship which is without compass. It becomes directionless. If the ship is without compass, or currently you can talk about GPS, it becomes directionless. So therefore, statistics is very, very important in all walks of life. It is not medicine. In the entire walks of life, it is very important. I just quote one example. Do you know even commerce people and accountancy people have a greater utilization of statistical methods like risk analysis, right? Portfolio analysis. All these are based on statistical methods only. No field is left without the application of statistical methods. Then, this is my personal quote out of my personal experience. In research, I've taken epidemiology and statistics, where I've compared epidemiology to heart and statistics to spine. Particularly in medical science research, when I say medical science, I'm not only talking about MBBS, everything put together, we call it as medical science. In medical science, research cannot be done without epidemiological designs. Maybe if you are in first year or second year or third year, I do not know. But are you not using the study designs? Have you heard of the so-called RCT, or otherwise called as randomized controlled trial? For any clinical trial where you want to establish the efficacy or effectiveness of a new drug as compared to a gold standard, you are supposed to use a study design called as randomized controlled trial, which is of very highest hierarchy in all the designs except meta-analysis and systemic reviews. Meta-analysis, systemic reviews are not for postgraduates, that is for faculty. But when it comes to, say, students or postgraduates, student researchers, the topmost is RC. Now they have gone one step ahead. We also talk in terms of crossover design. Crossover means you start with the two drugs. One is new drug, other one is a controlled drug. Measure, again, it is based on the principles of allocation, is based on RCT.
You measure how many, say let us take 30 patients in group 1 and 30 patients in group 2. Based upon the RCT, you treat them for the stipulated period of time. How long a patient has to be treated, that you need to do it. Once you complete the treatment modality using the first step, measure how many of the group 1 patients of 30 have been completely cured. Similarly, of the group 2, how many are completely cured? I'm sure you agree with me that all 30 may not be responding equally. There will be some patients either partially responded or some patients may not respond also. You agree with me? Right? Now, our interest is we leave out those who are responded. We don't want now to consider them, analyze them separately. Now, those who have not responded or partially responded, let us say in case of group 1, 80% have responded well, 20% either partially or no response. Similarly, in the control group, second group, 15% have responded, not responded well, 85% have responded well. For this 20% and 15%, you allow for what is called as washover period, meaning the effect of the drug what was already administered should be removed or nullified. Otherwise, it will act as a confounder. Then from there, once you establish that, okay, see, every drug has its shelf life, right? Based upon the shelf life, you allow them to be free from all the effects and then change over the drug. Suppose group A was treated with the drug B and group B was treated with the drug A. Now, change over group A with the drug A and group B with the drug B. Once again, you measure. See, this kind of designs are now popularized in allopathic clinical trials. They're becoming more and more popular these days because ultimate goal is patient relief. Right? Now, I'll raise one question in this crossover design. Suppose, let us say, in spite of all these, both the drugs used for treating, say 3% in both the groups still not responded to either of the group. What are you going to do? Suppose you are in that place. What is your response? What will you do? Please, see, this is not me talking from this end. I also want you to give your ideas. Don't worry, make a mistake. Tell the wrong answer. Make a mistake. We'll correct it. Tell me, what is your response? 3 patients in both the groups have not responded at all to either of the drugs. Which drug? Sorry. We don't have a C drug. We are testing only the efficacy of 2 drugs. I don't have a third drug. Right? You can't. I mean, what I'm saying is, let us say that 3 patients in group A and 3 patients in group B have not responded for neither of the drugs. You got my point? Started with one drug, some responded, then started with the second drug for the same group. Yet, 3 patients did not respond. What are we supposed to do, please? Can I expect the answer from you? Okay, then what are you going to do? What call are you going to take? Now, you're all postgraduates, at least you should know what are supposed to be done with this. Anybody for that matter? So, yeah, please. No, you cannot abruptly increase the drug dose because, see, when we start the study, please remember, ethical issues are also there. Please, ethical issues are also there. I cannot violate the ethical issues. I'm not supposed to. whatever clinical trial we do, we should do within the framework of ethical, consideration only. You can't violate it. So, in your methodology, what you are supposed to mention, this is where I wish to make you understand. When you write particularly in clinical trials, when you start your study, particularly in case of crossover design, you explain the crossover design, right? As I mentioned, at the end of that, in spite of any subjects not responding to either of the drugs, you analyze the data as it is. That is part of your research. You analyze it as it is, that so much percentage of subjects in group 1 and so much percentage of subjects in group 2 did not respond in spite of the crossover design. That means both the drugs have been used for treating them. In spite of that, if they have not responded, you have to analyze as it is, but you can't wash your hands. Okay, I've taken you for my study, I've done my best, right? But I can't help you out. That's not your responsibility morally. There may be possibility such patients may need some other drug which is outside the purview of your research, but you can't wash your hands. You have to treat them. Mention that. That completes the research and responsibility. Even in clinical trial also, you cannot just wash over your hands saying that, okay, I did my best and these many patients did not respond. You report it that these many patients did not respond or these many patients have partially responded. But being a doctor on a humanitarian basis, you must try to give treatment outside the purview of your research. Mention that in the research protocol. In case if they are not responding until the end of the study, right? You cannot say that, okay, I have done the best of it. You please go to some other doctor and continue the treatment. No, that's not fair.
That should be mentioned in synopsis.
Yes, sir. Better. No, I make people to mention, right? In the case, if some percentage of patients are not responding to any of these drugs within the purview of the clinical trial, they will be taken up separately and treated by us, by any other drug which is suitable for them. Say, for example, let me give you an example. This is what we did in case of homeopathy. I'm also now visiting government homeopathy medical college in Bangalore. We started RCT. Earlier, RCT means homeopathy doctors used to say, no research can be done in RCT. They started initially, when I went there in 2008, my first, visit for teaching was in 2008. They were doing only about 10 to 15 or 20 interesting cases. That was their dissertation. But over a period of time, by now they are conducting RCT, please believe me. They are doing RCT. And they say that in case if the patient is not responding to, they usually believe that, like you have your own Ayurvedic principles, they too have their own homeopathic principles. In spite of that, there are some special remedies they are using. Like, for example, in case of temper tantrum, they use a drug by name chamomilla as a special drug. Suppose for that drug patients are not responding, we made them to report as it is, and outside the purview of this research work, you now assess the patient, reassess the patient, and find out for which drug they can be treated. So therefore, this is really important in clinical trials. Particularly, we have some moral responsibility of relieving the patient from their suffering. That is why we cannot wash our hands. Right? So that means here epidemiology is compared to heart, because you know that if the heart of a person is diseased, either the person is suffering, there is also a possibility the person might die. And Same thing, if a person's spine is injured, the person is going to collapse. In that context, if you are not using appropriate study designs, I'm not going to discuss those epidemiological designs because my focus is only today on statistics. Maybe some other time we'll discuss exclusively on research. Right? That is what sir has told me, that purely statistical concepts I introduce. Here and there I do mention about research methodology, but not in depth. But however, research designs are very, very important, particularly in medical science. Like, for example, we classify like this. It may be an experimental study or it may be an observational study. If it is experimental study, you can go for, sir, are you doing animal experiments here? No, you're not doing animal experiments. Okay, that we'll forget it. Otherwise, it's going to be 2 designs or 3 designs. Yes, sir? Okay, no. Yeah. I keep moving. I'm not going to stand in one place. Oh, okay. Am I not audible to the backside if I speak without mic? Okay. Anyway, so in case of experimental studies, we have 3 designs. Just make a note that we have 3 designs. One is RCT. In case of RCT, the subjects or the patients are allocated randomly. There are random procedures we follow: individual randomization, block randomization, group randomization, right? So these procedures we follow, allocate randomly, mainly to avoid selection bias. Selection bias. We want to avoid selection bias, we go by this method. Suppose for various reasons, I'm not able to randomize the patients, then we adopt the design, what we call it as quasi-experimental design. Yeah. Can I get a pen? Marker? Okay. Oh, thank you. So it is called as quasi-experimental design, where this is based on no randomization. Experimental study, no randomization, based on no randomization. Control is there, right? Replication is there. Replication is there, but without randomization. Particularly in quasi-experimental studies, the subjects are selected based on, very, very important, inclusion and exclusion criteria. That must be made strong. Why? But more so, exclusion criteria. Why? What could be the reason for giving, more importance for exclusion criteria? No, I'm not telling that inclusion criteria is least important. No, we have to prepare inclusion criteria, but in my opinion, exclusion criteria is more important. Okay, I'll give one example. One pharmacy, batch of students, Form D students, had taken up a study on assessing the drug-drug interaction. They use allopathic drugs, right? The drug-drug interaction for treating ischemic heart disease. That means they have 2 allopathic drugs. They wanted to find out what is the kind of interaction between those 2 drugs in case of treating ischemic heart disease. Yes, it was a retrospective case record analysis. 5 years, right? It is in Dayanand Sagar Hospital. They had taken 5 years case records and analyzed it. They had prepared a report. Just incidentally, the guide met me in the corridor and she asked me, "Sir, will you go through it?" I went through the entire report. I found that there was a major flaw in the design. I tell you what. They have mainly focused on
the drugs which are used for treating ischemic heart disease and their interaction. Don't you think if a person is suffering from, say, diabetes, hypertension, chronic kidney disease, or anything of that kind, the drugs used for treating these conditions also will interact with the drugs used for treating ischemic heart disease. Oh, thank you. Ischemic heart disease, yes or no? They are allopathic drugs. Drugs which are used for, I don't know in Ayurveda, allopathic drugs, the drugs used for treating, right, diabetes or kidney disease or hypertension will also interact with the drugs which are used for treating ischemic heart disease. Their main focus is only analyzing the drug-drug interaction between drugs used for treating ischemic heart disease. So I pointed out, you know what? This is what we call it as confounders. In medical research, confounder is a major issue which we need to address it. Confounders. I'll give one more example. Okay, doesn't matter. You're able to hear me, right? Okay. I'll give one more example. Like, for instance, you want to assess the effect of smoking on coronary heart disease. Effect of smoking on coronary heart disease. Who are the people who we are supposed to choose for this study? General question. I'm not asking a very, special question here. Who are the people we are supposed to select it? I want to assess what is the risk associated with causing coronary heart disease. Whom should I choose? Please come out. PGs at least, come out. Who should be chosen for this purpose? It is very simple. Only people who are smokers. Because I'm only looking at the effect of smoking on coronary heart disease. Correct? But what if you ignore that those who are smokers may also take alcohol? If you don't inquire that whether the smoker is also an alcoholic, ignoring, you take the effect of only smoking, don't you think alcohol is also an independent risk factor in causing coronary heart disease? Right? If you don't take the data related to this, then here we say that alcohol is a confounder. Confounder is nothing but the synergistic effect, combined effect of alcohol with smoking. It triggers the speed of occurrence of coronary heart disease in simple words. So meaning, if I were to be the person, I should think only selecting those people who are only smokers. Then I'll be able to assess the actual risk involved in causing coronary heart disease due to smoking alone. So therefore, whatever research we do, the research design is at most important. A proper design has to be selected, taking all these factors into consideration. So please, whenever you're choosing your topic, pay attention for looking for, right, identifying the confounders for whatever the disease that you're choosing, which are those factors which are going to affect on the outcome of the study variable. Fine. Now with this, what about the current? It comes now. Okay. Now, in research, though Rajiv Gandhi University is not asking for specifically, exclusively the research question, yet you must write a research question. You must write a research question for your own understanding the problem properly. Then what is the research question? The research question is focusing on either hypothesis generation or hypothesis testing. Two things are possible. Research question. Either you are generating the hypothesis or you are testing the hypothesis. Let me give you a simple example to make you understand what do you mean by generation of hypothesis and testing of hypothesis. There was an article in New England Journal of Medicine where a team of doctors from Harvard School of Medicine were examining a group of women suffering from endometrial carcinoma. While collecting the history from these women, majority of the women gave the history that they were consuming alcohol for more than 2 times a day. Majority. Now, the question before the team of doctors, does alcohol consumption causes endometrial carcinoma, is research question. I don't know. I don't know whether it causes or not. That is why I am framing the question as, does alcohol consumption causes endometrial carcinoma? When you put it as a question, you're supposed to find an answer to that question, right? Yes or no? That is where I'm saying when you are choosing a research topic, you must compulsorily write a question. Convert that statement, entire problem statement, into a question form. That leads to many openings. One, we talk in terms of PICO. PICO means population, intervention, comparator, and outcome measure. Right? On one side. The other side, we have what is called as fingers. Fingers means feasibility. Very, very important. Is my study feasible? Is this study interesting? Is this a novel idea? Can I generalize the results obtained from this study to the population from where I have selected my study subjects? Ethical considerations. Am I doing this research within the framework of ethical considerations? Is it relevant to the present day situation? And lastly, is my results are scalable, meaning mild, moderate, severe, otherwise, right? Cured, not cured, or partially cured. Those kind of scalings are to be done. Both are important. It is related to research question. Particularly among all these, 5 of them I would like to emphasize: PICO, all the 4 components, population. I must identify from on which population I am specifically looking for. More so is not just the general population, we call it as target population. Target in the sense, like, I'll give you an example. If I'm talking about cancer of cervix, who are my study subjects? Who are my study subjects? Pardon me? No, I'm not able to hear. Just stand up and tell me. Let everybody hear it. Doesn't matter. Make a mistake here. Make a mistake. Patients with cervical cancer. Can you be specific? Middle age. Right? So, no, she's right. She's right. You are supposed to look for only women above the age of 35 years, because generally the prevalence of cancer of cervix in women is seen only after the age of 35 years. That is your target population. You cannot say that I'll choose women population. In a women population, a baby, a girl baby just born is also a part of the women population. Unless it is genetically, designed. Cancer of cervix means genetic factors are not taken into consideration here. We only look at 35 years as a age group for studying about cancer of cervix. What about Alzheimer's disease? Old age. Again, Age factor is also important. Old age means from which age are you going to study? Which is the earliest age where you are observed, isn't it? Earliest age. That needs to be identified, and gender is also a matter of concern. Sometimes I have come across, say, pain. I have, let us say, I have non-specific low back pain. Non-specific low back pain. Let me say that it is a mechanical low back pain. Who are your study subjects? Target population. I've given the condition. I've given the condition. Mechanical low back pain. Whom are you going to consider? Hmm? Only labors? Only labors? What about the age? Age? Don't you think? Isn't it? So that is where you need to be very, very specific about the target population. Correct? Say, for example, you may include truck drivers, you may include software engineers, you may include laborers. What age group? A software engineer of 21 years, would you like to include 21 years old software engineer? The same software engineer profession who is 55 years. Is it possible to compare between 21 years and 55 years person? Pain perception by 55 years person is different from pain perception by 21 years. So this is where I am talking about. This is where I'm talking about. Okay, addressing the specific target population. So you stratify it. Stratify it. Let us say we have in WHO classification elder adult and older adult. Let us say 20 to 40 years, they call them as elder adult. 41 to 60 is called as older adult. They are comparable. Within that age group, they are comparable. So that is what I'm talking about, target population. Very important. Again, intervention, you can decide what kind of intervention you are doing it. Comparator must always be with a gold standard or standard control. You cannot choose new two drugs and compare between them. That's not ideal. One must be a gold standard. You can choose two new drugs and one gold standard. Then, of all that, outcome measures. How are you going to measure your final outcome of the study? That is purely based on statistical measures. I'll come to that later. I'll link it later, but it is purely based on statistical measures. And on the other side, I said about fingers, in that my main focus is only on feasibility. When it comes to feasibility of the study, first and foremost is I look at the financial aspects. Do I have sufficient financial support to carry out my work? Yes, very important. Say, for instance, you are taking diabetes as your study area. Routine investigation is fine, except in government colleges, particularly in private colleges. If it is fasting blood glucose and postprandial blood glucose, they do it regularly in those hospitals. Patient may pay because they have to get otherwise also the investigations done, like blood glucose, fasting and postprandial. For your research purpose, if you are insisting that the patient has to get HbA1c, I'm excluding government colleges, because in government colleges there may be facility of doing this HbA1c. But what about in private colleges? No, they're not doing free of cost. Say for example in Kim's Medical College, we tell postgraduate, since this is out of the routine investigations, you have to bear the cost of that investigation. Now, we had the same problem with the government homeopathy medical college, where for one of the students, X-ray was supposed to get done. Sorry, ultrasound was supposed to be get done in government homeopathy medical college. Ultrasound was that now, even now they have a they have a instrument. Yeah, please. Okay, let me.
Okay. In government homeopathy medical college, they have an instrument, but they don't have a radiologist. Now, the ultrasound scan was essential for that study. What is the way out? They have to go outside and get it done. How much it costs? 400 rupees. So we told the PG, even though you are a government medical college, PG, since facility is not there, if you want to get this done, you have to pay, but get it done from outside. She said, sir, I've spoken with one external radiographer. So they said they'll do it half the price. Whatever is your concern, you get it done free of cost or half the cost or full cost, but it is your responsibility for getting that done. Therefore, financial implication is very important as part of the feasibility of the study. Second most important is study subjects, availability of study subjects, means patients. Whichever the disease that you are choosing, do you get that many number of subjects in the span of your study period? Do you get it? And university is not going to show any consideration if you say that in our we calculated the sample size based upon this procedure, and I got 100 cases as per the calculation, but in my span of study duration, I was able to achieve only 70. So therefore, I'll analyze it only for 70. University will not accept it. If that could have been the case, you should have mentioned before itself that I'll do it only for 70. Now, this has happened many cases. I have certified that for these following reasons, there was an excess calculation of sample size. The actual sample size required based on these criteria was only around 60, 65. Right? By adding an additional 10% dropout rate, the sample size required is only 70. I've signed and given to the university. Only then they accepted. So feasibility is a very, very important component in medical research. In addition to that, third point is ethical considerations that you should not ignore it. Fine? Yeah. Now, we'll move on to the next one. Okay. So, this is the exact research process you are supposed to follow, but I'm not going to discuss all these things. The whole, right? The whole content of research process is this. The whole thing is included. Say, for example, the areas where we concentrate is this PICO.
In this, mainly my focus is on feasibility, others just follow. This is very, very important that I'll discuss in the statistics. Aim and objective, how you are going to write. The study designs, research design or study design. I mentioned about if you are doing an experimental study, those three designs, right? RCT or crossover design, or else the third one is quasi-experimental designs. Survey methodology, it is descriptive studies or observational studies. Only one group, you just observe them. Or else, you may also go for cross-sectional studies, case control study, cohort studies, observational studies. Design is important. Then, so epidemiological and statistical designs are there. Hypothesis. If at all a comparative study is there, you need to test an hypothesis. Then you have to mention what is null hypothesis and what is alternative hypothesis. We'll be having more detailed discussion about these part. This entire part, what I've mentioned here, we are going to have a detailed description, a detailed discussion on that. Got it? Everything. Sample size I'll discuss. Inclusion, exclusion criteria, generally I mentioned. Okay. So this is what we call it as the research process. We need to adopt. Okay. Now I'll move on directly to statistics. So because our focus is mainly on biostatistics, I'll go to that. Here and there, wherever necessary or wherever you want some points to be discussed, you please tell me. I'll definitely take it up for discussion. Okay. Now, what is the role of statistics in research? The role of statistics in research. Why statistics is needed? Then what is statistics? A professor by name Professor Horace Sacrist has given a comprehensive definition of statistics. We just make a note of the definition. Statistics we mean, I missed the slide. Just make a note of it. Statistics we mean aggregate of facts. Statistics we mean aggregate of facts affected to a marked extent. Aggregate of facts affected to a marked extent by multiplicity of causes. Affected to a marked extent by multiplicity of causes, numerically expressed, comma, enumerated or estimated, enumerated or estimated according to reasonable standards of accuracy. According to reasonable standards of accuracy, collected for a predetermined purpose, and placed in relation to each other. This is what exactly we define statistics. Now, let us say I'll ask Yashwant his height. He tells me some number. Sir, I'm 5.8 feet. Fine, that's good. But no statistical method is possible to apply when only his height is taken into consideration. It's not possible at all. Then what I need it is aggregate of facts. I given statistics, we mean aggregate of facts. Aggregate means collective or group of individuals. Data based on group of individuals, if you have it. Facts here to be read as data. So the data collected on a group of individuals is possible to subject it for statistical analysis. Also, suppose at the end of this 1 hour session, I'll give 5 questions to all of you with 1 mark for each question, right? If all of you score 5 out of 5, remember it's a group of individuals, correct? The test given to you on 5 questions, each question carrying 1 mark. Each one of you answer all the questions correctly. That means 5 out of 5 you scored. Once again, no statistical method is possible to apply. Why? It's a group of individuals, right? I said statistics should be applied for a group of individuals, not for a single person data. But this is group of individuals, yet we cannot apply statistical method. Why? The reason is it is all constant. All of you scored out 5 out of 5. There is no variability. That means statistical methods are possible to apply only if there is a variability. Variability means the change. If there is a change, only then you can think about application of statistical methods for analysis. So what is a summary? Statistical methods are not possible to apply for one individual, and also even though it's a group of individuals, if all value remain the same, we cannot apply statistical methods. That means it should be the variability from one individual to another individual. Only then we can apply statistical methods. That is where the first phrase says we mean aggregate of facts, facts to be read as data. The next one tells about affected to a marked extent by multiplicity of causes implies one word, that is variability. That is, whatever the change that is occurring, only in that case statistical methods are applied. And next is all the measurements has to be expressed numerically. Otherwise, once again, statistics is not possible to apply. Numerically, when you express it, then we can subject those data for analysis. The next phrase says estimated or enumerated. Enumeration means complete census, or the whole group is involved in the data collection. Complete enumeration. If I collect the data from the whole group, that is enumeration. If I choose, say, 10 of you, okay, let me say, I've taken the data on height from each one of you. Calculate the mean and standard deviation. Are you getting the point? Height of each one of you is recorded. Mean and standard deviation is computed. That is called as enumeration because it is based on the entire group of individuals, which we call it as population. So when you collect the data based on the population, we call it as enumeration. It's a true value. For the whole group, if I do it, it is a true value. Instead, if I choose 10 students randomly here, same height is measured. Whatever the mean height computed and standard deviation for that 10 student is called as an estimate because it may or may not be same as the true value of the population. So therefore, in research, this point is very, very important. Reason is no research is conducted based on the entire population for the reason that population may be unknown or infinite. Suppose you want to treat patients suffering from, right, bronchitis, allergic bronchitis. That is that the topic you've taken up for your dissertation is a 18 months period duration. Now, can you tell me how many allergic bronchitis cases are coming to this hospital in the next? I'm not talking about the past, retrospective. I'm talking about prospectively from the date you are starting your study. How many allergic bronchitis cases come in the next 18 months? Will you be able to tell me how many are there? That is where we are talking about unknown population. When there is an unknown population, how can I get the data on the entire population? Are you able to understand this basic concept? So, studying about the entire population is completely ruled out. What best we can do is, based upon the feasibility, I can determine how many allergic bronchitis patients are to be studied in my research. Like, I can use the prevalence of allergic bronchitis. I go with this way. If I'm able to get any reference for Bellary, that is the best. Because I should be able to know that if I get a reference for Bellary data, I can confidently say that because it is Bellary, I can get this many cases. If not, look for nearest research data like Hubli, Dharwad studies. I go with, it's a kind of periphery. I'll go with that. Start with the place where you're conducting study. Then you extend to neighboring places. If nowhere available, at least look for Indian data. Now, I have a question. If you look for prevalence of allergic bronchitis, where you're doing the study in Bellary, suppose the data is not available either in Bellary or the whole country, can I use USA data? Or can I use Pakistan data, neighboring country, or Sri Lanka, China, right? Can I use this data? Yes or no? Why? Why? Why can't I use it? They are neighboring countries, right? Still, why can't you use it? Because disease prevalence might vary from one country to another country. It's not just one place. See, political situation in that country and environmental factors in that country is entirely different from Indian context. I would rather say that even within India, it may be difficult to compare the Delhi data with Bangalore data or with the Bellary data. See, Delhi, if you go now, it's full of dust. Allergic bronchitis is one of the cause for dust is one of the cause, right? It's very difficult to compare. That is why I insist in that situation where we are not getting a proper data for calculation of sample size. I quote our hospital data. Take your hospital data. If you're not getting the hospital data, you conduct 1 month pilot study. Hello, ma'am. 1 month pilot study. That pilot study data can be made use. Right? In 1 month, how many cases have been treated? In that number of cases, how many allergic bronchitis cases are treated? You have the numerator in the form of number of allergic bronchitis, denominator total number of cases treated. You calculate the proportion. Go ahead with the calculation of sample size. Don't you think it's a feasible situation? Because you're using your own data for calculation of sample size. Quote the reference. Since this is the prevalence in the general population, right, which is not feasible for this situation, therefore, the sample size is calculated based upon hospital data of Bellary Hospital, or whichever the name that you're mentioning. Got it? So that is where whatever calculations we are doing based upon the sample, we are using it for generalizing it to the entire population. That is the meaning of enumerated or estimated according to reasonable standards of accuracy. Very, very important. I would like to write this within the quote. Reason. If you're not able to measure the data to a estimated or desired accuracy, what you are intended to prove may prove otherwise. I'll give an example later. Now, madam has come. I'll stop it here. We'll continue our discussion later. Thank you. Sir, namaste, sir. Madam, namaste. I have spoken to her over the phone. Sure, sir. Sure, sir.
And practices by his teachings. So now I would like to request our today's chief guest, Dr. Gangaboraya sir, Professor Emeritus and Research Head, Dayanand Sagar College of Dental Sciences, Bangalore, to come on the today's stage. I request our beloved principal, Dr. Syed Akhtar Fatima ma'am, to come on stage. Ma'am, as a principal, is a visionary leader of our academic institution, embodies excellence, integrity, and dedication to the pursuits of knowledge. I request Dr. Madhav Tigavi sir, Professor and HOD Department of Research Methodology and Biostatistics. As a research guide, sir provides invaluable support and guidance to students embarking on their research journey. I request Dr. Rajashekar S. Ganigar sir, Professor and HOD Department of PG Studies in Dravyaguna, who plays a pivotal role in fostering an environment of care, support, guidance for students. Now, I would like to request Dr. Shivalingappa J. Arakiri sir,
Professor and HOD Department of PG Studies in Shalyatantra, to welcome our today's dignitaries by offering flower bouquet.
ಎಲ್ರಿಗೂ ನಮಸ್ಕಾರ. ತಾರನಾಥ್ ಸರ್ಕಾರಿ ಆಯುರ್ವೇದ ಮಹಾವಿದ್ಯಾಲಯ ಬಳ್ಳಾರಿ ಪರ್ಯವೇಕ್ಷಣ 2024ರ ಈ ಸುಂದರ ಸಮಾರಂಭಕ್ಕೆ ಮುಖ್ಯ ಅತಿಥಿಗಳಾಗಿ ಆಗಮಿಸಿದಂತ ಡಾಕ್ಟರ್ ಗಂಗಾಬೋರಯ್ಯ ಸರ್, ನಾವು ವಿದ್ಯಾರ್ಥಿಗಳಾಗಿದ್ದಾಗ ಸರ್ ಬಗ್ಗೆ ಬೆಂಗಳೂರಲ್ಲಿ ಕೇಳಿದ್ವಿ. ಇವತ್ತು ತಮ್ಮನ್ನು ನೋಡುವಂತಹ ಸೌಭಾಗ್ಯ ನಮಗೆ ಸಿಕ್ಕಿದೆ. ತಮ್ಮ ಬಿಡುವಿಲ್ಲದ ಸಮಯದಲ್ಲೂ ಕೂಡ ನಮ್ಮ ಮಹಾವಿದ್ಯಾಲಯಕ್ಕೆ ತಾವು ಆಗಮಿಸಿದ್ದು ನಮ್ಮೆಲ್ಲರ ಹರ್ಷಚಿತ್ತವನ್ನ ಬಹಳ ಒಂದು ಕೌತುಕವಾಗಿ ತಮ್ಮನ್ನ ಕಾಯುವಂತೆ ಮಾಡಿದ್ದು. ತುಂಬಾ ಧನ್ಯವಾದಗಳು, ನಮಸ್ಕಾರಗಳು ಸರ್. ಪ್ರಪ್ರಥಮವಾಗಿ ನಮ್ಮ ಮಹಾವಿದ್ಯಾಲಯದ ಚೈತನ್ಯದ ಚಿಲುಮೆ ಹಾಗೂ ಸದಾ ನಮ್ಮ ಕಾರ್ಯಕ್ರಮಗಳಿಗೆ ಸದಾ ಸ್ಫೂರ್ತಿಯನ್ನು ತುಂಬುವಂತಹ ಮತ್ತು ಸದಾಕಾಲ ನಮ್ಮೆಲ್ಲರ ಕಾರ್ಯಕ್ರಮಗಳಿಗೆ ಬೆನ್ನೆಲುಬಾಗಿ ನಿಂತು ನಮ್ಮೆಲ್ಲರನ್ನ ಪ್ರೋತ್ಸಾಹಿಸಿ ಮುನ್ನಡೆಸುತ್ತಿರುವಂತಹ ನಮ್ಮ ಮಹಾವಿದ್ಯಾಲಯದ ಪ್ರಾಚಾರ್ಯರಾದಂತಹ ಡಾಕ್ಟರ್ ಸೈಯದ್ ಅಖ್ತರ್ ಫಾತಿಮಾ ಮೇಡಮ್ ಅವರಿಗೆ ಈ ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ನಮ್ಮೆಲ್ಲರ ಪರವಾಗಿ ತುಂಬ ಹೃದಯದಿಂದ ಸ್ವಾಗತಿಸ್ತೇನೆ. ಮಹಾವಿದ್ಯಾಲಯದ ರಸಶಾಸ್ತ್ರ ಮತ್ತು ಭೈಷಜ್ಯ ಕಲ್ಪನಾ ವಿಭಾಗದ ಸ್ನಾತಕೋತ್ತರ ವಿಭಾಗದ ಮುಖ್ಯಸ್ಥರಾದಂತಹ ಡಾಕ್ಟರ್ ರವಿ ಚವ್ಹಾಣ್ ಸರ್ ಅವರು ಗೌರವ ಪುಷ್ಪವನ್ನು ನೀಡುವುದರೊಂದಿಗೆ ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ಸ್ವಾಗತಿಸಿದ್ದಾರೆ. ಕಾರ್ಯಕ್ರಮದ ಕೇಂದ್ರ ಬಿಂದು ಡಾಕ್ಟರ್ ಗಂಗಾಬೋರಯ್ಯ ಸರ್. ವಿದ್ಯಾರ್ಥಿಗಳಿದ್ದಾಗ ಭಯದಿಂದ ಅವರ ಹೆಸರನ್ನ ನಾವು ಕೇಳ್ತಾ ಇದ್ವಿ. ಇವತ್ತು ಸಂತೋಷದಿಂದ ನಾವು ತಮ್ಮನ್ನ ನೋಡುವಂತಹ ಸೌಭಾಗ್ಯ ಸಿಕ್ಕಿದೆ ಸರ್. ಗಂಗಾಬೋರಯ್ಯ ಸರ್ ಸ್ಟ್ಯಾಟಿಸ್ಟಿಕಲ್ಲಿ ಅಪಾರವಾದಂತಹ ಜ್ಞಾನ ಮತ್ತು ಅವರ ಒಂದು ಅನುಭವವನ್ನು ಹೊಂದಿದಂತವರು. ನಮ್ಮ ಮಹಾವಿದ್ಯಾಲಯದ ಸೌಭಾಗ್ಯ ಇವತ್ತು ತಾವು ನಮ್ಮೊಂದಿಗಿದ್ದೀರಿ. ಈ ಒಂದು ಪೂರ್ಣ ದಿನದ ಕಾಲ ತಮ್ಮ ಒಂದು ಜ್ಞಾನವನ್ನ ನಮಗೆ ಮತ್ತು ನಮ್ಮ ಮಕ್ಕಳಿಗೆ ಕೊಡಮಾಡ್ಲಿದ್ದೀರಿ. ಈ ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ತಾವು ಆಗಮಿಸಿದ್ದಕ್ಕಾಗಿ ಮಹಾವಿದ್ಯಾಲಯದ ಎಲ್ಲ ತಾರನಾಥ್ ಬಳಗದ ಪರವಾಗಿ ತಮ್ಮನ್ನ ಅತ್ಯಂತ ಹೃತ್ಪೂರ್ವಕವಾಗಿ ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ಸ್ವಾಗತಿಸುತ್ತೇನೆ ಸರ್. ಡಾಕ್ಟರ್ ಸಂಪತ್ ಕುಮಾರ್ ಸರ್, ದ್ರವ್ಯ ಗುಣ ವಿಭಾಗದ ಪ್ರಾಧ್ಯಾಪಕರಾದಂತಹ ಡಾಕ್ಟರ್ ಸಂಪತ್ ಕುಮಾರ್ ಸರ್ ಅವರು ಗೌರವ ಪುಷ್ಪಗಳನ್ನ ನೀಡುವುದರೊಂದಿಗೆ ಡಾಕ್ಟರ್ ಗಂಗಾಬೋರಯ್ಯ ಸರ್ ಅವರನ್ನ ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ಸ್ವಾಗತಿಸಬೇಕಂತ ಕೋರ್ತೇನೆ. ಮಹಾವಿದ್ಯಾಲಯದ ಸರ್ವತೋಮುಖ ಅಭಿವೃದ್ಧಿಗೆ ಸದಾ ಪೂರಕವಾಗಿ ನಿಂತು ಈ ಮಹಾವಿದ್ಯಾಲಯ ಇಂದು ರಾಷ್ಟ್ರ ಮಟ್ಟದಲ್ಲಿ ಹೆಸರು ಮಾಡುವಂತೆ ಏನು ತಮ್ಮ ಅಪಾರವಾದಂತಹ ಶ್ರಮವನ್ನು ನೀಡಿ ನಮ್ಮೆಲ್ಲರಿಗೆ ಮಾರ್ಗದರ್ಶನ ಮಾಡ್ತಾ ಎಲ್ಲ ಒಂದು ಕಾರ್ಯಕ್ರಮಗಳಿಗೆ ಸದಾ ನಮ್ಗೆಲ್ಲರಿಗೂ ಸ್ಫೂರ್ತಿಯನ್ನು ತುಂಬುವಂತ ತಮ್ಮ ಎಲ್ಲ ಅನುಭವ, ರಾಜಕೀಯ, ಶೈಕ್ಷಣಿಕ ಮತ್ತು ಪ್ರತಿಯೊಂದು ಅನುಭವವನ್ನ ನಮ್ಮ ಮಹಾವಿದ್ಯಾಲಯಕ್ಕೆ ಮಾತ್ರ ಸೀಮಿತ ಇಟ್ಟು ಈ ದಿನಗಳಲ್ಲಿ ನಮ್ಮ ಮಹಾವಿದ್ಯಾಲಯ ಇಷ್ಟೊಂದು ಉತ್ಕೃಷ್ಟ ಮಟ್ಟದಲ್ಲಿ ಬೆಳೆಯುವಂತೆ ತಮ್ಮ ಪೂರ್ಣ ಸಹಕಾರ ಮತ್ತು ಶ್ರಮವನ್ನು ನೀಡಿ ನಮ್ಮೆಲ್ಲರ ಮಧ್ಯದಲ್ಲಿರುವಂತಹ ನಮ್ಮ ನೆಚ್ಚಿನ ಗುರುಗಳಾದಂತಹ ಡಾಕ್ಟರ್ ರಾಜಶೇಖರ್ ಗಾಣಿಗೇರ್ ಸರ್ ಅವರನ್ನ ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ತುಂಬು ಹೃದಯದಿಂದ ಆಹ್ವಾನಿಸ್ತೇನೆ. ಡಾಕ್ಟರ್ ದೊಡ್ಡಬಸಯ್ಯ ಸರ್ ಪ್ರಾಧ್ಯಾಪಕರು, ಪಂಚಕರ್ಮ ವಿಭಾಗ, ಇವರು ಪುಷ್ಪವನ್ನು ನೀಡುವುದರೊಂದಿಗೆ ಡಾಕ್ಟರ್ ರಾಜಶೇಖರ್ ಗಾಣಿಗೇರ್ ಸರ್ ಅವರನ್ನ ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ಸ್ವಾಗತಿಸಬೇಕಂತ ಕೋರ್ತೇನೆ. ಮಹಾವಿದ್ಯಾಲಯದ ಕಾಯ ಚಿಕಿತ್ಸಾ ವಿಭಾಗದ ಸ್ನಾತಕೋತ್ತರ ವಿಭಾಗದ ಮುಖ್ಯಸ್ಥರು ಹಾಗೂ ವಿಶೇಷವಾಗಿ ಬಯೋಸ್ಟಾಟಿಕ್ಸ್ ಮತ್ತು ರಿಸರ್ಚ್ ವಿಭಾಗವನ್ನು ಕೂಡ ತಮ್ಮ ಒಂದು ಈ ಉಳಿದ ರೆಸ್ಪಾನ್ಸಿಬಿಲಿಟಿ ಒಂದಿಗೆ ತಮ್ಮ ಆ ಒಂದು ಜವಾಬ್ದಾರಿಯನ್ನು ಕೂಡ ಹೊತ್ತುಕೊಂಡು ಮಹಾವಿದ್ಯಾಲಯದ ರಿಸರ್ಚ್ ಮತ್ತು ಸ್ಟ್ಯಾಟ್ ವಿಭಾಗದಲ್ಲಿ ತಮ್ಮ ವಿಶೇಷವಾದಂತಹ ಕೊಡುಗೆಯನ್ನು ನೀಡ್ತಾ ಬಂದಿರುವಂತಹ ಈ ಕಾರ್ಯಕ್ರಮದ ಆರ್ಗನೈಸಿಂಗ್ ಸೆಕ್ರೆಟರಿ ಆಗಿರುವಂತಹ ಡಾಕ್ಟರ್ ಮಾಧವ್ ದಿಗ್ಗಾವಿ ಸರ್, ನನ್ನ ಗುರುಗಳು. ಈ ದಿನ ಅವರಿಗೆ ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ವಿಶೇಷವಾಗಿ ನಾನೇ ಪುಷ್ಪವನ್ನು ನೀಡುವುದರೊಂದಿಗೆ ಸ್ವಾಗತಿಸ್ತೇನೆ. ಕಾರ್ಯಕ್ರಮದಲ್ಲಿ ಉಪಸ್ಥಿತರಿರುವಂತಹ ಎಲ್ಲ ಮಹಾವಿದ್ಯಾಲಯದ ಎಲ್ಲ ಬೋಧಕ ಸಿಬ್ಬಂದಿಗಳು ಹಾಗೂ ವಿಶೇಷವಾಗಿ ಸ್ನಾತಕೋತ್ತರ ವಿದ್ಯಾರ್ಥಿಗಳು ಮತ್ತು ಅಂತಿಮ ಹಂತದ ಪದವಿ ವಿದ್ಯಾರ್ಥಿಗಳಿಗೆ ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ತುಂಬ ಹೃದಯದಿಂದ ಸ್ವಾಗತಿಸ್ತೇನೆ. ದಯವಿಟ್ಟು ಯಾರು ಪ್ರಾಂಗಣದಿಂದ ಹೊರಗಡೆ ಹೋಗದೆ ಕಂಪ್ಲೀಟ್ ಮುಗಿಯುವವರೆಗೂ ಕೂಡ ಎಲ್ಲ ತಮ್ಮ ಉಪಸ್ಥಿತಿಯನ್ನ ಈ ಸಂದರ್ಭದಲ್ಲಿ ನಾನು ನಿರೀಕ್ಷೆ ಮಾಡ್ತಾ ಕಾರ್ಯಕ್ರಮವನ್ನ ಮುಂದುವರಿಸಲು ಡಾಕ್ಟರ್ ಅಂಜಲಿ ಅವರಿಗೆ ಕೋರ್ತೇನೆ. ಧನ್ಯವಾದಗಳು.
Thank you, sir. Before we commence our session, it's time to connect our spirits with higher power to seek blessings, guidance, and wisdom. Now, I would like to call upon Dr. Santoshi and Dr. Soumya, first year PG scholars, Panchakarma department, for Dhanvantari Stavana. I request everyone to stand up for Dhanvantari Stavana.
नमामि धन्वन्तरिम् आदिदेवं सुरासुरैर्वन्दितपादपद्मम् लोके जरारुभयं मृत्युनाशम् धातारमीशं विविधौषधीनाम् धन्वन्तरिं रमानाथम् सर्वरोगनिवारकम् आयुर्वेदप्रवक्तारम् वन्दे पीयूषदायकम्। सर्वे जनाः सुखिनो भवन्तु, सर्वे सन्तु निरामया, सर्वे भद्राणि पश्यन्तु, मा कश्चित् दुःखभाग् भवेत्। ॐ शान्ति शान्ति शान्तिः।
Thank you, Dr. Santoshi and Dr. Soumya. We are about to commence our event by lighting the lamp of knowledge and wisdom. I request all the dignitaries to light the lamp to inaugurate today's program.
I've done it. Yes, please.
शुभं करोति कल्याणं आरोग्यं धनसंपदा शत्रु बुद्धि विनाशाय दीपज्योति नमोस्तुते। Now, I request Dr. Madhav Diggavi sir, Professor and HOD Department of Research Methodology and Biostatistics for keynote address.
Om Shri Dhanvantari Namaha. With salutation to the lotus feet of Lord Dhanvantari and Pandit Taranath ji, most respected our beloved principal, Dr. Sayyida Attal Fatima madam, Dr. Ganga Boraya sir, the honorable resource person of the day, Dr. Rashekar Gangir, my friend and head of the Department of PG Studies in Dragagna, all the teaching faculty members, postgraduates and undergraduates. Without taking much of the time, every year new postgraduates enter the field of research in Ayurveda. and they need some sort of samskara to enter into the research field. With respect to their departmental specialities, they will conduct research based on the synopsis presented to university. So for that purpose, basically, understanding the biostatistics and its application in Ayurvedic research is needed. For that purpose, we organize under our able guidance of our principal ma'am, we have found out Pariyeshana, one of the terminology in Ayurveda, which says that Pariyeshana, searching in entirety for finding the truth. With that caption, we are conducting Pariyeshana workshops, and this year we are fortunate enough to have a new thought was in our mind that one resource person given sufficient time for entire day so that communication is possible. Usually we group resource persons, 4 or 5 resource person in a day, each will get 1 hour time, and sometimes we found that in 1 hour they are unable to communicate in depth to the audience and delegates. So we found that one day biostatistics seminar we have planned. So when we requested our Gangaburaya sir, he has his own commitments in entire week, but he has accepted to come to our institute and deliver a lecture on biostatistics. And another issue what we found is many of other delegates can also come and participate in this. To make them convenient, we have made YouTube online participation is also possible by technology. And I'm thankful to all the PG scholars who have made day and night efforts to make everything mainstream. Without taking much of the time, I conclude my keynote that make use of it. It may you may be thinking that it is entirely a new field, but I was one of the student or participant in research methodology training program at RGHS Bengaluru way long back in 2005-06. When Gangaburaya sir has given a guest lecture, it was very impressive. Anybody can understand from any field. Because of his experience, he makes the issues very easy and understandable with examples. So make use of it, and this will be a lifetime learning for you, for your PG academic activity as well as examination or your research work. In all way, it will be helpful. So make use of it and learn as much as possible, and be both directional. Ask questions whenever you find. Sir is very kind-hearted. If you ask questions, sir will be very happy. Even up to 10 p.m. Sir is available with you. After completion at 5 o'clock also, you can have discussion. And see that you will develop your research curriculum very well. In Ayurveda, what we needed is, research is needed in Ayurveda. But not only research is needed, it's data analysis, data gathering, and data publication is science actually. So use of biostatistics make your science more scientific, more appealable to scientific community. So for that purpose, learning statistics basics and application into our research is very useful. So all of us will learn from the learned resource person and make use of it. And this is a formal inaugural function wherein we will have this session as early as possible, and then we'll continue our ongoing sessions as usual. Thank you all for giving me an opportunity for say a few words. Thank you, Ananda.
Thank you, sir. Now I request Dr. Rajashekar S. Ganiger, sir, Professor and HOD Department of PG Studies in Dravyaguna, for guest of honor.
ಈ ಕಾರ್ಯಾಗಾರದ ಅಧ್ಯಕ್ಷತೆಯನ್ನು ವಹಿಸಿರುವಂತಹ ಮಹಾವಿದ್ಯಾಲಯದ ಮಾನ್ಯ ಪ್ರಾಚಾರ್ಯರು ಮತ್ತು ನಮಗೆಲ್ಲರಿಗೂ ಕೂಡ ಮಾರ್ಗದರ್ಶನವನ್ನ ಮಾಡ್ತಾ ಇರ್ತಕ್ಕಂಥ ಡಾಕ್ಟರ್ ಸೈದಾತ್ ಫಾತಿಮಾ ಮೇಡಮ್ ಅವರೇ, ನನಗೆ ಇವತ್ತು ಇಷ್ಟೊಂದು ಸಂತೋಷ ಆಗಿದೆ ಅಂದ್ರೆ, ನಾನು ಬೆಂಗಳೂರು ಮಹಾವಿದ್ಯಾಲಯದಲ್ಲಿ, ನಮ್ಮ ಸರ್ಕಾರಿ ಮಹಾವಿದ್ಯಾಲಯದಲ್ಲಿ PG ಮಾಡುವಂತ ಸಂದರ್ಭದಲ್ಲಿ ನಮ್ಮ ಜಯಶ್ರೀ ಮೇಡಮ್ ಅವರು ಸಾಕಷ್ಟು ಸಾರಿ ಗಂಗಾಬೋರಯ್ಯ ಸರ್ ಅವರ ಹೆಸರು ಇಡ್ತಾ ಇದ್ರು. ಸ್ಟಾಟಿಸ್ಟಿಕ್ಸ್ ಅಂತ ಬಂತಂದ್ರೆ ಬೆಂಗಳೂರಲ್ಲಿ ಯಾವುದೇ ಕಾಲೇಜ್ಗಳು ಇರ್ಬೋದು, ಅದು ಆಯುರ್ವೇದ ಇರ್ಬೋದು, ಹೋಮಿಯೋಪತಿ ಇರ್ಬೋದು, ನರ್ಸಿಂಗ್ ಇರ್ಬೋದು, ಯಾವುದೇ ಕಾಲೇಜ್ ಬಂದ್ರು ಡೆಂಟಲ್ ಇರ್ಬೋದು, ಬಂದ್ರೆ ಫಸ್ಟ್ ಹೆಸರು ಬರುವಂತದ್ದು ಡಾಕ್ಟರ್ ಗಂಗಾ ಬೋರಯ್ಯನವರು. ಯಾಕೆ ಕೇಳಿಸ್ತಿಲ್ವಾ? ಅಲ್ಲಿ ಬರೋಲ್ವಾ? ಹೆಂಗ್ ನಿಂತ್ರೆ ಸರ್ ನಗು ಕಾಮೆಂಟ್ ಮಾಡಿದಾಗ ಅದು ಬರುತ್ತೆ ನೋಡೋದ್ರೆ ನಾವು ಕೇಳ್ತಾ ಇದ್ವಿ. ನಿಜವಾಗ್ಲೂ ಇವತ್ತು ನಾನು ಡಾಕ್ಟರ್ ಮಾಧವ್ ದಿಗ್ಗಾವಿರ್ ಅವರಿಗೆ ಅತ್ಯಂತ ತುಂಬ ಹೃದಯದ ಅಭಿನಂದನೆಗಳನ್ನ ಹೇಳೋದಕ್ಕೆ ಇಷ್ಟಪಡ್ತೀನಿ. ಅವರು ಡಾಕ್ಟರ್ ಗಂಗಾ ಬೋರಯ್ಯ ಸರ್ ಅವರನ್ನ ನಮ್ಮ ಮಹಾವಿದ್ಯಾಲಯಕ್ಕೆ ಕರೆಸಿ ಅವರ ಒಂದು ಜ್ಞಾನದ ಒಂದು ದೀವಿಗೆಯನ್ನ ನಮ್ಮ ವಿದ್ಯಾರ್ಥಿಗಳಿಗೆ ಮುಟ್ಟಿಸುವಂತ ಒಂದು ಕೆಲಸವನ್ನು ಮಾಡಿದ್ದಕ್ಕೆ ಮಹಾವಿದ್ಯಾಲಯದ ಪರವಾಗಿ ನಾನು ಡಾಕ್ಟರ್ ಮಾಧವ್ ದಿಗ್ಗಾವಿರ್ ಅವರಿಗೆ ತುಂಬ ಹೃದಯದ ಧನ್ಯವಾದಗಳನ್ನ ಅರ್ಪಿಸ್ತೇನೆ. ಸಾಮಾನ್ಯ ಗಂಗಾ ಬೋರಯ್ಯ ಸರ್ ಅವರು ಕೇವಲ ಒಬ್ಬ ವ್ಯಕ್ತಿ ಅಲ್ಲ, ಅವರು ಅದೊಂದು ದೊಡ್ಡ ಒಂದು ವಿಶ್ವವಿದ್ಯಾಲಯ ಇದ್ದಂಗೆ. ಗಂಗಾ ಬೋರಯ್ಯ ಸರ್ ಅಂದ್ರೆ ಒಂದು ವಿಶ್ವವಿದ್ಯಾಲಯ ಇದ್ದಂಗೆ ಬಯೋಸ್ಟಾಟಿಸ್ಟಿಕ್ಸ್ ವಿಷಯಕ್ಕೆ ಸಂಬಂಧಪಟ್ಟಂತೆ ಅಷ್ಟೊಂದು ಅಥೆಂಟಿಕ್ ಆಗಿ ವಿಷಯಗಳನ್ನ ಮಂಡನೆ ಮಾಡ್ತಕ್ಕಂಥವ್ರು. ಮತ್ತು ಅವರ ಒಂದು ಪ್ರಬುದ್ಧವಾಗಿರ್ತಕ್ಕಂಥ ಬೋಧನೆಗಳು ಏನಿರ್ತದಲ್ಲ ಅದು ಕೇವಲ ಒನ್ ಸೈಡೆಡ್ ಇರೋದಿಲ್ಲ, ಅದು ಎರಡು ಸೈಡ್ ಅಂದ್ರೆ ವಿದ್ಯಾರ್ಥಿಗಳಿಂದ ಪ್ರಶ್ನೆಗಳನ್ನು ಕೇಳುವಂತದ್ದು, ಅದಕ್ಕೆ ಪರಿಹಾರವನ್ನು ಸೂಚಿಸ್ತಕ್ಕಂಥದ್ದು. ಎರಡು ವಿಚಾರಗಳು ಡಾಕ್ಟರ್ ಗಂಗಾ ಬೋರಯ್ಯ ಸರ್ ಅವರ ಒಂದು ಪ್ರಬುದ್ಧವಾಗಿರ್ತಕ್ಕಂಥ ಮಂಡನೆಗಳಲ್ಲಿ ಇರ್ತದೆ. ಅದರ ಒಂದು ಪ್ರಯೋಜನವನ್ನ ನಮ್ಮ ವಿದ್ಯಾರ್ಥಿಗಳು ಪಡ್ಕೋಬೇಕು ಅನ್ನುವಂಥದ್ದು ನಮ್ಮೆಲ್ಲರ ಅಭಿಲಾಷೆ. ಹಾಗೇನೆ ಪ್ರತಿ ವರ್ಷನೂ ಕೂಡ ನಾವು ಈ ಕಾರ್ಯಕ್ರಮವನ್ನು ಮಾಡ್ಕೊಂಡ್ ಬಂದಿದ್ದೀವಿ. ಅದರಲ್ಲೂ ವಿಶೇಷವಾಗಿ ನಾನು ವಿದ್ಯಾರ್ಥಿ ಆದಂತ ಸಂದರ್ಭದಲ್ಲಿ ನಾವು ನೋಡ್ತಾ ಇದ್ದಂತ ಪ್ರಬಂಧಗಳು, ನಮ್ಮ ಏನು ಡೆಸರ್ಟೇಷನ್ ಗಳನ್ನ ಮಾಡ್ತೀವಲ್ಲ, ಅವು ಅಷ್ಟೊಂದು ಗುಣಮಟ್ಟದಿಂದ ಕೂಡಿರ್ತಾ ಇರಲಿಲ್ಲ. ಅದು ನನಗೆ ಯಾವಾಗ ಗಮನಕ್ಕೆ ಬಂತಂದ್ರೆ, ನಾನು 2 ಟೆನ್ಯೂರ್ ಸೆನೆಟ್ ಮೆಂಬರ್ ಆದಂತ ಸಂದರ್ಭದಲ್ಲಿ ನಾವು ಬೇರೆ ಬೇರೆ ವಿಷಯಗಳಿಗೆ ಸಭೆಗಳಲ್ಲಿ ಸೇರಿದಾಗ ನಮ್ಮ ವಿದ್ಯಾರ್ಥಿಗಳು ಮಂಡಿಸ್ತಕ್ಕಂಥ ವಿಷಯಗಳಾಗಿರ್ಬೋದು, ಅಥವಾ ಅವರು ಆಯ್ಕೆ ಮಾಡ್ಕೊಳ್ತಕ್ಕಂಥ ವಿಷಯಗಳಾಗಿರ್ಬೋದು, ಅಥವಾ ಆಯ್ಕೆ ಮಾಡ್ಕೊಂಡಂತ ಸಂದರ್ಭದಲ್ಲಿ ಡೇಟಾ ಅಂತ ಏನು ನಾವು ಕಲೆಕ್ಟ್ ಮಾಡ್ತೀವಿ, ಡೇಟಾ ಸ್ಟ್ಯಾಟಿಸ್ಟಿಕ್ಸ್ ಮತ್ತು ಅದರಲ್ಲಿ ಬರ್ತಕ್ಕಂಥದ್ದು ಸ್ಟ್ಯಾಂಡರ್ಡ್ ಡಿವಿಯೇಷನ್, ಸಿಗ್ನಿಫಿಕೆನ್ಸ್, ಇನ್ಸಿಗ್ನಿಫಿಕೆಂಟ್ ಸಾಕಷ್ಟು ವಿಷಯಗಳು ಬರ್ತದೆ. ನಮ್ಮ ಹತ್ರ ಆ ಪ್ರಬಂಧಗಳಲ್ಲಿ ಅವ್ದು ಇರ್ತಾನೆ ಇರಲಿಲ್ಲ. ಸಿಗ್ನಿಫಿಕೆನ್ಸ್, ನಾನ್ ಸಿಗ್ನಿಫಿಕೆನ್ಸ್ ಅನ್ನೋದೇ ಇರ್ತಾ ಇರಲಿಲ್ಲ. ಅದು ಮೈಲ್ಡ್ ಮಾಡರೇಟ್ ಮಾಡಿ 100%, 20%, 30%, 100 ಇತ್ತು, 50 ಆಯ್ತು, 40 ಆಯ್ತು, 30 ಆಯ್ತು, ಗುಡ್ ರಿಸಲ್ಟ್ ಅಂತ ಕೊಟ್ಬಿಡ್ತಾ ಇದ್ರು. ಅದನ್ನ ಬೇರೆ ಒಬ್ಬ ತಜ್ಞರಿಗೆ ತೋರಿಸ್ತಾರೆ, ಗಂಗಾ ಬೋರಯ್ಯ ಸರ್ ಅಂತ ತೋರಿಸಿದಾಗ ಅವ್ರು ಇದೇನು ಈ ತರ ಇದು ಪ್ರೆಸೆಂಟೇಷನ್ ಇಲ್ಲ ಅನ್ನುವಂತ ಪರಿಸ್ಥಿತಿ. ಸೊ ಆದ್ರಿಂದ ನಮ್ಮ ಪ್ರಬಂಧಗಳು ಮತ್ತು ನಮ್ಮ ಆಯುರ್ವೇದದಲ್ಲಿ ಮಂಡನೆ ಆಗಿರ್ತಕ್ಕಂಥ ಪ್ರಬಂಧಗಳು ಒಂದು ಉತ್ಕೃಷ್ಟ ಮಟ್ಟದ, ರಾಜ್ಯ ಮಟ್ಟದ, ರಾಷ್ಟ್ರ ಮಟ್ಟದ, ಅಂತಾರಾಷ್ಟ್ರೀಯ ಮಟ್ಟದ ಒಂದು ಮಾನ್ಯತೆ ಪಡಿಬೇಕಾದ್ರೆ ಅದರಲ್ಲಿ ಇರ್ತಕ್ಕಂಥ ಸ್ಟ್ಯಾಟಿಸ್ಟಿಕ್ಸ್ ಅನ್ನುವಂಥದ್ದು ಏನಿದೆ ಅದು ಸಾಕಷ್ಟು ಮಹತ್ವವನ್ನು ಪಡ್ಕೊಳ್ತದೆ. ಆ ವಿಷಯಗಳನ್ನು ನಾವು ಇದರಲ್ಲಿ ನಮ್ಮ ಪ್ರಬಂಧಗಳಲ್ಲಿ ಸರಿಯಾದ ರೀತಿಯಲ್ಲಿ, ಸಮ್ಯಕ್ ರೀತಿಯಲ್ಲಿ ನಾವು ಅದರಲ್ಲಿ ನಾವು ಮಂಡನೆಯನ್ನು ಮಾಡಿದಾಗ ಆ ಒಂದು ಪ್ರಬಂಧಕ್ಕೆ ಒಂದು ಮನ್ನಣೆ ಸಿಗೋದಕ್ಕೆ ಸಾಧ್ಯ ಆಗ್ತದೆ. ಆ ಹಿನ್ನೆಲೆಯಲ್ಲಿ ನಾವು ಬರುವಂತದ್ದು ಈ ದಿವಸಗಳಲ್ಲಿ ಮತ್ತು ಈ ಕಳೆದ ಒಂದು 3-4 ವರ್ಷಗಳಲ್ಲಿ ನಾವು ಬೇರೆ ಬೇರೆ ತಜ್ಞರನ್ನ ಅಥವಾ ಇತರ ಸಂಪನ್ಮೂಲ ವ್ಯಕ್ತಿಗಳನ್ನ ನಮ್ಮ ಸಾಕಷ್ಟು ಆರ್ಥಿಕ ಹೊರೆ ಸರ್ಕಾರದ ಮೇಲೆ ಆದ್ರೂ ಕೂಡ ನಾವು ವಿದ್ಯಾರ್ಥಿಗಳ ಮೇಲೆ ಆ ಹೊರೆಯನ್ನು ಹಾಕೋದ್ರ ಮುಖಾಂತರ ನಾವು ಇಲ್ಲ ಒಂದು ಸಂಪನ್ಮೂಲ ವ್ಯಕ್ತಿಗಳನ್ನ ಈ ಮಹಾವಿದ್ಯಾಲಯಕ್ಕೆ ಕರೆಸಿ ಈ ಒಂದು ಬೋಧನೆಯನ್ನ ಮಾಡ್ತಕ್ಕಂಥ ಕೆಲಸವನ್ನು ಮಾಡ್ತೀವಿ. ದಯವಿಟ್ಟು ನನ್ನ ಒಂದು ಮನವಿ ಏನಂದ್ರೆ, ಈ ಒಂದು ಕಾರ್ಯಾಗಾರದ ಲಾಭವನ್ನ ನಮ್ಮ ವಿದ್ಯಾರ್ಥಿಗಳು ಮತ್ತು ನಾವೆಲ್ಲರೂ ಕೂಡ, ನಾವು ಅಧ್ಯಾಪಕರಾದಿಯಾಗಿ ನಾವೆಲ್ಲರೂ ಏನಿದೀವಿ, ನಾವೆಲ್ಲರೂ ಕೂಡ ಪಡೆದುಕೊಳ್ತಕ್ಕಂಥ ಪ್ರಯತ್ನವನ್ನ ಮಾಡೋಣ ಅನ್ನುವಂತ ಮಾತನ್ನ ಹೇಳ್ತಾ, ಮತ್ತು ನಮಗೆ ಹೆಚ್ಚು ಸಮಯ ನನಗೆ ಮತ್ತು ಮೇಡಮ್ಗೆ ಇಲ್ಲಿ ಕೊಡೋದಕ್ಕೆ ಆಗೋದಿಲ್ಲ. ಯಾಕಂದ್ರೆ ಪರೀಕ್ಷೆಗಳು ನಡೆದಿದೆ, ಅಲ್ಲಿ ಪೇಪರ್ ಗಳನ್ನ ಸ್ಟಾರ್ಟ್ ಮಾಡಿ ನಾವು ಇಲ್ಲಿ ಬಂದಿದ್ದೀವಿ. ಯಾಕಂದ್ರೆ ಆನ್ಲೈನ್ ಎಕ್ಸಾಮ್ ನಡೆಯೋದ್ರಿಂದ ನಮ್ಮ ಕ್ಯಾಮರಾಗಳಲ್ಲಿ ನಮ್ಮ ಉಪಸ್ಥಿತಿ ಬೇಕಾಗ್ತದೆ. ಆದ್ರಿಂದ ತಮ್ಮಲ್ಲಿ ಒಂದು ಕ್ಷಮೆಯನ್ನು ಕೋರ್ತಾ ಮತ್ತು ವಿದ್ಯಾರ್ಥಿಗಳಿಗೆ ತಮ್ಮ ಒಂದು ಲಾಭ ಆಗ್ಲಿ ಅಂತಕ್ಕಂಥ ಮಾತನ್ನ ಹೇಳ್ತಾ, ಮತ್ತು ತಮ್ಮ ಒಂದು ಬಿಡುವಿಲ್ಲದ ಸಮಯದ ಮಧ್ಯದಲ್ಲೂ ಕೂಡ ತಾವು ನಮ್ಮ ಮಹಾವಿದ್ಯಾಲಯಕ್ಕೆ ಬಂದಿರುವಂತದ್ದು ನಮ್ಗೆಲ್ಲರಿಗೂ ಕೂಡ ಬಹಳಷ್ಟು ಸಂತೋಷ ಆಗಿದೆ ಸರ್. ನಾನು ವೈಯಕ್ತಿಕವಾಗಿ ತಮಗೆ ಧನ್ಯವಾದಗಳನ್ನ ಸಲ್ಲಿಸಿ ನನ್ನ ಮಾತಿಗೆ
Thank you, sir. Now it's time to express our gratitude. Here we have a memento as a token of our appreciation. I request our beloved principal, Dr. Sayyida Akhtar Fatima ma'am, to kindly present felicitation to our chief guest, Dr. Ganga Borayya sir, Professor Emeritus and Research Head, Dayanand Sagar College of Dental Science, Bengaluru.
ಇಲ್ಲ ನಿಂತ್ಕೊಂಡ್ಬಿಟ್ರ
ಬೇಸಿಕ್ ಆಗಿ ಓದಿ ಒಂದು ಪ್ರೇರಣೆ ಸರ್ ಎಲ್ಲರಿಗೂ.
ಖಂಡಿತ ಇದು ಫೀಡ್ಬ್ಯಾಕ್ ನಾನು ಕೊಡ್ತೀನಿ.
ಎಸ್ ಸರ್, ಎಸ್ ಪ್ಲೀಸ್. ಒಂದು ನಿಮಿಷ.
ಥ್ಯಾಂಕ್ ಯು.
ಇದೊಂದು ಶವರ್ ಕೊಡಿ.
Yeah.
ಥ್ಯಾಂಕ್ ಯು ಮ್ಯಾಮ್. ಈಗ ಪ್ರತಿಭಾ ಪುರಸ್ಕಾರವನ್ನು ನೀಡಲಾಗುವುದು. ವಿದ್ಯಾರ್ಥಿಗಳ ಪ್ರತಿಭೆಯನ್ನು ಗುರುತಿಸಿ
ವಿಡಿಯೋ ಮಾಡಿ ಸರ್. ನೀವು ಹೇಳ್ತಾರಲ್ಲ ಅವ್ರು ಕಂಟಿನ್ಯೂ ಮಾಡಕ್ಕೆ. ಅದು ವಿಡಿಯೋ
ಈಗ ಪ್ರತಿಭಾ ಪುರಸ್ಕಾರವನ್ನು ನೀಡಲಾಗುವುದು. ವಿದ್ಯಾರ್ಥಿಗಳ ಪ್ರತಿಭೆಯನ್ನು ಗುರುತಿಸಿ ಪ್ರೋತ್ಸಾಹಿಸಬೇಕೆಂದು ಡಾಕ್ಟರ್ ಎಸ್.ಜಿ. ಉಪ್ಪಿನ ಅವರು ತಮ್ಮ ಮಹಾವಿದ್ಯಾಲಯದ ಪ್ರಸೂತಿ ತಂತ್ರ ಮತ್ತು ಸ್ತ್ರೀರೋಗ, ಕೌಮಾರ ಕೃತ್ಯ ಹಾಗೂ ಶಲ್ಯತಂತ್ರ ವಿಭಾಗದಲ್ಲಿ ಉಪನ್ಯಾಸಕರಾಗಿ ಕಾರ್ಯನಿರ್ವಹಿಸಿರುತ್ತಾರೆ. ವಿದ್ಯಾರ್ಥಿಗಳಲ್ಲಿ ಓದುವ ಆಸಕ್ತಿ ಮೂಡಿಸಲು ಹಾಗೂ ಓದಲು ನೆರವಾಗಲಿ ಎಂದು 1 ಲಕ್ಷ ರೂಪಾಯಿಗಳನ್ನು ಫಿಕ್ಸ್ ಡೆಪಾಸಿಟ್ ಮಾಡಿ ಅದರ ವಾರ್ಷಿಕ ಬಡ್ಡಿಯ ಮೊತ್ತವನ್ನು BAMS ತೃತೀಯ ವರ್ಷದಲ್ಲಿ ಪ್ರಸೂತಿ ತಂತ್ರ ಮತ್ತು ಸ್ತ್ರೀರೋಗ ಹಾಗೂ ಕೌಮಾರ ಕೃತ್ಯ ವಿಷಯದಲ್ಲಿ ಅತಿ ಹೆಚ್ಚು ಅಂಕಗಳನ್ನು ಗಳಿಸಿದ ವಿದ್ಯಾರ್ಥಿಗಳಿಗೆ ನಗದು ಬಹುಮಾನ ನೀಡುವುದಾಗಿ ನಿರ್ಧರಿಸಿರುತ್ತಾರೆ. 2018ನೇ ಸಾಲಿನ ತೃತೀಯ ವರ್ಷದಲ್ಲಿ ಕೌಮಾರ ಕೃತ್ಯ ಹಾಗೂ ಪ್ರಸೂತಿ ತಂತ್ರ ಮತ್ತು ಸ್ತ್ರೀರೋಗ ವಿಷಯದಲ್ಲಿ ಅತಿ ಹೆಚ್ಚು ಅಂಕ ಗಳಿಸಿದ ಪಸರ್ಗಿ ಭುವನೇಶ್ವರಿ ವೇದಿಕೆಗೆ ಬಂದು ಬಹುಮಾನ ಸ್ವೀಕರಿಸಬೇಕಾಗಿ ಕೇಳಿಕೊಳ್ಳುತ್ತೇನೆ. ಈ ಬಹುಮಾನವನ್ನು ಡಾಕ್ಟರ್ ಗಂಗಾಬೋರಯ್ಯ ಸರ್, ಪ್ರೊಫೆಸರ್ ಎಮಿರಿಟಸ್ ಅಂಡ್ ರಿಸರ್ಚ್ ಹೆಡ್, ದಯಾನಂದ್ ಸಾಗರ್ ಕಾಲೇಜ್ ಆಫ್ ಡೆಂಟಲ್ ಸೈನ್ಸ್, ಬೆಂಗಳೂರು ಇವರು ವಿತರಿಸಬೇಕೆಂದು ಕೇಳಿಕೊಳ್ಳುತ್ತೇನೆ. ಥ್ಯಾಂಕ್ ಯು ಸರ್. 2019ನೇ ಸಾಲಿನ ತೃತೀಯ ವರ್ಷದಲ್ಲಿ ಪ್ರಸೂತಿ ತಂತ್ರ ಮತ್ತು ಸ್ತ್ರೀರೋಗ ಪರೀಕ್ಷೆಯಲ್ಲಿ ಅತಿ ಹೆಚ್ಚು ಅಂಕ ಗಳಿಸಿದ ಗುಲ್ಸಬಾ ಅಂಜುಮ್ ಅವರು ವೇದಿಕೆಗೆ ಬಂದು ಬಹುಮಾನವನ್ನು ಸ್ವೀಕರಿಸಬೇಕೆಂದು ಕೇಳಿಕೊಳ್ಳುತ್ತೇನೆ. ಈ ಬಹುಮಾನವನ್ನು ನಮ್ಮ ಮಹಾವಿದ್ಯಾಲಯದ ಪ್ರಾಂಶುಪಾಲರಾದ ಡಾಕ್ಟರ್ ಸೈಯದಾ ಅಖ್ತರ್ ಫಾತಿಮಾ ಮ್ಯಾಮ್ ಇವರು ವಿತರಿಸಬೇಕೆಂದು ಕೇಳಿಕೊಳ್ಳುತ್ತೇನೆ. ಥ್ಯಾಂಕ್ ಯು ಮ್ಯಾಮ್. ಕೌಮಾರ ಕೃತ್ಯ ವಿಷಯದಲ್ಲಿ ಅತಿ ಹೆಚ್ಚು ಅಂಕ ಗಳಿಸಿದ ಆಕಾಶ್ ಬಿರಾದರ್ ಅವರು ವೇದಿಕೆಗೆ ಬಂದು ಬಹುಮಾನ ಸ್ವೀಕರಿಸಬೇಕೆಂದು ಕೇಳಿಕೊಳ್ಳುತ್ತೇನೆ. ಈ ಬಹುಮಾನವನ್ನು ಡಾಕ್ಟರ್ ಮಾಧವ್ ದಿಗ್ಗವಿ ಸರ್, ಪ್ರೊಫೆಸರ್ ಅಂಡ್ HOD ಡಿಪಾರ್ಟ್ಮೆಂಟ್ ಆಫ್ ರಿಸರ್ಚ್ ಮೆಥಡಾಲಜಿ ಅಂಡ್ ಬಯೋಸ್ಟಾಟಿಸ್ಟಿಕ್ಸ್ ಇವರು ವಿತರಿಸಬೇಕೆಂದು ಕೇಳಿಕೊಳ್ಳುತ್ತೇನೆ. Thank you, sir. Before we conclude, let us extend our heartfelt gratitude to all who made this event possible. I would like to invite Dr. Sampath Kumar Bellama, sir, Assistant Professor, Department of Dravya to deliver the vote of thanks. Now, I would like to invite our beloved principal, Dr. Sayyeda Akhtar Fatima ma'am, to say few words about the event.
Very good morning to all of you. Respected dignitaries on the dais, Ganga Boraya sir, Professor Emeritus and Head of the Department of Research, Dayanand Sagar College of Dental Sciences, Dr. Rajshekhar Ganegirji, Professor and Head of the Department Dravya, Dr. Madhav Diggavi, Professor and Head of the Department Kai Chikitsa, Dr. Ravi Chauhan, Professor and Head of the Department Rashastra Vaishyakalpana, Dr. Shiv Arkeri, Professor and Head of the Department Shalyatantra, Dr. Rajesh Sugur, Professor and Head of the Department Panchakarma, all my faculty colleagues, I just welcome all of you. This Paryeshana, the workshop on research methodology or medical statistics, was planned and designed in such a way that it should be benefited for the postgraduate students as well as undergraduate students. So it was being decided in the month of January to carry out this workshop, but due to various official commitments, exams were going on, and there was we were expecting the visitation team, and that is the very reason it was delayed. And somehow, within a short span of time, within a week, we decided to go ahead with this workshop, and the job was assigned to Dr. Madhav Diggavi, just because he's been teaching research methodology past 10-15 years, and he has the idea who can really do justice for this workshop. And he suggested, the first name he suggested was Ganga Boraya sir. I have heard about him from my students and my fellow colleagues, and today probably he is going to throw light on various aspects of medical statistics. I'm sure that all your doubts will be cleared and all your queries will be answered today. I just want my students to actively participate. It should be an interactive session, my dear students. In fact, I just want to say that research, the knowledge of research is very, very important to the postgraduate students as well as undergraduate students who are interested in to carry out research, because students, it is you who are carrying out the research. You should be interested because you are the one who are carrying out the research. The whole work is 90% of the work is being done by the students. Guides will only guide you. They'll be keenly observing whether you're doing the research properly or you're following the research protocol properly, collecting the data properly. They will be just keenly observing you and guiding you. But the whole of the research is being carried by the students. So the knowledge of research is an integral part for the student. They have to have the knowledge. And medical statistics, as you know, it is a sub-discipline of statistics, and the knowledge of medical statistics is equally important for all of you. To carry out any research program, I think my students should have the complete knowledge about what is this observational study design is all about, what is this experimental study design is all about, what is this sampling technique, what is the sampling method, how to determine the size of the sample, what is this correlation, what is this regression, what is this mean mode, what is standard deviation, what is standard error of the mean is all about. It is not just by hearting the things in the books to write an exam. No, then you will never can give justice for the research. Understand? You can never give the justice for the research. You just I have done that. I used to by heart mug up. Even today, I have a vague idea of medical research, because in those days they were not giving so much importance. We used to go to the statistician. He used to decide what test to be applied. He used to give the results. That's it. We hardly had knowledge, an in-depth knowledge of medical research when we were doing the research. I don't want my students to be like that. They should not be ignorant about the research, medical statistics, because it is the science which provides the users the means to collect, to review, to process, to summarize the data, and you can only draw conclusion from your study based on this data. You can only test the hypothesis by proper collecting and interpretation and analytical study of this data. So medical statistics is very, very important. I am sure that today's deliberation will 100% will clear all your doubts, all your queries, and you'll have a brief knowledge about medical statistics. With this very idea, we have invited Ganga Boraya sir, who is having in-depth knowledge about medical statistics. He has vast experience, is an expertise in this field, and I think this deliberation or this session will be very, very rewarding for all of you. Please make use of this opportunity. I take this opportunity, having said that, I take this opportunity to thank our HOD, Dr. Madhav Digga sir, for inviting Ganga Boraya sir for this workshop. I thank you once again, Ganga Boraya sir, for taking all the time and traveling from Bangalore. And you're giving time to share your knowledge with our students. Thank you all the HODs for arranging such a wonderful workshop. Thank you once again.
Thank you, ma'am. Before we conclude, let us extend our heartfelt gratitude to all who made this event possible. I would like to invite Dr. Sampath Kumar Bellama sir, Assistant Professor, Department of Dravaguna, to deliver the vote of thanks.
ಧನ್ಯವಾದಗಳು ಅಂಜಲಿ ಅವರೇ. ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. ಪರ್ಯೇಷಣ 2024 ಈ ಕಾರ್ಯಕ್ರಮದ ಘನ ಅಧ್ಯಕ್ಷತೆಯನ್ನು ವಹಿಸಿದಂತಹ ನಮ್ಮ ನಿಮ್ಮೆಲ್ಲರ ಅಚ್ಚುಮೆಚ್ಚಿನ ಮಾತೃಮೇಲ್ ಹಾಗೂ ಈ ಕಾರ್ಯಕ್ರಮದ ಘನ ಅಧ್ಯಕ್ಷತೆಯನ್ನು ವಹಿಸಿದಂತಹ ಡಾಕ್ಟರ್ ಸೈಯದ್ ಅಖ್ತರ್ ಫಾತಿಮಾ ಇವರಿಗೆ ಈ ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ಕಳಸದಂತಿದ್ದು ಶೋಭೆಯನ್ನು ತಂದುಕೊಟ್ಟು ಈ ಕಾರ್ಯಕ್ರಮವನ್ನು ಯಶಸ್ವಿಗೊಳಿಸಿದ್ದಕ್ಕಾಗಿ ತಮ್ಮೆಲ್ಲರ ಪರವಾಗಿ ಅವರಿಗೆ ಧನ್ಯವಾದಗಳನ್ನು ಅರ್ಪಿಸುತ್ತೇನೆ. ಅದೇ ರೀತಿಯಾಗಿ ಈ ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ಸಂಪನ್ಮೂಲ ವ್ಯಕ್ತಿಯಾಗಿ ಬಂದಂತಹ ನಡೆದಾಡುವ ಜೀವ ಸಂಖ್ಯಾಶಾಸ್ತ್ರದ ವಿಶ್ವಕೋಶ ಎಂದೇ ಖ್ಯಾತಿ ಹೊತ್ತಂತಹ ಡಾಕ್ಟರ್ ಗಂಗಾ ಬೋರಯ್ಯ ಸರ್ ಅವರಿಗೂ ಸಹ ಈ ಕಾರ್ಯಕ್ರಮವನ್ನು ಯಶಸ್ವಿಗೊಳಿಸಿದ್ದಕ್ಕಾಗಿ ತುಂಬು ಹೃದಯದ ಧನ್ಯವಾದಗಳನ್ನ ಹೇಳ್ತೇನೆ. ನಮ್ಮ ಸಂಸ್ಥೆಯ ಕ್ರಿಯಾಶಕ್ತಿ ಹಾಗೂ ಬೆನ್ನೆಲುಬಾದಂತಹ ನಮ್ಮ ನಿಮ್ಮೆಲ್ಲ ಅಚ್ಚುಮೆಚ್ಚಿನ ಡಾಕ್ಟರ್ ರಾಜಶೇಖರ್ ಗಾಂಗೀರ್ ಸರ್, ವಿಭಾಗ ಮುಖ್ಯಸ್ಥರು ದ್ರವ್ಯಗುಣ, ಇವರಿಗೂ ಸಹ ತಮ್ಮೆಲ್ಲರ ಪರವಾಗಿ ಹೃದಯಾಂತರಾಳದಿಂದ ಧನ್ಯವಾದಗಳನ್ನ ಹೇಳಬಯಸುತ್ತೇನೆ. ಸೃಜನಶೀಲತೆಯ ಮೂರ್ತಿ ಎತ್ತಂತಹ ಡಾಕ್ಟರ್ ಮಾಧವ್ ದಿಗ್ಗಾವಿ ಸರ್ ಅವರೇ, ವಿಭಾಗ ಮುಖ್ಯಸ್ಥರು ಕಾಯ ಚಿಕಿತ್ಸಾ ಹಾಗೂ ಈ ಕಾರ್ಯಕ್ರಮದ ರೂವಾರಿಯಾದಂತಹ ಅವರಿಗೂ ಸಹ ತಮ್ಮೆಲ್ಲರ ಪರವಾಗಿ ತುಂಬು ಹೃದಯ ಧನ್ಯವಾದಗಳನ್ನು ಹೇಳ್ತೇನೆ. ಎಲ್ಲ ವಿಭಾಗಗಳ ಮುಖ್ಯಸ್ಥರು ಹಾಗೂ ಬೋಧಕರಿಗೂ ಸಹ ಸರಿಯಾದ ಸಮಯದಲ್ಲಿ ಸಹಾಯ ಮತ್ತು ಮಾರ್ಗದರ್ಶನ ನೀಡಿದ್ದಕ್ಕಾಗಿ ತಮ್ಮೆಲ್ಲರಿಗೂ ಹೃದಯಾಂತರದ ಧನ್ಯವಾದಗಳು. ಹಾಗೂ ಆಸ್ಪತ್ರೆ ಮತ್ತು ನಮ್ಮ ಸಂಸ್ಥೆಯ ವಿದ್ಯಾರ್ಥಿಗಳು ಹೆಚ್ಚು ಅಂಕ ಗಳಿಸಿದ್ದಕ್ಕಾಗಿ ಬಹುಮಾನವನ್ನು ಘೋಷಿಸಿದಂತಹ ಹೂವಿನ್ ಸರ್ ಅವರಿಗೂ ಸಹ ಈ ಒಂದು ಸಂದರ್ಭದಲ್ಲಿ ಧನ್ಯವಾದಗಳನ್ನ ಅರ್ಪಿಸಲು ಬಯಸ್ತೇನೆ. ಅದೇ ರೀತಿಯಾಗಿ ಕಚೇರಿ ಸಿಬ್ಬಂದಿ ಮತ್ತು ಆಸ್ಪತ್ರೆ ಸಿಬ್ಬಂದಿಯವರು ಸಹ ಈ ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ತಮ್ಮ ಸಹಾಯವನ್ನು ಒದಗಿಸಿಕೊಟ್ಟಿದ್ದಾರೆ. ಅವರಿಗೂ ಸಹ ತುಂಬು ಹೃದಯದ ಧನ್ಯವಾದಗಳು. ಕಟ್ಟಕಡೆಯದಾಗಿ ಈ ಕಾರ್ಯಕ್ರಮದ ಶಿಬಿರಾರ್ಥಿಗಳಾದಂತಹ ಎಲ್ಲ ವಿದ್ಯಾರ್ಥಿಗಳನ್ನು ಸಹ ಈ ಕಾರ್ಯಕ್ರಮದಲ್ಲಿ ಪಾಲ್ಗೊಂಡು ಯಶಸ್ವಿಗೊಳಿಸಿದ್ದಕ್ಕಾಗಿ ತಮಗೆಲ್ಲರಿಗೂ ಧನ್ಯವಾದ ಹೇಳ್ತೇನೆ. ಎಲ್ಲರಿಗೂ ಮತ್ತೊಮ್ಮೆ ಧನ್ಯವಾದ.
Thank you so much, Dr. Sampath Kumar sir. Also, Anjali, and many congratulations to our meritorious UG students of PTSR and KB department. I thank Principal Ma'am, HODs of all department and professors present here to grace their presence today. So, without any further delay, I can see the eagerness in eyes of everyone to begin with the session. Now I request Dr. Ganga Boraya sir to take on the dais and begin with the next session.
Thank you. Thank you. Hold it. Thank you. Okay, let them connect. I was talking about accuracy of data, how accurate data should be. I used to give an example, my own personal experience. I was working as a consultant biostatistician for Novo Nordisk company. So they had conducted a clinical trial on insulin pen. They had their own pen released long ago, but the success rate of that pen was not all that good and appreciable. So the company took it as a challenge and did further study, further research. They came out with a new modified pen. Now, as per Indian government policy, any new drug to be introduced in the market, they have to obtain permission from Drugs Controller General of India. So this company approached DCGI. DCGI said, okay, fine, excellent, if you come out with a new pen, but please produce data proving that the new pen is better than their own old one. So clinical trial, we call it as multi-centric clinical trial. This has become more popular in these days, conduct of multi-centric clinical trials, because the results are easily generalizable to the whole country. So they selected 20 centers all over India, identified diabetologists, and distributed these two types of pens, which was in their product. So these diabetologists, based upon the numbers allocated to each of them, they did the study. Altogether, there was almost 6,000 patients, diabetic patients, who were insulin dependent. 3,000 diabetic patients were given with their first product, another 3,000 with the new product. So blood glucose was measured, fasting, postprandial, as well as HbA1c at a regular interval. Then, as I was a consultant biostatistician, the vice president medical called me and said, sir, kindly analyze this data and give the result. But before collecting the data, I had inquired with them, have you cleaned the data? I do not know what they understood by word cleaning. They nodded the head that yes, we have done it. So I took the data, analyzed it. To everybody's surprise, the new drug was not as good as the old drug. Company authorities became very angry because they have invested crores. They had invested crores of rupees. If a doctor recruits one patient as a sitting charges for that patient, the doctor was given 5,000. 5,000 into 6,000 patients. Drug expenses, investigation, huge sum of money was invested on this. So naturally, it is quite natural for the authorities to become angry. They also, asked me, have you done the analysis correctly? Please recheck once again the analysis. I've taken my laptop in front of them. I demonstrated what kind of analysis has to be done. There is no change in the results. That was a great loss. And besides this, the same drug tried in USA, UK, France had given an excellent result. They had proved that new pen is
superior to their old pen. Then why not in India? And moreover, the company had a great aspiration that Indian market they want to conquer. Since you know that the prevalence of diabetes in India is now very high. So they had in their mind that yes, we can promote this drug in Indian market, but it is failing. Then they said, sir, will you calmly think and find out what could be the reason? I said, sir, before collecting the data, I had asked one question, have you cleaned the data? 6,000 data, I was not able to, verify it. I believed that you have cleaned the data and given to me. I did the analysis. Now we need to verify whether data is correctly entered or not. When we verified, we found a lot of mistakes. Like, for example, fasting blood sugar for a patient, if it is 120, while typing that in the computer by the DTP operator, because at all the 20 centers, 20 DTP operators were appointed. While typing that value, it had printed as only 0. Probably the keyboard was so hard for 1 and 2, even though they have pressed it, not entered there. In some cases, the value was 1,200, 12,000. Such many mistakes out of 6,000 data we were able to identify. That is not an accurate data. So then I suggested, please ignore this data completely. Don't take this data into consideration. But you have the data, original data. Get all the original data from all the 20 centers, appoint a new team of DTP operators, make them to sit in a Bangalore office and make an entry, cross-check as and when there is a possibility. They took around 2.5 months to enter and cross-check, recheck it. We did the analysis, reanalysis once again. The result came out excellent. P-value and all I'll be introducing, right? That P-value was highly significant with respect to the new pen, right? So therefore, measurement of data as much as possible to an accuracy. That is where I use the word standards of accuracy. You need to ensure it. Only then you can prove what you are intended to prove it. And one more design, which I just half and forgotten, but this is also one of the excellent study design in clinical research, which we are making use of, called as non-inferiority studies. Nowadays, that is also becoming more and more popular with respect to clinical trials. The meaning of non-inferiority study is simple. You have a standard drug whose efficacy and safety has already been established, which is being practiced. It has also passed phase 4 clinical trial. In clinical trials, we have 5 phases. Preclinical relates to animal experiments. Phase 1 and phase 2 relate to the initial stage of establishing efficacy and the safety of the drug. Phase 3 is pre-marketing trial and phase 4 is post-marketing trial. Right? So you must use a drug which has even passed the phase 4 trial, and whichever the drug you want to prove it as non-inferior should be compared with that gold standard drug. Here, the meaning of non-inferiority study is that maybe in mathematics, if you're not forgotten, if I write x greater than or equal to 2, we call this as non-negative. Those mathematics lovable students will understand what I mean by non-negative is, right? I have written both the symbols. It is equal as well as greater than. Equal means x may be equal to 0 or it may be even greater than 0. That is a meaning. Equal to 0 or it may be greater than 0. Indeed, it is a positive values only. But because 0 is included, we call it as non-negative. The same word is extended in clinical trial, call it as non-inferiority. That means it's not inferior. In other words, it may be same as the gold standard drug, or even it may be better. So even this fourth design, non-inferiority studies are also becoming more and more popular in allopathic clinical trials. You can also try it. I told you, till this year in Government Homeopathy Medical College, from nowhere we have come up to RCT. Lot of students are doing RCT in homeopathy college. But this time I have told them, you must take a crossover design. Right? I'll try my best to even introduce this non-inferiority study. That means two drugs are compared. Either you should prove that the drug is same as the effect of the other drug, gold standard drug, or it could even be better than that. This is how a newer and newer technique has to be made use in conducting of research.
This RCT is same, sir.
Yes, sir. Yes, sir. You can extend that. You can extend it, but you are going to prove that also possibly better than. So that's where we need to think in terms of. There are some mathematical concepts I'll introduce later. Fine. Now coming back to, shall I use this now? No. Connected. Okay. Any problem? Put in order. How that? ವರ್ಕ್ ಆಗ್ತಿದಲ್ಲ ಆಗ್ಲೇನೆ ಈಗ ಲೂಸ್ ಏನಿಲ್ಲ ಒಂದು ನಿಮಿಷ ಬಟ್ ಅಲ್ಲಿ ಏನು ಬರ್ತಾ ಇಲ್ಲ ಮತ್ತೆ ಸರಿ ಅದಕ್ಕೆ ಕನೆಕ್ಟ್ ಮಾಡಿ ಬಟ್ ಪೆನ್ ಡ್ರೈವ್ ಏನ್ ಮಾಡೋದು ಶೇರ್ ಮಾಡಕ್ ಆಗುತ್ತಾ ಹಾಗೆ ಮಾಡ್ಬೇಡಿ ಪ್ಲೀಸ್ ಡೂ ಇಟ್ ಫಾಸ್ಟ್ ಅಲ್ಲ ಯೂಸಿಂಗ್ ಪೆನ್ ಡ್ರೈವ್ ಮಾಡ್ತೀರಾ ನಾನು ಯೂಶಲಿ ಪೆನ್ ಡ್ರೈವ್ ಹಾಕೋದಿಲ್ಲ ಏನಾಯ್ತು ವರ್ಕ್ ಆಗ್ತಾ ಇತ್ತು ಅದೇ ಅಲ್ಲೆಲ್ಲ ಏನೋ ಕನೆಕ್ಷನ್ ಪ್ರಾಬ್ಲಮ್ ಆಗಿರ್ಬೇಕು No. ಬರ್ತಾರೆ ಬಂತು ಬಿಡಿ ತಗೊಳ್ಳಿ ಆಗತ್ತೆ I'll show you. Right. ಆಯ್ತು. Okay, now, yes, this is very, very important. So these are I was talking about variability, and these are the different types of variability we come across. One is biological variability. We know that every one of us have a different biological parameters. Though normal, yet it varies from one individual to another individual. Then we have genetic variability, quite natural. Susceptibility and response variability means the patient's susceptibility as well as the response variability is also different from one individual to another individual. Environmental variability. Environmental factors Let me give you an example. I have no idea here in Bellary, but what we have seen in Bangalore, if I take, for example, Anandrao Circle, I think Anandrao Circle is familiar to all of us, right? The kind of major gases present in Anandrao Circle, supposed to be, right, toxic in nature, is entirely different when you go to, say, other areas like Bangalore. Silk Board. Silk Board is a very congested area now. Lot of vehicles move because it is a connecting area between Hosur Road. Hosur Road. It varies from one signal to another signal. So environmental factors also play an important role. Then we do have observer variability. A study has been done by choosing 25 X-rays. Coded means the details of the patient is masked. 2 radiologists were identified independently and they were not introduced. Those X-rays were given to them to report. So they gave the report. There was variation in the results report given by these 2 radiologists. A month later, all the 25 X-rays were recoded once again because some way, if they remember the coding, possibly they go with the bias. So it was recoded once again. The same 25 X-rays were given to them. You know what? The report given by them for the first time and report given by the second time, there was a variability. This is what we call it as observer variability. Inter means between as well as intra within. In both the cases, there is a variation. This is also true with other pathological, testing, reporting, microbiological reporting, biochemical reporting. Everything is possible. That's where we call it as. See, for example, I don't know whether you are heard of it or not. Sometimes we go for validation of the test. Some new test you want to make use, and you want to compare with the standard control. We suggest you are not supposed to do the test and reporting. You must choose 2 neutral persons to study that and give the report. There again, we come across, we call it as in case of validation, test retest method. So in test retest method also, we come across this type of inter-observer variability. Variability in treatment strategies. Two physicians treating the same disease, they prefer 2 different drugs. It's not the same drug. Same way, instrument and laboratory variability is also well established, as well as chance variability. So all these things will continue in discussion. Now, what is variable then? This 2-3 slides are very, very important. You must try to understand the whole statistical concept is based on or built upon understanding the meaning of these variables. Variable is a quantity which changes from person to person, then place to place, time to time, and from one entity to another entity. If you record your heart rate, it's not the same. Isn't it? Will it be same? Your heart rate will be same? No. Let us record your heart rate and ask you to go 1 round around this college. Come back and say, once again, what was recorded now, in another few minutes, it will change. So change from time to time. The temperature in Bellary now and temperature in Bangalore or Mysore or elsewhere is not the same. It varies from one place to another place and from one entity to another. Entity means non-living. Say, for example, if I choose 20 paraffin blocks of pathology department of the same disease, the results are not the same. It varies. That is where I'm talking about the variation from person to person, place to place, time to time, and from one entity to another entity. As said, the entire statistical analysis and selection of statistical methods based on the next 2-3 slides. So, in variable, we have two types. Two types. One is quantitative variable, the variable which is measured by numbers. The statistical procedures for analysis of data when they are measured by number are totally different from the statistical analysis which is to be used for analyzing the next type of variable called as qualitative variable. Qualitative variable are assessed only based upon certain criteria or attribute. So for example, here if I have to classify the students community as male or female, boy or a girl, you are not measuring by any number. To call the person as a male, you are not measuring by number and say that the person is a male or the person is a female. There are certain attributes based upon which we classify the person as a male or a female. Isn't it? Similarly, say type of family, nuclear family, joint family, 3-generation family. Once again, we are not measuring by any number. So also occupation. Do you measure a professor of statistics by a number or a professor of anatomy by a number? No, right? Isn't it? So therefore, Tyler, driver, software engineer, you name any profession, we don't measure by number. That is where I am talking about the qualitative variable. The statistical measures used for measuring this quantitative variable, you cannot apply here for qualitative variable. For example, I am going to calculate the mean age, the mean hemoglobin percentage, the mean lipid profile of different profiles, triglyceride, isn't it? LDL, HDL, whatever you measure, I should be able to express in terms of mean and standard deviation for all these. But not for this. It will be an absurd. I must give this example. When I was working in KIMS, I used to take around 30 hours of teaching for postgraduates, first year postgraduates. Every day, afternoon 2 to 4, I used to teach them. It so happened almost 2-3 days before conclusion, I had taught them the use of SPSS software. So one medicine PG, he approached me saying that, sir, I got a new SPSS version. Would you like to use it, sir? I was surprised because just 3 days back, that particular version of SPSS, which is an IBM product, was released in the market. If you want to procure that, commercial price is 10 lakhs. If I have to, whether it's a single user or multiple users, the cost of that software is 10 lakhs. But I was surprised, maybe this fellow's father is a very rich man, so therefore he has paid 10 lakhs and purchased. I asked him, how much you paid? His friend started laughing. No, sir, this fellow is good at hacking. So he has hacked and downloaded the software along with the product key, because software will not work without, giving the product key. Fine, I said, I don't want it. I'm an SPSS trainer. I have traveled the length and breadth of India. All over state I have traveled for one of the organizations. I don't need it. I have a personal, version. That was first year student. After 1.5 years, that fellow has done the analysis for himself as well as for his other fellow postgraduates. Fine. Dissertation was submitted to university. For his bad luck, his dissertation was sent to CMC Vellore. I tell you, whether it is CMC Vellore or CMC Ludhiana, is Christian Medical College. They are damn good in research methodology. Extremely good. So the professor of medicine, by looking at the result, was shocked and he called the vice chancellor. The vice chancellor name, I'm sure they all know by name, Dr. Sri Prakash. He called. He said, "What kind of research are you encouraging in your university?" Sri Prakash was asked, "What happened, sir?" You know what? Your postgraduate has calculated the mean and standard deviation for the sex of a person. SPSS requires coding. Even though we are measuring as a male or female, we are supposed to give 1 and 2 to represent male and female. It doesn't matter whether you are going to give 1 for male and 2 for female or vice versa. But that is the way the coding has to be given and then analyze it. This fellow has given the coding. What all I thought he did it. One thing what he missed is, I told him, none of these are to be calculated mean and standard deviation. That point he has slipped it. He selected the sex of a person, I mean that entire variable column, put it into calculation box, gave the command, it calculated mean and standard deviation, right? And below the table, he writes 1.6, madam. Mean and standard deviation of sex is 1.6 plus or minus 0.3. Then the professor examiner asks, "You mean to say that among the study subjects that your student has selected, 1.6 means either those people are male, neither a male nor a female, they are transgenders?" That's the meaning. That's the meaning, right? Please remember, whether you do the analysis or you give the data for somebody else, see that mean and standard deviation are not supposed to be calculated for any of these things. So this is also my request. Please see that, because in my college, you might have heard of that person named Dr. Anjanappa, who is very popular in the university also. He is least bothered about verification of all these things. He simply is to sign. Whatever student does it is immaterial. Hey, don't worry. But things are really important. Now these days, publication is gaining more and more popularity. People think in terms of, right, publishing. I was talking with Professor Dikavi in the morning. Now they look at your publication, is it in Q1 journal or Q2 journal and so on. So never do that mistake. Be clear, you are not supposed to do the calculation of mean and standard deviation for any of these variables. You can only, I have a measure. For these variables, we calculate only in terms of proportion. Proportion is a measure where you can do the calculation for these things. Otherwise, it is rate or ratio. When you measure a variable as a qualitative variable, you can calculate rate or ratio. 3 terms are used: proportion, rate, and ratio. Proportion is a quantity where numerator will be part of denominator. Suppose, say, we treat varicose vein. 60 patients you have selected, treated with a drug. Right, you may not believe in, say, in adverse reactions. Doesn't matter. I don't take adverse reaction as an example. But recurrence can occur, right? After treating the varicose vein patient, recurrence can occur. Out of 60 patients, how many patients have recurred in a span of, say, 2 years? Proportion of recurrence we talk about. That is, 60 patients of varicose vein were treated with a drug. After 2 years, say 8 patients have recurred back, come back to you. So proportion is 8 divided by 60. That is proportion. If that proportion is multiplied by 100, you express in percentage. That is all you can do it. Then what is a rate? How do you define a rate? OBGPGs can tell what is a rate. I'm talking about, say, perinatal mortality rate. How do you define perinatal mortality? I'm not talking about maternal mortality. Maternal mortality is now not considered as a rate, it is a ratio. Do you know that? Maternal mortality is not taken as a rate, it is considered as a ratio. So, what is that rate? In rate, numerator is a part of denominator, just like proportion. But in case of rate, you have to measure for a given place and time. So then what is perinatal mortality rate? Perinatal mortality rate is defined as number of late fetal deaths. This is a WHO definition. Late fetal deaths plus deaths under 1 week, within 1 week, weighing over 1000 grams at birth. Because WHO has felt that if the weight of the baby is less than 1000 grams at birth, the survival chances are very, very less. That's why they are measuring in terms of, right, late fetal deaths plus deaths under 1 week weighing over 1000 grams at birth. Denominator is very, very important. We take it as not total population, it is total number of births. Total number of births. That means it can include also stillbirth, live births plus stillbirth. That is perinatal mortality rate. For, say, for example, Bellary for the year 2023. That means for 2023, you have the data for Bellary, you can calculate perinatal mortality. Just an information, why we don't call it as maternal mortality as a rate, but why it is called as ratio. Ratio definition is the numerator and denominator are separate entities. They are not the same. That is why we say that it is sex ratio. For every 1000 males, how many females is what we counted. For India, as per 2011 census, we have for every 1000 males, 924 females only. Is due to Corona, we did not had this 21 census, but many have projected that the female population is further reducing thanks to our mother-in-laws. Yes, madam. Mandia, we call it as alemane. You know the meaning of alemane? Sugar, jaggery producing factories, we call it as alemane. I hope they'll understand Kannada, right? Yes. Mandyadalli, they grow sugar cane. Some they go for, they supply sugar cane for sugar factories. Some they go for preparing this jaggery. ಆ ಆಲೆಮನೆಯಲ್ಲಿ ಕೆಲವರು ಡಾಕ್ಟರ್ಗಳು greedy persons have encouraged sex determination using portable ultrasound scan machines. And once they come to know that among the pregnant women, once they came to know that female is going to give birth to a female baby, ಆಲೆ ಮನೆಯಲ್ಲಿ ಅಬಾರ್ಷನ್ ಮಾಡಿದ್ದಾರೆ. ಅನೈಜಿನಿಕ್ ಕಂಡೀಷನ್. ಆಲೆ ಮನೆ ಅಂದ್ರೆ ಕಬ್ಬಿನ ಸಿಪ್ಪೆ, ಅದು ಕಸ ಕಡ್ಡಿ ಎಲ್ಲ ಬಿದ್ದಿರುತ್ತೆ ಅಲ್ಲಿ. ಅಂತ ಕಡೆ ಅಬಾರ್ಷನ್ ಮಾಡಿ few women have died. No, I mean this is really inhuman. I mean, just to say, I don't have any other word to talk about that. That is why not only here, see, Karnataka is not just one example, is just one example. This situation is prevalent the whole country, throughout the whole country. Women population is reduced not because of Karnataka incident. It is the whole country. Anyway, leave that part. So coming back to this, please don't do the calculation of mean and standard deviation. It is only 3 measures. What are the 3 measures? Important. This is what statistics. Proportion, rate and ratio. Stop it there, right? Don't go behind that. But here we have wide range of statistical measures. That I'll take it up. one by one. Okay. Apart from qualitative and quantitative variables, these used as a basic variables, we also go for what is called as derived variables. They are referred as derived variables. Okay, called as categorical variable, independent variable, and dependent variable. Suppose a patient comes to you, you examine the patient, and you also record the patient height in meters, weight in kgs, and calculate body mass index. And you tell the patient that the body mass index of the patient is 32.86 kgs per meter square. Not an educated patient, a laborer, right? If you tell 32.86 kgs per meter square, patient will ask you back, Hagandre ಏನು Swami? Don't you think so? I'm not talking about educated people. I'm talking about a laborer. For him, if you say that your body mass index is 32.86 kgs per meter square, they don't understand anything. Instead, ನೀವು ಕನ್ನಡದಲ್ಲಿ ಹೇಳಿ, ನೀವು ತುಂಬಾ ದಪ್ಪ ಇದ್ದೀರಾ ಅಥವಾ ನಿಮ್ಮ ಏನೋ ತೂಕ ತುಂಬಾ ಕಡಿಮೆ ಆಗಿದೆ ಅಥವಾ ನಾರ್ಮಲ್ ಆಗಿದೆ ಅಥವಾ ಜಾಸ್ತಿ ಆಗ್ತಾ ಇದೆ, ಓವರ್ ವೆಯ್ಟ್ ಜಾಸ್ತಿ ಆಗ್ತಾ ಇದೆ ಅಂತ ಹೇಳಿದ್ರೆ they understand very easily. Am I right? But basically, what have you measured? By numbers. Correct. But you are expressing as underweight, normal, overweight, obese. This is what I meant by categorical. Categorical. Pain. We express pain as no pain, mild, moderate, severe. Physical activity, no physical activity, mild, moderate, heavy. All these are considered as, okay, categorical. What is the usefulness of classifying the variable as a categorical variable? Let us say you are taking two variables. One of them is smoking. The other one is suffering from cancer of lung. So, I classify the variable as cancer of lung, present, absent. Smoking, yes, no. The immediate thought that should come to your mind is, can I find a relation between smoking and cancer of lung? Don't you think so? Can you give me one more example like this? Categorical, where you want to find out a relation between the two categorical variables. Classical examples, there is also one more kind of a example where delivery assisted through instrument, yes, no. Epilepsy, present, absent. Lot of studies have been done. Delivery assisted through instrument, instrumental delivery, and epilepsy. They have found an association between these two. Tobacco chewing, oral cancer, alcohol, liver cancer. You can make a list of them. You know what? All these are tested using a statistical test called as chi-square test. Right? Chi-square test. That means there is a purpose for making this categorization. Later, I would like to look for whether such relationship exists or not. So therefore, a variable, whether you measure it as a qualitative or quantitative, it is required to make it as categorical. Similarly, also have what is known as independent and dependent variable. What is independent variable? A variable is called as independent when the changes takes place in itself. Without the external force, the change takes place in itself. Then what is dependent variable? The dependent variable is one where change in that variable is because of change in the independent variable. I'll give 2-3 examples. I think now it is common to everybody. When you go to a market, you want to buy tomato. Sometime back, kg of tomato was 200 rupees. Nobody liked to buy 5 kgs of tomato by paying 1000 rupees at that point in time. Yes, there was 200 rupees per kg. We have paid, right? Maybe I used to buy quarter kg, wait for the time, when it is going to reduce. It's a common phenomenon, isn't it? Now, what is the situation? As the price increases, quantity purchase decreases. Price is an independent variable. Quantity purchase is a dependent variable. We can bring out a relationship between them. That is what Madam was mentioning about correlation and regression. We are going to look into measuring the relationship between the two variables. See, for example, I was also mentioning about coronary heart disease. Coronary heart disease, I have taken, let us say, 200 people. They're not suffering from heart disease, but I've chosen 200 people. In those 200 people, let me assess their smoking habit, alcoholic habit, diabetes status, right? Hypertension status, obesity, stress, sedentary nature of work, or their physical activity. Don't you think? And age, of course, sex, of course. Don't you think all these variables which I mentioned here have an effect on either causing coronary heart disease or not causing coronary heart disease? Don't you think so? Did you get my question or not? I am measuring the variables like age, sex, smoking habit, alcohol, obesity, hypertension, physical activity, stress. You can make some more list. All these are considered as independent variables. These have an effect on either causing, not that everybody who is a smoker will develop coronary heart disease, not that every obese person will develop coronary heart disease, but some amount of risk is related, right? This is precisely what Madam was mentioning about regression. That means I wish to estimate what are the risks associated with each of these independent variables, what all I mentioned, on causing coronary heart disease is what we try to explain in terms of regression. In fact, we call it as logistic regression. Maybe you come across this kind of a literature where it's not just the regression, it is logistic regression, because quantitative variable is made it into category as disease present, disease absent. Fine. So hence, the entire concept of understanding variable is very, very important. Once you have a total grip over understanding the variable, selection of statistical method becomes damn easy. Very easy. Look at this example. Independent variable I've taken as OP poisoning, organophosphorus poisoning. The dependent variable, I would like to look whether the person after taking the OP poisoning has survived or died. Correct? Survival or death of a person depends on how much poison has been taken, what was the time gap between taking the poison and bringing the patient to the hospital. You have a concept called as golden hour. All that plays a role, right? So, similarly, even for quantitative variable, we have the same situation. We can bring out the relationship. Please understand, when you want to analyze your data, these two slides are very, very important. You must have a complete understanding of the variables. Then only you can decide what type of analysis can be carried out for the type of variable which you have measured. That is where morning I mentioned. I'll now link back. In the research method, in the research process, I think I'll go back to the slide. Yeah. In this slide, this one, outcome measure. So, when I look at the synopsis of any postgraduate, based upon the selection of the topic, I'll ask only two questions. What is your exposure and what is your outcome measure? For diabetes, what is your exposure? How did the person get the diabetes? And okay, you've identified the diabetes with the exposure. Exposure to diabetes, right? Yes or no? Then what is the outcome measure? How are you going to measure the outcome? I have given the background of variables. Tell me, how are you going to measure the outcome? Right, but what is that? What is that investigation? I'm not looking at investigation. I want it in the form of variable. What is that variable? What is it? Name it. Name what variable you are measuring. It is quantitative, not categorical. But what variable? Are you not recording blood sugar, HbA1c, or fasting glucose, or postprandial? That is where you need to come out. Okay, I'll give one more example. This you must tell me, being a medical person. Suppose 10 Alzheimer patients you are treating. Alzheimer patients. Your drug, you want to prove that your drug is effective. Correct? What outcome variable are you measuring? So for that, you must have a clear knowledge. What is the causative factor for causing Alzheimer, that is exposure? That may also be taken up as an outcome variable. You know what is the causative factor for that? Huh? Age is not a factor at all here. I don't look at, I'm also an aged person. Do you mean to say that I have an Alzheimer? There is one factor, it is beta amyloid 1 to 42 levels of protein. 1 to 42 levels of protein. Am I right? Yes or no? That is the exposure and that is a variable you are measuring, which is possible to measure in numbers. And it is measured by collecting CSF, cerebrospinal fluid. So this is the way you need to link to what topic you have selected, what outcome variable, what is the exposure for that, and can that be converted into, right, outcome variable? Is that outcome variable going to be your quantitative variable or qualitative variable? You got it? So therefore, first and foremost, you try to understand a clear idea about your variables, and the moment you identify the variable, come back to this slide and find out what is your outcome variable. Then your analysis will be very easy. It goes with the flow. It becomes very easy. Fine? Yeah. Before continuing, if you have any questions, please ask me. I will clear them and then proceed, because the subsequent topics are going to be different from what I'm teaching. Yes, anything, any questions? Yes, ma'am. Okay.
Anyone has any questions?
You want to announce anything?
No, sir. Just for the break.
Okay.
You want to take a break? Tea break.
Okay, then fine. I don't have anything to say. Right, fine, no problem.
Thank you so much, sir, for that varied explanation on variability. For the first time, we have studied.
Yeah, please.
Yeah.
Thank you so much, sir, for that varied explanation on variability. For the first time, we studied the concept of variability and variables in such detail. Now, I would announce a tea break for 15 minutes and request our audience to return promptly within 15 minutes. 10 minutes? Okay. 10 minutes.
15 ಅಂದ್ರೆ half an hour ಮಾಡ್ತಾರೆ ಸರ್.
Yes, sir, that's what I'm saying. See, madam, the whole research concept is based on this. What is
Okay. ಫೈನಲ್ ಬಿಡಿ ಕೊಡಿ. ಇಲ್ಲ ಫೈನಲ್ ಬಿಡಿ. ಇಲ್ಲ ಇದು ತಗೊಂಡ್ಬಿಡಿ, ಅದು ಅಷ್ಟು ಎಫೆಕ್ಟಿವ್ ವರ್ಕ್ ಆಗಲ್ಲ, ನೋಡಿ ವರ್ಕ್ ಅದೇ
ಆಗ್ತಿಲ್ಲ.
ಇಲ್ಲಿ ಬಿಟ್ಟು ನೋಡೋಣ. Now we'll start with ಸರ್ ಬರ್ತಾರೆ ಕೇಳಿ. ಆ ಕಡೆ ಇಟ್ಬಿಡಿ. Start. Okay. ಬರ್ತಾ
ಸ್ಟಾರ್ಟ್ ಮಾಡಿ.
Okay. See, hitherto whatever I have described or explained is related to just basic concepts. ಇದು ಪಾಯಿಂಟರ್ ಏನಾಯ್ತು? Basic concepts. But yes, I have the data, I have collected the data depending upon, okay. I have collected the data depending upon our research process, research design, objective, research question, the described methodology, all that we have followed, and let us say that we have the data with us. If we have the data, then first step is we have to describe it. In statistical analysis, we have two types. One is called as descriptive statistics, where you do certain calculations only to describe how the data is distributed. And the second type is inferential statistics. Inferential statistics comes only if there is a comparison. Only comparative studies we go for inferential statistics. Otherwise, we end up with only descriptive statistics. So in that connection, the first thing is that, right? Not moving. Okay. The descriptive statistics is based on what type of variable you are measuring. Are you measuring it as a qualitative variable or quantitative variable? That is important for us to clearly distinguish what type of analysis has to be carried out, either qualitative variable or quantitative variable. If it is qualitative variable, let us say the variable measured is qualitative, then as I said, only there are three variables or three measures. Either you can go for proportion or you can go for rate or ratio. Proportion, rate or ratio. They are the only three measures which one can think about. But if your variable is quantitative, then this is an example of proportion. If 7 out of 40 persons shows adverse drug reactions, in place of adverse drug reaction, I mentioned about the recurrence. You can think in terms of recurrence. So 7 by 40 is what we call it as proportion. We don't multiply by 100. We just keep as it is.
Then we have rate. Rate is one where numerator will be a part of denominator, but it is measured for a given time and place. Example, I've taken it as an infant mortality rate. So infant mortality rate, pediatric persons should know that it is defined as number of deaths of infants under 1 year age divided by live births, total live births, multiplied by, usually we multiply it by 1000. So if 40 births have occurred in a place for the year, whatever, 2019, and the infant mortality rate for the year 2019 is 1 divided by 40 multiplied by 1000. That means 25 deaths of infants have occurred per 1000 live births. Third one is ratio. That means if there are 25 boys and 60 girls in a class, then the sex ratio is, right, 60 divided by 25. That means for every 60 girls, correct. For every one boy, there are 2.4 girls. Okay. If the ratio is different, that means if there are 60 boys and 25 girls, it should be 25 divided by 60. That's the way it should be taken out. That's fine. Now is our concern. Concern is with respect to, right, calculation of measures, statistical measures for quantitative variable. Whether you are measuring your variable, outcome variable as qualitative or not, definitely you might measure your variable as quantitative. But in this case, we have to describe the data, right? Complete description is possible only by only after the lunch only by calculation of measures of central tendency and measures of dispersion, a very important pair of measures here, without which your description is going to be incomplete. So for that, let us learn one by one what do you mean by measures of central tendency and dispersion. Suppose I have a height, as I told, right, in the morning, if I have a height of one person, no statistical methods are possible to apply. No. But at least I have two data, height of two persons. One of them is 171 centimeters, the other one is 169 centimeters. I can make some effort in describing. That means the height of two persons ranges between 169 to 171. Got it? Also, you can say the mean height of the two persons is add up both the values, divide by 2. Correct? But before that, I just want to draw your attention for one. So I was waiting for the sir to come. You pen, marker, pen. ಇಲ್ಲ ನೋಡಿ ಎಲ್ಲನ ಇದೆಯಾ ಇದೆಯಾ ಕೊಡಿ now ಕೊಡಿ. This is applicable to all of you. Observe this data and tell me. Now, group 1 and group 2, this is related to descriptive statistics. Smoking habit, yes, no, discontinued, and quit. Okay, so it is, let us say, 100 and 35. Here also 135. Then 160 or 260, doesn't matter. 165 and 85. This is discontinued is say 100 people, and here it is 115. Quit or 50 and 100. Now, wait a minute. Okay. Suppose you are asked to give the interpretation of this data. How do you interpret this data? This is a natural way of presentation of data between the two. ಇಲ್ಲಿ ಮುಂದೆ ಇಟ್ಬಿಡಪ್ಪ, ಅಥವಾ ಇನ್ನು ಕೆಳಗಡೆ ಇಡಿ, ಪರವಾಗಿಲ್ಲ, ಕಾನ್ಸೆಪ್ಟ್ ಎತ್ತಾಗಿರ್ತದೆ. ಇಲ್ಲಿ ಕೆಳಗಡೆ ಇಟ್ಬಿಡಿ, ಅದು ಕೆಳಗೆ ಯಾವ್ದು ಬೇಡ, ಇಲ್ಲೇ ಇಡಿ, ಬರೆಯೋದಕ್ಕೆ ತೊಂದರೆ ಇಲ್ಲ. ಇಲ್ಲ, ಅದು ಇದಕ್ಕೆ ಸ್ಕ್ರೀನ್ ಎಡಿ ಆಗತ್ತೇನೋ. ಇಲ್ಲ ಸರ್, ಅವ್ರಿಗೆ ಕಾಣೋದಿಲ್ಲ. ಇಲ್ಲ, ನಾನು ಹೇಳೋದೇನಂದ್ರೆ ಇಲ್ಲಿಟ್ರೆ ಸಾಕು, ಕಾಣಿಸುತ್ತೆ. ಇದು ಅಡ್ಡ ಆಗುತ್ತೆ. ಇಲ್ಲ, ಬರಿಬೋದು, ನಾನ್ ಬಂದು ಕೇರ್ಫುಲ್ ಬರೀತೀನಿ ಬಿಡಿ. ಇದು ಸ್ವಲ್ಪ ಟರ್ನ್ ಮಾಡೋದೇ ಬೇಕಾದ್ರೆ ಅವ್ರಿಗೆ ಕಾಣೋದಿಲ್ಲ. ಹೇಳಿ. Now, how do you interpret this data? ಹೇಳಿ. How to interpret this data? I am not only teaching some statistical methods, I am also going to tell you how to interpret this kind of data. How do you interpret? Right? Say there are 135 people who are smokers in both the groups, 65 non-smokers. 65 of them are non-smokers in group 1 and 85 of them are in group 2. 100 of them have discontinued smoking in both the groups, and 50 quit in group 1 and 120 quit in group 2. How do you interpret this data? If not, our undergraduate students, PG should be able to tell this. How do you interpret? Important, right? This is what I call it as a data. There are two types of data. One is called as primary data, other one is called as secondary data. Primary data is the data collected according to your problem statement, your research question, your aim and objective, your study design, everything. It is according to your idea. You are the authority on that primary data. Secondary data is the data collected by some other researcher or some other source, right? Some other researcher would have collected the data, analyzed it, given in the form of results. Suppose I wish to know the trend of diseases treated in, right, Taranath Government Ayurvedic Medical College. I want to see the trend or trend of, let us say, chronic kidney diseases treated in this hospital for the last 10 years. If there is a record, I can look at those 10 years data and report in every year. Like, for example, now it is 2024. I'll start analyzing the data from 2015. I'll take 10 years data, correct? I can find out. That is also secondary data, right? So this is data. What all I have given here is a data. Data is defined as raw details. It's just the raw details collected from either patient or individual or healthy person, whoever it is. Even if you look at the records, that's called as retrospective case record analysis. Even there also, I get only the data. Now, given the data, how do you interpret this? Please make an effort. Okay, I will give the interpretation. Tell me whether it is correct or not. If I say there are equal number of smokers and equal number of smokers and equal number of discontinued persons in both the groups, is that correct or not? No. Why no? You must have some reason to say no, right? But then what is that reason? Why do you want to say no? I say yes. That's the way data has to be interpreted. Yes or no? Is wrong. Wrong. Right? Look at this. Why it is wrong is 0, then 1, 5, 350, 4, 440. Correct. Calculate the percentage. Please do it. Take your mobile at least. Tell me the number. Divide 135 by 350. How much? 38. Any decimals? This is also important point. When you do the calculation, you must express it for 2 decimals, right? So tell me, 38.57. When you write in the bracket, it is understood that it is percentage. Yeah, next number, 65. 18.57. Okay. 18.57. 100. 28.57. Okay. 50. 14.28. Okay. Same thing, you please tell me here. 30.68. Okay. 19.31. 72. Then 27.27. Now 19, so there is some when you add up, it should add up to 100. There is some maybe small decimals. You need to make an adjustment. Totally get to add up to 100. Figures in parentheses indicate percentage. Figures in parentheses indicate percentage. This is an excellent way of presentation of data. So you need not tell that what is given in the bracket is a percent, and you need not use percentage symbol. It looks clumsy. It doesn't look nice. Every number you put a percentage symbol. This is the beauty of making a presentation of a table. Now, do you agree? There are equal number of smokers and equal number of discontinued? Not at all. That means the message is, when you are interpreting data, never ever use data for interpretation. It should always be the information. So what is information? It may be mean, it may be percentage, it may be proportion, it may be correlation. Anything, the data transformed into other form, we call it as information. So always we use information for interpretation purpose. Now that is going to give you the correct interpretation, right? When you present the data graphically also, never present the data in the form of, never present it in the form of data, because for yes and for discontinued, both the rectangular bars will be equal. But it is not equal. Isn't it? It's not equal. So this is also an important thing. When you represent the data, don't represent by data, you should represent by information. Whatever information you're taking, If I convert this into mean, you should use mean for your interpretation of data. Okay, coming back to this now. Here, so it's like this. As the number of observations in quantitative variable increases, its description also requires different measures. First, let us take up the central location issue by studying measures of central tendency. These are the different measures which we are making use of. Is it visible for you? Okay. These are the different measures which are used for interpretation of data. Sorry, for describing the data. Description. So one is, I just call it as a mean, but there are three types of mean. We call it as arithmetic mean, geometric mean, and harmonic mean. This is used only in physics. We generally don't use in medical data analysis. This is used in microbiology. You know the meaning of geometric progression. Have you heard of geometric progression? Like 2, 4, 8, 16, 32, right? 64, correct? 128. That kind of data we call it as geometric progression. Very unlikely that we come across that kind of a data in our results, research results. So therefore, that is also not used unless you find the data in that pattern, geometric pattern. So both are ruled out. Hence, is only the arithmetic mean. Therefore, even though mean is referring to arithmetic mean or geometric mean or harmonic mean, we simply call it as, right? Mean implies it is arithmetic mean unless otherwise specified. Unless otherwise specified as geometric mean, it is to be taken as arithmetic mean only. Mean is referred to arithmetic mean. Oh, sorry. What happened? No. I think it is my connector. ಇಲ್ಲ ನಂದು ಕನೆಕ್ಟ್ ಆಗಿಲ್ಲಪ್ಪ ಇಲ್ಲ ನಂದು ಲ್ಯಾಪ್ಟಾಪ್ ಕನೆಕ್ಟ್ ಆಗಿಲ್ಲ ಕೊಡಿ ಅದಕ್ಕೋಸ್ಕರ ಅದು ಆಫ್ ಆಯ್ತು ಇದು ಅಷ್ಟೊಂದು ಪವರ್ ಬ್ಯಾಕಪ್ ಇಲ್ಲ ಓವರ್ಸ್ ಬರುತ್ತೆ ಅಷ್ಟೇ ಈಗ ಆನ್ ಆಗಿದೆಯಲ್ಲ ಬರುತ್ತೆ ಓಕೆ ಬರುತ್ತೆ ಬಿಡಿ, ಡೋಂಟ್ ವರಿ, ಬರುತ್ತೆ ಬಿಡಿ. ಆಗತ್ತಾ ಅದನ್ನ? ಫೈನ್, ಥ್ಯಾಂಕ್ ಯು. Right. So you must always think that mean implies is only arithmetic mean unless otherwise specified. Suppose you have a data which follows geometric progression, then you say that I am calculating geometric progression. Here, example ಹೇಳ್ತೀನಿ. Now rabies trials ಅಲ್ಲಿ we collect the blood sample and then for the presence of antibodies we give the vaccine, right? By giving the vaccine, a vaccine is an antigen. So when you inject an antigen into a person, that antigen will get converted to antibodies. So we test for the presence of antibodies by using a test called as rapid fluorescent inhibition test. That is expressed in geometric progression because they dilute the that whatever they are using for testing in multiples of hundreds. So results are going to be like 2, right? 4, 8, 32, 64. It comes that way where we are using geometric mean concentration. That's called as geometric mean concentration. And that particular test is done in the entire country in only one place, that is NIMHANS, National Institute of Mental Health and Neuroscience. Okay, so otherwise you don't bother about the geometric mean, right? It is only arithmetic mean. So how do we define arithmetic mean? It is defined as number of observations divided by number of observations divided by sum of the observations divided by number of observation. For calculation of mean, particularly when you are measuring the variable as quantitative variable, they are always denoted by x, y, z, etc. X, y, z. The values taken by these variables are denoted by their lowercase letters. These are all small lowercase, right? I have given here two definitions intentionally. If I call this as a population, if there are 30 persons, then I'll use this as a mean. 30 persons. This will be used as a mean. Got it? Called as population mean. This has its implication in the statistical inference. I'll tell about that later. Out of 30, if I choose 5 of you and collect the same data, then it will be called as sample. Demarcation is, one is notation. I am using mu as a notation for mean, for population, and x bar as a notation for sample. Denominator also differs. For always population size is denoted by capital N, and for sample it is denoted by small n. These are all universal notations. Whether this is used in Ballari or in California in USA, right, or Mexico, understand, or Moscow in RS and Russia, notations are same. That's not going to change. So always keep it in mind that capital N will be taken up as a population size, small n will be sample size. Then fine. Look at this data. This also known as dot diagram. This is one of the graphical representation called as dot diagram. Each dot denote frequency. So 1, 3, 5, 7, and 9. These are the values I have taken. 1, 3, 5, 7, and 9, just for making you understand the concept. So in this case, the mean happens to be, okay, I've given all the values, fine. That's also good. Look at the 1, 3, 5, 7, and 9. And 1, 3, 5, 7, instead of 9, I will change it to 14. Here, even 9 and 14 is dropped. I've taken the value as 24. In this case, 44. Can you tell me what is the mean? Quickly. Each one of you take different, series and just tell me. Very simple. Add up all the value, divide by 5. In every case, we have only 5 values. And you are not going to end up with decimal. I'll see to that is without decimal. Tell me. 1, 3, 5, 7, 9. What is the total? 25 divided by 5. Mean is 5. What about the second? Here. 6. Then? No. No. Total is 40. 8. Then what about this one? Total is 16 plus 44. Rather, no, not 16. 12, correct. 12. What do you understand by this? What do you understand by this? This is where you need to apply your, mind. What do you observe here? What do you observe here? What is your observation? As the value increases, the mean also increases. Correct? So that means there is a shift. Mean is a centrally located value. When you calculate the mean, taking into consideration all the values, it tries to locate somewhere, not exactly center, it tries to locate somewhere in the middle of the distribution. But What you should understand is these two. These two. This is what we refer it as extreme values or outliers. Because see, these four values are almost close to each other, whereas these two values, even 14 might be taken somewhere close to this, but these two values are very far away from the other four values, which are called as outliers or extreme values. Got it? Outliers might be recorded with or without our knowledge. Sometimes it might come for various reasons. It's an error, or it might even be a wrong selection of study subjects. That might also lead to these type of errors. I'll give you an example how the errors come to prove that this new combination of two drugs of microlab is non-inferior to the other standard company drug. Okay, the study duration was 3 months. 4 measurements were recorded. Blood glucose were recorded before starting the treatment. We call it as day 0 or baseline data at an interval of 1 month, because 3 months duration. So day 0, then at 1 month, 2 months, and 3 months. The inclusion criteria was all those diabetic patients, newly diagnosed diabetic patients. Because if I take old age, they would have been treated by some other drug. The effect of the drug will already be there. I cannot measure, right, the pure effect of the new drug. So therefore, we always go in any clinical trial, we always go with the new diagnosed cases. So it was done. Inclusion criteria was all those patients who have 200 to 250 as our blood sugar, fasting blood sugar. Study started. So after 1 month, the blood test was done. There was a reduction in the blood sugar. So the team felt very happy, at least our drug is working. Second month, there was further reduction. Last measurement, we had also found that the measurement showed quite a considerable amount of reduction in the blood sugar. I mean, it's not that within 3 months we'll bring them back to the normal. No, fine. There was a considerable reduction in the blood sugar, except for one patient. For that patient, initially he was having 200 as his blood sugar level. The third month measurement showed very close to 300. We were all shocked. See, first month, second month showed a reduction in the blood sugar. All of a sudden, it triggered to 300, close to 300. So then we started exploring what could be the reason. So we went on, guessing too many reasons. Finally, we decided, no, let us not go with the guessing. Let us call the patient and inquire. All of a sudden, what happened to the patient? The story given was quite interesting. He's from Bangalore, but from a village background. In the village, Gram Devata festival. They all went to the native. They had a grand feast for about a week's time. And there was a due date for a blood sample. Previous night, they have enjoyed the party till 2 o'clock midnight. Next day morning, he came to the lab and gave the blood sample. And that was the reason all of a sudden there was a triggering off. Because 1 week he has enjoyed the life. That 1 week he also has not taken the drugs. So that is what I meant by outlier. That is what I meant by outlier. wrong selection of subject might also give the right results of outliers. So be careful. That is where we insist that your inclusion and exclusion criteria must be very carefully prepared. One is possibility of preventing the confounders. Second is a wrong selection will result in this kind of a outlier results. That's one point. Secondly, see, when we calculate the mean takes all values into consideration for calculation. While sum of the observations divided by number of observations, that means you are including all values in the calculation. So one of the property of mean is that it is affected by extreme values or outliers. That needs to be taken care. Then we have, okay, this is a mean I had computed. Next, median. Median is another measure which gives you exactly mid value. That means median divides the whole data into two equal parts, for which one important procedure you are supposed to do it, that is arranging the data in the increasing or decreasing order. Only then you will be able to identify the correct position of the mean. In fact, it is a median which is called as positional average. Though it's a location parameter, but exact position, central position is indicated by median. However, median is not affected by extreme values. Why? Look at that. In this 2, right, it is 5. Also in the next 2 examples, it is 5. Why? Because it takes only the middlemost value. Extreme values are not taken into consideration since all the values are not taken together, unlike the mean. Got it? So therefore, there is a concept called as skewed data, skewness or skewed data. So what is that skewness? What do you mean by skewness? That's so easy. I'll take it. Okay. The meaning of skewness is this. See, suppose if I have the distribution of data like this, or so this is normal. We call this as normal negative skewness. This is also important in data analysis to look at what type of data you have positive skewness. Then what is the meaning of normal first? Look at the graph, first one. It resembles a bell shape. Agree with me? First one resemble a bell shape. Bell is symmetrical, right? It's not that there is a dent on one side, means bulge on the other side. It looks symmetrical. If your data follows symmetrical, then it is called as normal. But look at the other two. It is deviating from normal. It's not exactly normal, right? There is a majority of the data in this case is distributed towards the right side and a very few values towards the left side. Very few values towards the left side. In the third case, majority of the data is distributed towards the left side and again a very few values in the opposite direction. This is what we call it as deviation from normal is what we refer it as skew. Skew means asymmetrical, otherwise also called as deviation from normal. So, when your data is of these two type, that is skewed type, either is negative skewness or positive skewness, you are not supposed to analyze your data using the mean and standard deviation. A very important point that you must note down, that we have what is called as, in statistical inference or testing of hypothesis, we have what is known as parametric tests and non-parametric tests, right? So, if your data is skewed, you can't apply parametric test. You can't. Meaning, if I have two groups of data, I recorded, let us say, the diabetic patients' blood sugar value for both the groups. If my data follows the first type, we test for normality. I'll discuss in the inferential statistics. If the data is normal, no doubt I can apply unpaired t-test and draw the inference. If my data is not normal, even if one group is normal, the other group is non-normal, you cannot apply unpaired t-test. We have to go for non-parametric test where we have it in the form of Mann-Whitney U-test. Mann-Whitney, some people call it, but spelling is M-A-N-N, whatever the way you pronounce, it is called as Mann-Whitney U-test. That is a test we are going to apply. So therefore, median play a prominent role when your data is skewed data, right? And for what type of data you are supposed to calculate mean, it is only quantitative variable. I already told you, when you measure the data quantitatively, even here also you measure quantitatively. You got it? This data is also quantitative. Still, I'm not recommending mean because it is skewed data. So this point you must be clear to yourself that where to apply what type of statistical analysis. Then mode. Mode is the most frequently occurring or highest frequency. The one with highest frequency, we call it as mode. Not a very commonly used statistical measure in data analysis. Only in case of qualitative nominal scale, like for example, the occupation, gender, all that kind of a variable we express, which is the most frequently occurring. Say, suppose you have collected the data related to occupation. In the study which you are conducting, you are analyzing also occupation as one of the group, right? So most of them may be homemakers. Now we are not calling them as housewife, we call them as homemakers. So if majority of them are homemakers, then mode is related to that number. That's how we interpret the data with mode. Otherwise, we are not using it as a major measure for statistical analysis. Okay, that's fine. But there is a possibility you have only one value repeating more than one time. So this is considered to be the unimodal because 9 has repeated 3 times, others have less than 3 times. Therefore, mode is taken as 9. Whereas here, 9 and 12 repeat highest but equal number of times. So therefore, it is called as bimodal. This is unimodal, single value. There are 2 values with equal number. Hence, we call it as a bimodal. Like that, we have trimodal also. We have trimodal. Okay. 3 numbers are repeating highest but equal number of times, which is called as trimodal. And Suppose if all the values are repeating exactly once, then it is called as ill-defined. We call that as ill-defined mode. That doesn't mean that there is no mode, right? But we make use of the, that's why it's called as ill-defined. We make use of the formula for ill-defined as mode equals 3 times median minus 2 times mean. So this formula is made use in the calculation of median mode. Okay, fine. Next. Yeah. Tell me what is the mean median mode for this data? Please. I have given 2 sets of data. Tell me what is the mean median mode quickly. You just take 5 minutes, doesn't matter. Okay, this side you can calculate for the group 1, this side let them calculate for the group 2 to save the time. I also given the total. You need not do the totaling. Tell me what is the mean, median, and mode. I don't think you require so much of time, right? Mean is 5 in both the case, right? 45 divided by 9. 5 repeats 3 times in both the cases. So mode is 5. Only it's a question of median, right? That's also 5. That's also 5. Now, you have mean, median, mode. Both group distributions have equal number. Now, my question is, do you mean to say that both distributions are same? Why? If you say no, you should give a reason why. Why you say that? Because all the 3 measures are same, right? Then why can't we say that both the distributions are same? Tell me why. There must be some reason. Individual? What do you mean by that? Right, your point is correct. Your point is correct. See, in the first group, the lowest value is 2, highest value is 8. If it takes a difference between any two values, say for example, it's not there, 2 to 8, the difference is plus or minus 6. Either you go for 2 minus 8 or 8 minus 2, plus or minus 6. 5 to 5 is 0. 3 to 5 is plus or minus 2. That means there is a distorted difference between one pair of observation to another pair of observation. So the lowest is 2, largest is 8 in the first group. Whereas in the second group, the lowest is 1, largest is 15. So it ranges between 1 to 15. Obviously, the differences are also of that type. So mean is also a measure which is mean or median, whatever you are calculating, is a measure which tells only the central distribution, central location. Rather, distribution is a central location. In that, mode is the positional average. Only central part you are talking about, but how much spread in the data is not possible to tell through calculation of mean or median. So, when you want to describe the data, we need 2 things. One is, where is the central position? Around that central position, how much
spread in the data. I repeat once more, try to grasp that concept. When you want to describe the data, I need a central position, and around that central position, how much, right, spread is there? How much spread in the data? And that is possible to, right, do by calculation of the second measure, which I had mentioned it as measures of dispersion. So dispersion is nothing but spread. This term dispersion is borrowed from physics. There, you know that it is called as dispersion of light, means spread of light, isn't it? Don't we use that word spread of light? It is dispersion of light. So here we are talking about dispersion of data. So around that we are talking about the chain, isn't it? For which now the most widely used measures of central dispersion is standard deviation. Given by S equals square root of summation x minus x bar whole square divided by n minus 1. This is the formula we are using it, that is x minus x bar whole square. Procedure is very simple. You first calculate the mean, subtract that mean from individual values. When you add up, invariably it will be 0. That is one of the property of mean also. When mean is subtracted from the individual value which is used for calculation of mean, add up, invariably that will become 0. Then square that difference, total it. That is what I have written as summation x minus x bar whole square. That total divided by n minus 1, and then divided by n minus 1. That's it. It is called as variance without square root, meaning s is equal to s square equals summation x minus x bar whole square divided by n minus 1. We call it as variance. So this is also a very, very important measure which we are going to use in inferential statistics in the name of analysis of variance. Okay, so definition is same. If you take the square root of variance, it is standard deviation, or if you square the standard deviation, it gives you variance. Okay, any problem? ಇಲ್ಲ ಅಲ್ಲಿ ಆನ್ ಆಗಬೇಕು. So you had noted down the values, those values. I had projected two distributions, right? You are not noted down. Okay, please do that standard deviation formula. I mean, apply the formula, calculate standard deviation for that. I think first group also noted down. Okay, okay. I'll show you the data. Please. Can you do the calculation of standard deviation? I just said you already calculated mean. From each value, you subtract the mean.
and total it. The total is going to be 0. Just check it. Say here 2 minus 5 is minus 3. This is plus 3. Automatically cancels. Here all this is 0. Between these two, minus 2 plus 2 cancels. This is plus 3, 0, minus 3, right? Cancel. This is also 0. So total will be 0. But square it. Square it, square it. Whoever has done the first group and second group, subtract the mean, square it, take the total, tell me what is the standard deviation. Divide by n minus 1, that is 8. Just to break the monotony. Just to break the monotony, I just gave them the problem. Not only that, they should understand. Oh. Got it? How much you got? $44 for first group. Yeah. Divided by 8. $5.5 is the variance. 5.5 should be taken up as a variance. Take the square root of the 5.5. Use your calculator. There is a calculator, square root in the calculator. 5.5 square root of it. 2.35, right? 2.35. You're right. Always mean and standard deviation should be expressed to 2 decimals at least. So 2.35. What about the second group? Who is doing the second group? So the first group is 2.345, otherwise it is 2.35. Second is 4.09. Okay. Now, the important observation, particularly with respect to the standard deviation, I would like to draw your attention for this, that look at here. Look at the interpretation. The interpretation is, what we do is, we take the data, this is a mean, and around the mean, we look at the observations. These are the observations around the mean. Central value is mean. Around the mean, you can look for the observations. Correct? The average distance from the mean to the individual data is what we call it as standard deviation. You can, in place of the dots, you can write the value. It gives the same meaning. Let us say this is 2.35. It may be even, I think it was 2, 3, 5, 6, right? Maybe one more value was there, and this was 8, right? So on an average, the distance from mean to the individual data is called as standard deviation. You just make a note that the standard deviation is nothing but, right, the average distance from the mean to the individual data. Or else, the standard deviation is also described as, right, the average distance around the mean, or the spread of the data on an average. The spread of data on an average around the mean is what we refer it as standard deviation. Lower the standard deviation, look at here. Lesser standard deviation shows lesser variation in the data, leading to consistency. Consistency. Otherwise, similarity in the distribution of data. consistency or similarity in the distribution of data. So we always look at consistency in the data. More the spread, more variation in the data is considered to be inconsistent. That is very difficult to interpret it. So, there is a question. Sir, what should be the ratio of mean and standard deviation? When to use mean, standard deviation, and moreover, whenever you are using the quantitative data, calculating the mean, there is a thumb rule that the standard deviation generally should be less than 1/3 of mean. For example, if the mean is 15, you expect that the standard deviation should be around 5. But some school of thought, different statisticians thought that it's too narrow a limit, so therefore they extended to 2/3 of mean. Meaning, out of 15 as a mean, you can go up to 10 as a standard deviation. 2/3 of mean. 2/3 of mean is 10, right? So, you are considering the application of mean and standard deviation for description of data if the standard deviation is less than or equal to 2/3 of mean. If it crosses beyond 2/3 of mean, it's an indication that your data is moving towards skewness. Got it? Here, what we expect is the standard deviation should be ideally less than 1/3, but very difficult to achieve. So extend it till 2/3 of mean. If the data goes beyond 2/3, there is a possibility the data will move towards skewness. Then you are not supposed to use mean and standard deviation as a pair for description of the data. So in place of mean and standard deviation, we are using median and interquartile range. I'll tell about the interquartile range later. So when the data is going towards this skewness, we don't interpret the data by mean and standard deviation. We go for median and interquartile range. I'll give the definition of interquartile range. Got it? Is it clear to all of you? Okay, tell me. When to use mean and standard deviation and when to use median and interquartile range? Not able to hear. Tell me yourself. The first girl, yeah. When do you use mean and always mean and standard deviation should go together? Yeah, please tell me. Okay, what do you mean by consistent data? Because that is little way to call it as consistency in the data. So we use a term, I told you, 1/3 or 2/3 of mean. Standard deviation should be either less than 1/3 or 2/3 of mean. You go ahead. If not, we are going to use median and interquartile range. That's the point. Got it? Okay, please sit down. So, it is not enough if mean alone is used to describe the data, but standard deviation is also needed to give complete description of the data, as both mean and standard deviation have a same unit of measurement, whereas variance has double the unit of measurement. Suppose you are recording the height in centimeter, both mean and standard deviation will have the same unit. Why? You're taking square root, right? The square root and square cancels, but in the variance, the square remains. Yeah. So, next one is this. probably tea. Sir, when do you leave them for the lunch? What is the time plan for lunch? Okay, we'll stop it here. This I'll start after. Yeah, new topic. I'll start after the lunch. Yeah, tell them the time for lunch, when they should come back. I feel earlier the better.
ಆಯ್ತು ಅದೆಲ್ಲ Okay, we'll start.
Good afternoon, everyone. You had a good lunch. Now, 2 minutes. Now that we have gained insights on the basics of biostatistics, it's time to deepen our conversation with our upcoming session. As we delve deeper, let's approach with curiosity, our mind, curiosity, open minds, willingness to learn, and bring theory of science into practice. I once again request our guest of honor today, Dr. Ganga Boreya sir, to begin with our next session on probability.
Thank you. Okay, so what all we discussed till now is just pure statistical concepts. Pure. Look at these examples. I have four examples. These two are equations, mathematical equations, very elementary in nature. And the first equation is taken from equations of motion from physics. V is equal to U plus AT. V is the final velocity, initial velocity, acceleration, and time taken. The second expression is taken from elementary arithmetic, calculation of simple interest. I is equal to PRT by 100. Correct? Now, there are four unknown quantities in both. Among these, if I know the value of any three of them, the fourth one is possible to calculate. For instance, in the second equation, if the simple interest is 500 rupees for a period of 2 years calculated at the rate of 5%, you substitute the value of I, R, and T. What we do not know is P. With simple algebraic jugglery, we get P is equal to rupees 5,000. It's an exact value. It's not a guess value. Whoever does the calculation, value is not going to change. So therefore, we call it as deterministic because exactness is there. Same way, for instance, if you are given with a value for final velocity, initial velocity, and time taken, meaning V, U, and T, A can be calculated again using the simple algebraic jugglery that V minus U divided by T. That gives the acceleration. That's also going to be exact. Look at these two examples. Now, you're all doctors. You also have been, PGs also might be now doing, seeing the cases in the OPD, and how many times, right, we are able to make 100% correct diagnosis all the time. You've seen 100 patients. Is that all 100 patients have been diagnosed correctly? Not possible, right? Similarly, look at this example, diagnosis through an laboratory investigation. Our recent experience. We have read in the paper, people were suffering from corona, but the RT-PCR test result has shown negative. People were not having corona infection. RT-PCR has showed positive. We call it as false positive and false negative. All these are based on a simple concept called as randomness or chance occurrence. We call it as, the first one is known as deterministic because exactness is there with V equals U plus AT or I is equal to PRT by 100. We come across the exactness, but whereas here it is unlikely, likelihood, may or may not be. See, if you see 100 cases, 99 might be a correct diagnosis, at least one might go wrong. The chance of wrong diagnosis is 1 by 100. Or even it could be 1 by 1000. An experienced person. May not be because of your mistake. Let us take the example of dengue and chikungunya. Don't you think the signs and symptoms are almost the same for both? A thin line difference between dengue and chikungunya. If you miss that in your differential diagnosis, don't you think that there is a likelihood of a chikungunya being diagnosed as dengue or dengue being diagnosed as chikungunya? That may happen 1 in 1000. Probability is 1 divided by 1000, 0.001. Still we go wrong. This concept of probability or randomness or likelihood is not only applicable to the diagnosis or not only applicable to anything, anywhere, even in our day-to-day life, it is applicable. Were you dreamt before joining to this college for your postgraduate or undergraduate that, let's say, let us take the undergraduate students, were you dreamt that you are going to do your BAMS in, right, Taranath Government or Ayurvedic Medical College before you got selected and enter the college by paying the fees? Definitely not, right? Probably you were aiming for medical seat, MBBS seat. You might have landed up here. That is a chance factor. Purely a chance factor. See, for example, very last year, my brother's son got 1,000 around 800 rank rural quota. Last seat was remaining in the selection process. It went into one reservation category. Still he has not come out of the depression because I got 1,800 rank and in spite of that I did not get it. It took almost 4 months for me to bring him into a normal state, and I'm encouraging him to write one more time the NEET. He has scored 98% in 10th standard and 99% in pre-university physics, chemistry, biology, and mathematics. 100% in all the 4. Only languages he has scored less. That's why it is 99%. He says, when I'm able to score 100 out of 100, right, still I'm not able to get a medical seat. So these are a chance factor. Somewhere something goes wrong. We can't predict it. So therefore, in research also, it is quite natural. Why did that example I gave about that diabetic example where the blood sugar value happens to be 120 recorded as 10, right? 0. They're all referred as some randomness, some systematic error. I'll come to the differentiation later. Okay. So this is how exactly we define probability. Any event related to chance occurrence, not being able to predict, unpredictable, uncertain situation, should be described by a phenomenon called as probability or likelihood. It's a measure of how likely that something will happen. Something will happen. And it is always expressed in numbers. Always. Example, let us take, suppose on the highway, two vehicles have met with an accident. There are, say, 12 persons involved in the accident. 12 persons met with an accident. So here n is equal to 12, and we can classify the outcome of this. And don't you think accident is a random phenomenon? It's a random phenomenon, right? It's not that every time the accident is going to take place or for everybody. Some people are escaped, some people are getting involved in the accident. It's purely random phenomenon. In that random phenomenon, I am going to divide as, say, RTA, whatever may be the number, n is equal to 12. I classify into two categories: survival or death. Survival or death. Both are chance, right? Both are chance, right? So, probability is nothing but finding the chance occurrence of the event in which you are interested. You might be looking at finding out what is the chance of a person met with an accident being survived. I might be looking at what could be the possibility of a person being died. Survival is the event of your interest. Finding the probability of death of a person is my event of interest. So, probability is defined as, always we denote an event, say probability of yes is number of favorable event for survival divided by total number. So I said 12 of them were involved. The formula generally we write it as m divided by n. So this value will always be less than or equal to 1 and greater than 0. Why? Why this value is always less than or equal to 0 and greater than, less than or equal to 1 and greater than 0? It is very easy to describe it. Whatever numerator I am talking about, the m, is selected out of n. Number of favorable event in which you are interested is chosen out of the total number of events. For instance, let us say 8 of them have survived. That means probability of survival I am calculating as m divided by n, which is 8 divided by 12. 8 divided by 12. That 8 is chosen out of 12. For that reason, it can never be a negative value because m is always chosen out of n. It can never be a negative value. For the same reason, if all 12 survives, probability is 1. I cannot say if 12 people were involved in the accident, 15 have survived. I can't say. It's an absurd thing. Only I'm looking at 12, right? I'm not able to think about 15 survivors. Where do you bring the remaining 3? So therefore, it will not go beyond 1. If all 12 survive, we call it as certain to survive. Certain means definite. Certain to survive with probability 1, because 12 divided by 12 is equal to 1. So therefore, it is certain to survive. If all 12 die, it's an impossible event for survival. Am I right? Are you getting the point? If all survive, certain to survive. If all 12 dies, impossible to survive. So therefore, probability of always lies between 0 and 1. Otherwise, it will be less than 1 and greater than 0. A very, very important concept which I am going to make use henceforth completely till my discussion today is over. And perhaps they've already selected or submitted the synopsis. Not yet. Okay. Have you started doing a review of literature? Not yet. Started, right? While you are doing the review of literature, the most common term which you are going to come across is capital P less than or equal to 0.05. And they say that it is significant. Then what is this magic number of P? Can't we do our research without this P, particularly in the comparative studies? Impossible. Impossible. You might select 2 drugs for treating, let us say, asthma cases. You must select 2 drugs. You want to test which drug is better in treating asthma. Okay, you have chosen 40 patients in one group and another 40 patients in the second group. Experimental drug and control drug. You find 15% difference in the improvement of experimental and control group. Clinically, you are very happy that compared to the control drug, I am able to achieve 15% more in the experimental drug. And if you report in your scientific paper, nobody will support you. Nobody will accept you unless you give a result through this, the magic number P less than or equal to 0.05. You refer to any journal article. Nobody has said clinically this is significant. Instead, they say that statistically it is significant. Only that word statistically significant makes your paper of high standard. So let us learn today that concept through this probability. So hence, probability of S is equal to 8 by 12. Obviously, probability of D should be N minus M by N. That means out of 12, if 8 survives, who are the remaining? 12 minus 8. It is 12 minus 8, right? In the equation form, I can write this as N minus M. Quite natural. So this is 4 by 12. So for me, this equation is very important. Probability of S plus probability of D will always be equal to 1. Will always be equal to 1. And this is known as probability distribution. That means if you consider any event, any number of events, the probability distribution is nothing but the distribution of a total probability of 1 according to the events which you defined. Morning I had written one table, you remember? Smoking, right? Group 1, group 2. Yes. Do you know what is the name of that table? It is called as frequency table. That is the distribution of 350, right? according to in group 1, the distribution of 350 according to either the smokers, non-smokers, those who discontinued or those who quit. Same thing with respect to 405, right? 440, right? Isn't it? That is all known as frequency distribution. Because it's a distribution of a total number of 350 or 440 according to the 4 categories which we had listed out, that is smoking, yes, no, discontinued and quit. Remember that it is called as frequency distribution. This one is called as probability distribution because here it is addressing the distribution of a total probability of 1 according to the different occurrence of events. Let me make that small modification. The small modification is, say, instead of taking only survival and death, the same thing, I'll just divide it as 3 classifications, and those 3 classifications are, let me say, S1, I call it as survived with injury. S2, survived without injury. And S3, I take death. I know the probability of death, 4 by 12. For instance, let us say here, this is 6 by 12, right? This is 2 by 12, and this is obviously 4 by 12. So therefore, probability of S1 plus probability of S2 plus probability of S3 also again add up to 1. So I will introduce 2 distributions. One is frequency distribution, other one is probability distribution. Subsequently, we are going to learn one more distribution, which is also very, very important for our learning. Any questions here? Is it clear? Among these probability distributions, I have to tell you about one very important distribution, that is normal distribution. Yeah. Look at this example. What kind of graph is this? No, graph. No, not a bar diagram. Bar diagram is one where between every rectangular bars you are leaving a gap in between. That is called as, right, that kind of data, because you're also going to present your results after 1.5 years, right, in the form of graphical representation. They're all referred as simple or multiple or component bar diagram, where between every rectangular bars you're giving a equidistant gap. That kind of a data we call it as, again, data I divide it into 2 types. One is called as discrete data, other one is called as continuous data. When do we call the data as a discrete? When your measurements are made without decimal values. Age is a discrete. Yes or no? Why? Why can't we take? Suppose if I am, say, 65 years, right, 8 months, 9 days. Why can't I put it in decimals? Can't I or can I? It's a quantitative, right? But can I express my age as, right, 61 years? Understand? 9 months, 3 days. Why? Why not? Why not? Because it is a government policy. Yes, it's a government policy. Please understand. It is a government policy because there are people like me, honestly, who do not know my date of birth. I do not know, honestly. Whatever was written at the time of admission to the school, that has become my official date of birth. All my friends who studied along with me, I'm from a village. I'm from a village. My parents, my uncle, my grandparents, everybody is illiterates. Probably they had not dreamt that their son or grandson is going to become a professor, emeritus, and going to stand before in this Ayurvedic medical college, addressing you all of you on biostatistics. They're not known at all. They're not known. Therefore, my date of birth is not written anywhere. All my friends who studied along with me, both in BSc and MSc, they retired from service after 2.5 years of my retirement. It seems my grandfather used to say, I was very naughty boy during my younger days. Right? I never used to allow my parents to just keep quiet. And very ತುಂಬಾ ಹಠ ಮಾಡ್ತಿದ್ದೆ ಅಂತ ಹೇಳ್ತಿದ್ರು. ನನಗೆ ಇಂಥದ್ದು ಬೇಕು ಅಂದ್ರೆ ಅದು ನನಗೆ ಬೇಕೇ ಬೇಕು. So to avoid all that, at very young age, they put me into school. Right? So yes, teacher wrote 2.5 years to adjust for that 6 years. Admission was 5 years, 10 months at that time. I mean, I don't repent because my background was like that, isn't it? So that's why, like me, there are many in India who are all from rural background who do not know their date of birth. Tribal people who will write their date of birth. Isn't it? I have visited Biligiri Ranganabetta, where you might have, I don't know whether how many of you heard about Dr. Sudarshan of Vivekananda Trust. He is running a very good NGO providing health services for people living in that tribal area. They're all called as Soligas. In Mysore district, there is a place called as Biligiri Ranganabetta. It is close to Malay Mahadeshwara Betta. So he is doing a yeoman service. We have visited those places. There are tribal people, they don't even know how to read and write. Who will teach them how to write their date of birth? Like that, we have so many people in India who are living right in tribal areas or even in the rural area. So therefore, age is to be, till government changes the rule, age is to be taken as completed number of years. See, 2016 I retired. My current age is, as per the government order, I am 67 years. Right? What may be the original age? So please remember, why I am giving this particularly is, when you are collecting data on your patients, you are not supposed, even though they are educated, even though they say that my date of birth is so much, but still you are counting it as completed number of years only. Therefore, it is discrete. Can you give me some other example of discrete variable? Measured without decimal. Lipid profile. Any of the lipid profile. Cholesterol. Do you measure with decimals? Cholesterol. What about LDL, HDL? I'm not talking about the ratio. LDL, HDL, triglyceride, all are measured without decimals, right? Or are you measuring any of those with decimals? No, right? So therefore, they all come under discrete. Very important point which I want to tell you here is, when you construct a class interval for these things, we have what is called as inclusive type of class interval. Inclusive. That is where bar diagrams comes into picture. Say, for example, if I take age is classified as, let us say, 21 to 30, 31 to 40, 41 to 50, 51 to 60. Suppose your lowest age included in your study is 21 years. So then 21 to 60. This kind of a class interval, we call it as inclusive type. Because this is known as lower limit and this is known as upper limit. Both lower limit and upper limit are included for counting. 21 to 30 you have to include only in the first class interval. So both are included, right? And there is a gap between 30 to 31, 40 to 41, 50 to 51. For this type of data, you are supposed to draw only bar diagram. Bar diagram means it comes like this. This kind of a diagram, we call it as bar diagram. Now, what is continuous? Opposite of discrete is continuous. Continuous variable is one where it is measured with decimals. We can give quite a number of examples. Hemoglobin percentage is measured with decimals. Electrolytes, potassium, sodium, right? Nitrates, all of them are measured with decimals, right? Suppose if I take hemoglobin percentage, then the class interval is going to be 5 to 7, 7 to 9, 9 to 11, 11 to 13, and 13 to 15. This is known as exclusive type. Exclusive type. Because decimal values are also to be counted. For that reason, even though I take it as 5 to 7 and 7 to 9 and so on, why it is named as exclusive is while counting the exact value of 7, exact value of 9, 11, 13 are excluded for counting in the upper limit. I'm saying 7, 9, 11, 13 to be excluded for counting. Meaning to say, in the first class interval, you can include up to 6.9. Exact 7, take it to the next class interval under lower limit. Then 9 up to 8.9, exact value of 9 to be taken to the third class interval. Now, you have a continuity from upper limit to lower limit. 7 and again 7, 9 and 9. It is for that data we are drawing this histogram. So please remember, when you want to draw a histogram, your class interval essentially must be in the exclusive type. Continuity should be there. Okay? On the other graph, alternative to histogram, the other graph is line graph. You can draw a line graph also. Advantage between a histogram and line graph, if at all you are intended to measure the trend in the data, you know the meaning of trend, right? Either increasing or decreasing. When you want to express a line graph is always better instead of going for histogram. Got it? So now coming back to this, in this histogram, I am selecting midpoints. Midpoints at every rectangular bar at the top. You can just see I have selected midpoints at the top of the rectangular bars. If these midpoints are joined by a straight line using scale between 2 points, it is called as frequency polygon. When the two midpoints are joined by a straight line, it is referred as frequency polygon. The same 2 points, if I join with a freehand curve, is known as frequency curve. If that frequency curve resembles a bell shape, then it is referred as normal curve. Got it? And if for the normal curve, if I'm defining through probability, then it is called as normal distribution. So a normal distribution is a bell-shaped curve, symmetrical on either side. Morning I told you about skewness. So therefore, it is symmetrical on either side of the central line, the mean. The central line is considered as a mean of the distribution. So this is known as, I remove the histogram. This is exactly how a normal curve looks like. It has a wider application in statistical inference. Whatever data that you measure, if you want to apply parametric test, either t-test, ANOVA, or whatever, first assumption we are supposed to verify is that whether your samples are drawn from normal population or Sometimes I told you, population is unknown population. I may not know the nature of the population. When the population is unknown, I cannot know the nature of the population. In such cases, whatever the data that you have collected, there are statistical tests meant for verifying whether the samples drawn are following normal distribution or not. I'll mention that later. We do that. If it follows normal, we continue with the parametric test. Otherwise, we are supposed to move to non-parametric test. So therefore, this probability distribution play a prominent role or crucial role in statistical inference. Okay, now look at here. The range of this is between minus infinity to plus infinity. First of all, it's a continuous distribution. And normal distribution is considered as mother of all other probability distribution. There are empty number of probability distribution by different name. But ultimately, for various properties verified, all of them converge to this normal distribution. One of them is sample size. If the sample size is more than 30, it has been established beyond doubt that eventually it may be a triangular distribution. We have triangular distribution, we have rectangular distributions, we have irregular distributions. All of them, if sample size is more than 30, eventually they get distributed like this. So therefore, this is considered as a mother distribution or population distribution. That is why, remember I had introduced this term. What is this? Population mean. I told that this is population mean. So population mean implies it is for the entire group, right? So therefore, we need to carefully, right, use the concept mu is the population mean. Then, you know what? From this line to any of this is measured by standard deviation. I told you, no? What is standard deviation? Around the mean. Around the mean, it is an average distance. Average distance. Look at here. If you take the distance from this point to this point and this point to this point, standard deviation is the same. It will not change because it's an average distance. So, the entire area from minus infinity till plus infinity is 1, right? Total probability, right, is 1. But in terms of percentage, I can express it as 100%. Total probability is 1. That percentage, it becomes 100%. In which case, this part from up to mu, from minus infinity up to mu, it is 50%. Again, from mu to plus infinity, another 50%. Both put together, 100%. That is where we call it as symmetrical. Symmetrical. The central line is the mean that divides the whole area into 2 equal parts. Okay. This is exactly what I would like to make it clear. Okay. 50% on either side of the mean mu. Then, these are some of the important properties. It's a bell-shaped symmetrical curve on either side of the mean mu. This is the only distribution where all the 3 measures all the 3 measures of central tendency will be same. Point of inflection is the maximum area covered and area under the curve, that will come later. We make use of mean and standard deviation in describing the area. It has its wider application. Let me show first. This is known as 1 sigma limit. 1 sigma. Between mu minus sigma to mu plus sigma, the area covered is 68%. This has application in medical science. Pediatric PG. Who is a pediatric PG here? Nobody? At least you have studied pediatrics, right? Okay. What is growth and development of a child? How do you decide the growth and development of a child? Milestones. Good. But how do you measure? Weight, weight and height. Then, have you heard of Road to Health card? Road to Health. Okay. You know what? When you consult pediatricians, this is also a WHO recommended concept where we take the anthropometric measurements on y axis and say, for example, age along x axis. Age measured in weeks, months, and years at different time points. For a large number of normally healthy children, whatever anthropometric measurements you are talking about, height, weight, mid-arm circumference, chest arm circumference, isn't it? All that measurements can be plotted along the y-axis. Say, let us say, I'll take it as weight. Weight measured in kgs. This is y-axis. So, they've plotted a graph. It runs like this. Please refer to WHO also. This is how the three lines are observed. And the bottom one is called as mu minus sigma. This is mu and this is mu plus sigma. Mu, mu is the mean of the distribution. Sigma is the standard deviation, right? If you want to consider for different ages, if you want to consider, of course, a little different type, it goes this way, a little higher, because as age advances, this also increases. So this is known as, if the weight or any anthropometric measurement is fallen within these three lines, it is considered as a normal growth. Normal growth. Anything fall below, it is undernourishment. Undernourishment is in the form of marasmus and kwashiorkor. Then this is considered to be overnourishment, childhood obesity as one of the examples. So to decide this, we are making use of this called as, it is popularly known as Road to Health. You can refer to WHO, even they have given this graph for all anthropometric measurements, weight separately, height separately, right? Or mid-arm head circumference, mid-arm circumference, chest circumference. For everything, you are able to see this. So, therefore, mean plus or minus 1 standard deviation finds its wider application in deciding the growth and development of a child. Now, this is covering 16% because the middle area is 68%. So this is another 16%. Right side also naturally should be the other 16%. Let me give another example. Suppose I take the height of 1,000 people. Height of 1,000 people measured in centimeter. So it's a quantitative number, right? Measured in centimeter is quantitative, right? I can calculate the mean. Let me say 1,000 is a population. I get mu is equal to 164 centimeters. I avoid decimals just for easy calculation. 164 centimeter with a standard deviation of 5 centimeter, let us say. Now, what is mu minus sigma? 1 sigma only. That is 164 minus 5, 159. And what about 164 plus 5? 169. That means this is 159, 164, 169. What does that mean between 159 to 169 centimeters? 68% of the observations are distributed within this range of 159 to 169 centimeters. In other words, 68% of 1000 means it is 680 people height, ranges between this, correct? 680. In the remaining 32%, 16% on the left side and another 16% on the right side. That means 160 people will have the height less than 159 centimeter and another 160 will have the height more than 169 centimeters. So this is also a WHO recommended used kind of scales which we are making use of. Secondly, because this is taken as only 68% and a wider area is left out, now they have increased to 2 sigma limit. And very, very important for all scientific endeavors, because that 5% what I had written there is derived from this area. I written P less than or equal to 0.05. And you observed it. That is derived from this area. That means for all scientific endeavors, we expect that most of the data should be distributed within 95% of the area, considered as acceptance region. In testing of hypothesis, I am going to talk about that. The middle area, 95%, is taken as an acceptance region, acceptance of null hypothesis. And the remaining 5%, 2.5% to the left and another 2.5% to the right. So therefore, this is going to be a widely used distribution. Lastly, we have this 3 sigma limit where almost the entire area, 99.97% is covered within this range. Practical application in statistical quality control process. Any product manufacturer, right from our garment till major machines, it has to pass through quality check. For that quality check, the tail ends, where I mentioned as unshaded, is considered as a rejection criteria. What is shown within the shaded area is taken as a acceptance region. So if it falls within this, that quality will be passed. Is any product quality is passed. If it falls in that unshaded area, it is 0.015%, because what is left out from that 99.97% is 0.03%. I am dividing between both the tails. That means it is 0.015%. A very small. The garment may be, say for example, this garment, believe me, I have paid 300 rupees in a sale. Looks good, but the cost of this is only 300 rupees. But some people go for trending, right? They want only, Park Avenue or whatever the name. I am not going for that, right? Costs around 1,000, 1,500, 2,000. Such dresses, you are going to look for every inch of the stitches, whether it is correctly put or not. Isn't it? If it is not, you are going to reject it. You don't want that kind of a damaged or defective product. Imagine for a garment like that, if it is a bigger machine, where invested in terms of crores of rupees, if it falls in that rejection region,
how much money you are going to waste. So therefore, we always look for meeting at most carefully check specifications. That's where we are following this. Okay. Anyway, just one another slide. Exactly the normal distribution is represented by this formula. I'm not scaring it. You need not remember it. But the point here is, it is very difficult to simplify this formula, even for a mathematician like me. We have to go for integration. Quite number of steps I'm supposed to do it. If that is the case for me, I can't expect you to do that integration. It's not wise. So therefore, what we have done is, this is the trouble creator. This entire thing with the square, whatever I've written here is a trouble creator. So what I'm going to do is, only what I've written inside the bracket x minus mu by sigma, I replace it by a new variable called as z. The whole calculation becomes very easy then. That is the beauty of mathematics. The whole equation, if I take, very difficult to simplify. I replace the trouble creator x minus mu by sigma, your calculation becomes much, much easier. So, advantage, you need not even integrate it. Ready-made statistical tables are available. We just calculate the z value and refer to the table. Again, coming back to pediatrics. In pediatrics, they make a small for, right? Large gestational age, those kind of concepts you are using it, right? You come across what is called as Z score. They also, I mean, people call it also Z score. That is the one which we make use in case of studying about the whole concept. So you need not worry about the normal distribution. We go for Z distribution. So this is what I meant by Z distribution, normal distribution. This is how the whole concept is simplified, right? And it has a mean 0 and variance 1. Yeah, this is a table. This is a table where these are the Z values calculated. You know the mean value, you know the standard deviation. Substitute in the formula. Whatever the value you get, you for the first decimal, you refer this table. Second decimal, you refer the first row. I'll give you an example. I have an example just for demonstration, nothing more. Nothing more. Look at this example. I said just for understanding, to make you understand how this table can be made use. If birth weight in a population are normally distributed with a mean of 3,113 grams and a standard deviation of 95 grams, that is mu is equal to 3,113, standard deviation sigma is equal to 195. Read this question. What is the chance of obtaining a birth weight of 3,481 grams or heavier? Heavier means more than, right? So what I'll do here is, I've done the calculation. Look at there. X value is 3,481. That is what I want to find out. I know the mu value, I know the sigma value. So 3,481 is my X value. This is given. This is also given. On simplification, I get the value as 1.89. Correct? Isn't it? On simplification, I get this value. Now, I'll go back to that table. How we are going to refer the table. Look at this table. Here, 1.89. 1.8 is here. The last value I'm supposed to consider, this is 0.9706. This is a total area I'm talking about. But I need more than that. See, what I'm saying here is, okay, let me represent in the graphical form.
It is this way. I have the normal curve, right? This is what given z is equal to 1.89. This entire area is 0.9706. I want this area because I am looking for more than 3,481. So I need this area. What is the total probability? 1. Subtract this. How much you get? 0.0294, correct? From 1, you subtract 0.9704, 06. You get 0.0294, otherwise it is 2.94%. That means those children who have the birth weight more than 3,481 gram is only 2.94%. This has a wider application. That is where we always quote that normal distribution is considered as a mother distribution, referred everywhere. We'll move further. I'll just tell about briefly about the sampling, or if you're all familiar with sampling, directly I go to testing of hypothesis. You want me to tell about sampling or not? Okay. In our medical science or any other science, the research is not done based on the entire population. I told you the reason also, that population is an unknown population. Suppose here, I'll give one more example. Say, professor has given you the topic related to diabetic foot ulcers, right? Treatment for diabetic foot ulcers. Topic is given to you. After completion of your synopsis submitted to university, now you are supposed to start the study. How do you know how many diabetic foot ulcers patient come to your hospital here? You have any idea? Let us say you start the study from May 1st. Count 18 months from there. In a span of 18 months or 1.5 years, how do I know how many diabetic foot ulcer cases are coming to you? Possible? Possible to tell me how many? I'm talking about prospectively from May 2024 till probably, right, November or December 2025. I can't say how many diabetic foot ulcer patients are coming here. Correct? So you can't do a study on the entire population. It's quite difficult. Not difficult. You can't do that because population is unknown. So the only choice left out is I can choose a part of that diabetic foot ulcer patients based on this sampling technique. But for that, I need to know how many patients. See, when population is unknown, at least I should know what is a sample, how many samples or patients should be chosen. How can I go about it? Let us say diabetic foot ulcer is around 26%. 26% of diabetes, not the general population. So how can I go about calculation of sample size? If I use that data, you might feel that you are getting around, say, 150 or 160 patients. It may not be possible in this hospital. Maybe some patients also go to Vijayanagar hospital. Some patients come here. Some patients go to private hospitals. Am I right? It gets distributed all over, right? Then how to find out how many patients are to be used for my study or for your study? So, one criteria, that is where morning also I mentioned about, use your hospital data. How can I go about? So, I'll go to last year data, 2023 data. I'll look for how many diabetic patients have been treated here. I use that as a denominator. And among those diabetic patients treated in the last year, How many were treated for diabetic foot ulcers? That becomes a numerator. Total number of diabetic cases comes taken as a denominator. So numerator divided by denominator gives you proportion of patients, right, treated for diabetic foot ulcers in this hospital. That can be used for calculation of sample size. I'll tell you the formula later, but this is exactly how a concept of sampling technique is made use. So a sample is a representative part of the population. Representative part. Then how to choose these samples, for which firstly you must identify whether your population, target population particularly, I told you in the morning about target population. Your target population is a finite population or an infinite population, as well as your target population is a homogeneous population or heterogeneous population. I'll give you an example of heterogeneous population that should make you understand what I mean by homogeneous population. I was teaching this concept of sampling techniques to my medical students, so they were finding it difficult to understand. It was a sample of, it was a strength of only 50 students. MCA had got a restriction on our admissions for various reasons in one batch. So only 50 students were admitted out of 150 in our college in one particular year. So I divided those 3 batches into, 50 students into 3 batches. And our campus where I worked in Kempengoda Institute of Medical Science is run by Vakaliga Sangha. So therefore, we have varied courses offered there. We have medical, dental, pharmacy, physiotherapy, nursing, biotechnology as one discipline, engineering as a second discipline, humanities, BA, BCom, BBM, LLB as the other domain. Topic given to my students was awareness on HIV. So we developed some 15 questions, sent them to collect the data from all these students in 3 batches. After collecting the data, we analyzed it. I came to know that 93% of medical science students, means medical, dental, pharmacy, physiotherapy, what all I listed out, I made them into medical sciences. So they were aware to an extent of 93%. Engineering students were aware to the extent of 44%, whereas humanities students were aware only to the extent of 18%. We analyze the reason why this is so broad. Humanities students studied biology science till 10th standard only. Engineering, a few of them studied till pre-university, but those who did not want to pursue medical science, they dropped out biology at the 10th standard and took either electronics or computer science. That is where that 44% was identified. Medical students, you're all studying as a curriculum on HIV, so therefore it is 93%. Now look at there. My topic of interest, what I'm studying is HIV awareness, right? For that HIV awareness, this students' community is heterogeneous. If I take within humanities or within engineering or within medical science, it is homogeneous. That concept is very, very important to decide what type of sampling techniques I am supposed to choose. Coming to again selection of samples, we have basically 2 methods. One is probability sampling, the other one is non-probability sampling. Probability sampling means every sampling unit what you are choosing will have an equal chance of being selected. I'll give you an example. Let us say 30 persons are there in this hall. Among the 30, I want to choose 5 of you. 30 is a total. I want to choose 5 of you. Each one of you have a probability of 1 by 30 to be selected as the first sample. Correct? And most of the samplings are going to be sampling without replacement, meaning whichever the first sample drawn, I'm not going to replace it back. Otherwise, what happens, if I put it back, the same person name might be selected more than once. So that's why we go for sampling without replacement. Then, okay, first name is selected, not kept back. 29 remains, 29 remains, and in the remaining 29, each one of them have a chance of 1 by 29. So second one is selected. Like that, so 1 by 30, 1 by 29, 1 by 28, it goes on that way. Advantage of going for probability sampling is selection bias is completely prevented. You don't come across any type of bias that is committed in this selection process. Results are generalizable. Everybody will accept when you say that you have selected the samples based on probability method. Then other one is non-probability method. As the name itself says, we are not following any kind of probability technique. Under probability sampling method, we have four techniques. One is called as simple random sampling technique. Second is systematic random sampling technique. Third one is stratified random sampling technique. Fourth one is multi-stage random sampling technique. Under non-probability sampling, first is purposive or judgment sampling. Second is convenience sampling. Third one is quota sampling. And fourth one is snowball technique. The last two under probability as well as in non-probability, that is multi-stage sampling technique and snowball technique, are widely made use only for data to be collected in a large geographical area covering wide heterogeneous population. But in all other situations, we make use of the first three. Coming to simple random sampling technique, firstly, your target population should be finite and homogeneous. That is the first requirement. Finite and homogeneous. Because it is finite, you are able to prepare a list of all the individuals. That is required. Listing of all individuals in that finite target population is important, but homogeneity should not be forgotten. Then samples are selected one after the other. That means unit by unit. One at a time you are choosing. That's a meaning. By assigning equal probability, for which you can either make use of random number table. Any statistics books has a table called as random number table. You can make use of that. Your laptop, Excel also has a facility. Otherwise, your mobile also has a facility of an application called as random number generator. You can also make use of that random number generator. Okay, leave it, no problem. Yes. So that can also be made use. I don't think so. I have it. Let me see if I can. Just my other mobile. Yeah, let me download and show you. Okay. Okay, fine. Right. See, this is known as this logo. What you are seeing is known as random number generator. Blue color with that aroma. Suppose I want to choose, let us say, 80 as my sample size. So you are choosing between 1 to 80. Choosing between 1 to 80. I also mentioned no repeat. That means same number should not appear more than once. Got it? Now I must generate the numbers. So therefore, to generate the number between 1 to 80, this button, that blue button, I'm just supposed to press it. Look at there. The very first number generated is 77. The random number generated is not going to give you the numbers from 1 to 80. No. That is where it is called as arbitrary number. The very first number is 77. Second number happens to be 31. 31. The third number, look at there, 54, 46. Next is 6. See the way it fluctuates. If I go by this procedure, then there will be zero selection bias. Your results are not going to be suspected. Not going to be suspected because you followed a strict generation of random numbers. There is no either personal bias or selection bias involved. So therefore, this method is considered to be more valid. More valid. Okay, that is one part of it. Next is advantages and disadvantages. Where to use this? First of all, I am looking for finite population, homogeneous population. Therefore, this simple random sampling technique cannot be used in hospital-based studies. Why? I don't have a finite population. My population is unknown. How can I prepare a sampling frame? Sampling frame is possible to prepare only when there is a finite population. I can't do that. Right? Suppose, sir, I want to analyze data for the last 5 years, a retrospective case record analysis, and have, say, 500 cases in the span of 5 years. I can't analyze all the 500 cases. I want to choose a few of them. Okay, fine. You do the calculation of sample size. Let us say it comes out to be around 80. You want to choose only 80. But from, say, 2005 means, now let us say, from 2018 to 2023, 5 years you have taken, right? So all the cases, you number them from 2018 January till 2023 December, whichever the cases comes, you name them or number them as 1 to 500. Got it? Now, as I saw, the very first number was 77. So serial number 77 case will be selected as the first sample. Then 56, 44, 6, it goes that way. That is possible because it's a finite population. But when you want to do it prospectively, definitely simple random sampling technique is not an ideal technique at all. You should not use it. Then, sir, can I use any other sampling technique? For that, systematic sampling is ideal. So what is the systematic sampling technique? Again, you need to look for homogeneity. Homogeneity. Finite population is not there. It may be either huge population or an unknown population. If it is unknown population, based upon the previous year data, you project your capital N. It's possible to project, right? Okay, say suppose you have seen last year, you're doing tuberculosis, and last year 600 cases have been seen. Got it? This year also you might expect around plus or minus 600 cases. That becomes your capital N. Sample size, you based upon the prevalence of tuberculosis, you calculate the sample size. Let us say you need to choose 40 cases. So what I'm supposed to do is you start preparing a list from 1 to 600. You make a list of 1 to 600. Now what I'll do is I'll divide 60 by 40. That is called as sampling, or 60 by 50 I'll take it for easy division. How much it gives? 600 divided by 40. Okay, I'll take it as 40 only. If I take it 40, the sampling interval we call it. Are you able to follow me? Capital N is a population size, that is 600, divided by sample size small n, that is equal to 40. If I divide 60 by 40, it becomes 15. Now choose a number between 1 to 15. One number. Okay, fine. Never mind. I can also use currency note because I do not know what number is there printed on my currency note. It's random. It's random. Right? I'm supposed to choose between 1 to 15, right? 15 is a 2-digit number. That means you're supposed to read from right to left. First number is a unit place. Second number is the tens place. Sir, what is the number you tell me, sir? No. Between 1 to 15, the first 2 digits from right side. It is 4 and 0. 4 and 0, that means the serial number 4 will be chosen as first sample. Serial number 4. Maybe you are getting 12, you go according to that. But procedure is this. If I choose 4 as my first sample, that is the only sample which is going to be selected randomly. Unlike simple random sampling technique, where every sampling is selected at random. Subsequent samples are selected at an interval of 15. So that means if I choose 4 as my first sample, the second sample, I'm preparing the serial number right. So first 3 I'll leave it. Fourth one I'm choosing, picking up. Then 15 from there, that is 19. Isn't it? 19, right? Then the third sample will be another 15 from there. 19 plus 15 is 34. 34 is the next sample. Then 49. 49 goes in that order. If as she says it is 12, then 12 will be the first sample, and that is the only sample you are choosing randomly. The next one is add 15 for that, it becomes 27, 42, correct? Then 59 or so goes that way. That is possible in case of hospital-based studies. Systematically, you can do that. When the population is heterogeneous, then in that case, use of either simple random sampling technique or systematic random sampling technique, it results in underestimation or overestimation. What I mean is that awareness of 18% or awareness of 93% are likely to be occurred. So never use simple random sampling technique or systematic random sampling technique when they are heterogeneous. Be clear with that. Then, if the population is heterogeneous, divide that population into different stratum, means subgroups. In such a way, ensure homogeneity within each stratum. Homogeneity has to be ensured. Like I had made it as medical sciences as one stratum, engineering as another stratum, humanities as third stratum. In this case, selection of sample is little tricky. We have different population size. For example, in my study, what I noticed was Medical science, there were 2,000 students altogether. There were 2,000. Medical sciences, there were 2,000. Technical, there were 6,000. And humanities, there were only 1,000 students. Totally, capital N is equal to 9,000. When we calculated the sample size, it came out to be 1,500. You have two options. Either divide this 1,500 equally among all the three groups, but it gives an irregular representation. Out of 1,000, if you are choosing 500, it gives you an alternative every person has selected. In that case, this is going to be affected. Because out of 6,000, 500 will not give a proper representation. So therefore, we follow what is called as probability proportional to population size. Population size. That means I am multiplying this by 1,500 divided by 9,000, right? This gives you 333 as the sample size. Again, do the same thing for all the three. It gives you 1,000 here, and in this case, it is 167. All put together, it becomes 500, 1,500. So this is known as probability proportional to population size, or otherwise popularly known as PPPS, a widely used, well accepted sampling design whenever you have a heterogeneous population. And since you have divided this heterogeneous population into different stratum, within each stratum there is homogeneity. That is the way the population is divided. So therefore, one is finiteness, second is homogeneity. Hence, you can make use of simple random sampling technique within each stratum. That's the best way when you have a heterogeneous population. All other problems are taken care by doing this. Coming to non-probability sampling technique, among the three techniques, first one is purposive or judgment sampling. It is purely based upon your inclusion and exclusion criteria. That is it. But any of these non-probability sampling technique, results are not generalizable. That point you must remember. It's not generalizable. We treat that data only as a baseline data. Convenient sampling is convenient to the researcher we are choosing it. Suppose, say, you want to do a school health examination. You need not go from here to hospital to do your school health examination if you go by, right, random selection. Choose a school near to your vicinity and carry out the study. That is what I meant by convenient sampling. And finally, the other one, that is quota sampling. It is exactly ditto of stratified sampling. Purposive and convenient should be only based upon homogeneity. When there is heterogeneity, you just adopt the quota sampling. There is no probability. There's the only difference. Fine? Yeah, this is what we follow in sampling techniques. Are you giving the break for them, sir? 10 minutes? Yeah, I think we'll give a break for 10 minutes because I'm starting a new topic, that is testing of hypothesis. Yeah, that's why. Let them come back with the 5 minutes break. Hello. Okay. Look at this example. It is taken from Ayurveda only. Efficacy of Ayurvedic formulation in rheumatoid arthritis. A double-blind, placebo-controlled crossover design. That is where I mentioned in the morning that even in Ayurveda also they are making use of crossover design, but it is randomized, double-blind, placebo-control. In the sense, it is an RCT extended to a crossover design. The study design I have mentioned here, placebo control, and the Ayurvedic indigenous formulation contains. This is a study done in one of the Western, North India Medical College. So Withania somnifera, whatever that is given. Look at there. First and foremost is what you need to identify is outcome measure. Outcome measure. Look at there. They have identified 3 outcome measures. One is significantly greater relief in pain. How do you measure pain? Tell me, how do you measure? I think boys are not answering, right? Please tell me. Yes. Second row, first boy. How do you measure pain? Hey, no, I'm talking about how do you measure pain? Pain measurement. Pain measurement. How do you measure? Say, if you choose 30 patients to be treated with Ayurvedic preparation, another 30 patients placebo. Placebo, ethically, that will decide later. But suppose if this is the case, how are you going to measure the pain? Please, these are all very important basic things. Pain is measured using 2 different scales. One is called as visual analog scale. Other one is numerical pain rate scale. Please sit down. Okay. Now, decreased morning stiffness is the other measure. Decreased morning stiffness. Third is decreased in rigid articular index and joint score. This is a study conducted by orthopedicians, Ayurvedic doctors. Now, suppose you want to prove that Ayurvedic preparation, indigenous formulation, okay, for treating this rheumatoid arthritis is a better effective drug compared to placebo group. How to prove this? This one example is good enough for me to discuss throughout. Tell me, how do you prove this? So this is where statistical knowledge comes into picture. First is, we need to go with formulation of an hypothesis. Then what is hypothesis? Hypothesis is a statement which is yet to be proved. A statement which is not yet proved is not an assumption. People think that hypothesis is an assumption, but don't call it as an assumption. It is a statement which is yet to be proved. Got it? So, how to formulate the hypothesis? There are two types of hypothesis. One is called as null hypothesis, other one is called as alternative hypothesis. Then what is this null hypothesis? Null hypothesis is an hypothesis of no difference or neutral. No difference or neutral. Pen. ಅದು ಸ್ವಲ್ಪ ಬರೀತಾ ಇಲ್ಲ ಇವ್ರೆ? ತಗೊಂಬನ್ನಿ ಪ್ಲೀಸ್. So, first and foremost, to describe the null and alternative hypothesis, null hypothesis is denoted by H0, alternative hypothesis is denoted by H1. Got it? To formulate, I told you this is an hypothesis of no difference or neutral hypothesis. This is an hypothesis which you are, as a researcher, is intended to prove it. Be clear. We need the help of this hypothesis to prove this H1. Now, to formulate the hypothesis, the first step is what variable are you measuring? It should start with identification of the variable that is to be measured. So, I have given the outcome measure. How do you measure them? What variable are you using to measure pain relief? How do you measure? Quantitative or qualitative? Quantitative. I told you, VAS is a numerically measured scale. It is a 10-point scale. 0 to 10. 0 is no pain. 10 is severe pain. So also numerical pain rate scale, otherwise called as NPRS, numerical pain rate scale. That is also 10-point scale. The only difference is in VAS we give a scale, clearly marked scale. Okay, on that the patient has to put a pencil dot how much pain they have perceived. It is a subjective scale. What is my pain perception is different from your pain perception. So therefore, they measure it also in terms of decimals. That is VAS. Numerical pain rate scale is a clear cut between 0 to 10, no decimals. But measured by numbers, right? Yes or no? Measured by numbers. Keep that in mind. What about decreased morning stiffness? How do you measure stiffness? That is also measured by a scale you must identify. Stiffness is also measured by a scale. Identify. Otherwise, if you are telling, sir, that can be measured by categorical, you tell me how categorical it is measured. But I feel that it is measured by scale only. Scale. Then last one, no doubt it is numerical. Correct? Look at there. Ritchie articular index and joint score is a numerical scale. So let us take that all the three scales are measured by numbers. Got it? Now how to formulate this as an hypothesis? So first is when you are measuring the variable as quantitative variable, the first thought that should come to your mind should be calculation of mean and standard deviation. That should be the first thing. The rest we'll see later. Whether normality, no normality, that we'll take it up later. But the first and foremost is that quantitative variable, your idea should first go towards calculation of mean and standard deviation. So that means you are going to formulate your hypothesis based on mean only. So I have three hypotheses here. First one is related to VAS or pain relief. I'll put it as pain relief. Pain relief, VAS. I'll take it as VAS. So VAS is a numerical scale, right? Therefore, I'll write mu1 equals mu2, where mu1 is the mean pain score of patients, rheumatoid arthritis patients treated with, right, Ayurvedic formulation. Understand? Mu1 is a mean pain score of rheumatoid arthritis patients treated with Ayurvedic formulation. Mu2 is a mean pain score of patients treated with a placebo. Very, very important step to go further. Clear or not clear? Why I have taken equal to? Because neutral. I have stated that null hypothesis is an hypothesis of no difference or neutral. Therefore, it must always be equal to. That is it. Second, now I should think whether my alternative should be less than, three possibility. Either it should be less than or more than or not equal to. Three possibilities arises. So which one to be chosen here? Do you expect, think like this, it's a common thing that a common sense can tell us how to formulate this. Do you expect a rheumatoid arthritis patient suffering from rheumatoid arthritis should get more pain or less pain because of your treatment? Less pain, right? I think this girl is still confused. Tell me, what is your doubt? No. Did you understand my question? Did you understand my question? When you are treating with the Ayurvedic formulation, do you expect the pain score to be less or more? Less, right? Then how do you write the hypothesis? It should be mu1 less than mu2. Am I right or not? The Ayurvedic drug formulation is considered to be effective in bringing down rheumatoid arthritis pain if the mean pain score is less. It's a general concept. Less than that of placebo. Got it? Even if I replace placebo by some other standard control, the statement is not going to change. Follow? So therefore, I want this to be mu1 less than mu2. This is for pain relief. Suppose morning stiffness. Sir said it is going to be measured by scale. Just hypothetically, I'll tell you. Hypothetically. Okay. You measure by scale. Okay, I'll just go by this. Morning stiffness, I just made a small change to introduce another concept. Morning stiffness, I'll put it this way, present, absent. Shall we go by that? No, I don't want to go by measuring by scale, right? I just want to consider morning stiffness, whether it's present or absent. Clear to all of you? What variable are you using for measuring this stiffness, present, absent? Just wait. Whatever I taught in the morning is completely evaporated. Qualitative variable. Present, absent is a qualitative variable. The moment you say qualitative variable, what is a measure? Very first measure. Proportion. Proportion. Right? Isn't it? So I'll put it this way. P1 is a proportion of patients who had morning stiffness, those treated with Ayurvedic formulation. Clear to you? Every patient, say 30 patients in each group I've taken. Every patient I classify it as stiffness, present, absent. Got it? What is the proportion of patients showing stiffness means those who are showing presence of stiffness, isn't it? Let us say for Ayurvedic formulation, out of 30 patients, say 6 patients showed morning stiffness. So what's the proportion? 6 by 30. difference between mean difference from pre to post test may be may be different, not may not be, sorry, this is may not be correct, may be same post test we talk in terms of application of statistical test. Only statistical test will be able to tell whether donepezil is an effective drug or not an effective drug. And you know what? In all these examples, the statistical test what we are going to use is students T test. Student T test. For the first one, rheumatoid arthritis case, you are going to apply unpaired T test because both observations are independent. Because they are independent, we call it as unpaired T test. Understand? And the second example of COVID, where it's a dependent observation or related observation, therefore, we are going to apply paired T test. There's a test called as pair t-test, only one group. But either application of unpaired t-test or paired t-test, some assumptions are very, very important. This paired t-test or unpaired t-test is considered as a parametric test. Because why it is called as parameter? We are addressing the test based on mean, mu. Mu is a parameter. Therefore, we are addressing in the form of parametric test. This test can be applied only if your samples are drawn from normal population, or else there is a test called as Kolmogorov-Smirnov test. Kolmogorov. Kolmogorov dash Smirnov. SMIRNOV. Smirnov test. So we use this test. This test is going to tell us whether the data is normally distributed or not. If it is normally distributed, we continue to apply unpaired t-test. I'll show you an example. If not normally distributed, just for the information's sake, we have to apply what is called as Mann-Whitney, M-A-N-N. We call it as actually Mann-Whitney. It's not man, it is Mann. Mann-Whitney U test. Whitney is W-H-I-T-N-E-Y. Mann-Whitney, capital U test. The difference is this. In parametric test, your inference is based on mean. Whereas in non-parametric test, your inference is going to be based on median. That is a major difference. You draw the inference based on median in case of non-parametric, whereas in parametric test, it is based on mean. Got it? Now, same thing is applicable to students' t-test, pair t-test. There, the assumption is you take the difference between two observations, observation 1 and observation 2. You're making two observations, right? Before and after. Take the difference. If the difference in the observations are normally distributed, we continue to apply pair t-test. Otherwise, we call it as Wilcoxon sign rank test. Wilcoxon sign rank test. The test what we are going to apply is called as Wilcoxon sign rank. Wilcoxon. Wilcoxon sign rank test. But this is fine. These t-test unpaired. This is again unpaired t-test. Here also unpaired t-test, and this is by paired t-test. Paired t-test. Then we have one more here. What about this? So proportion, not measured by numbers. So therefore, here we use Z test. Z test. So Z is nothing but standard normal variable. I told you, Z is equal to X minus mu by sigma. So based upon the normal distribution, we apply that Z test for testing the difference between two proportions, whether the proportion of stiffness due to Ayurvedic formulation is less than the proportion of stiffness due to placebo. You have to apply. Both are independent. Both are independent, right? So therefore, we apply this Z test. I have many more examples which I have collected, like randomized placebo controlled pilot clinical trial on the efficacy of Ayurvedic treatment regime, etc. So sir, they are using RCT even in your discipline, right? Good. RCT as well as crossover design. Okay, I'll give you an example. Listen carefully the story. Listen carefully the story. There is an involvement of something which we need to decide. A police person has arrested a criminal, suspected criminal, and produced before the jury. The suspected criminal is generally in legal language, they call them as defendant person. So now the jury has to decide whether this defendant person innocent or guilty. So the jury formulated the null hypothesis that the defendant person may be innocent because unless otherwise proved, the person cannot be called as guilty. So the neutral statement is person may be innocent. What they are intended to prove that the person may be guilty. So question is, how do the jury decide whether the defendant person innocent or guilty? Anyway, the procedure is known. In the court of law, one advocate would be arguing in favor of the defendant person, other one against the defendant person. The decision is made based only on the evidences, not by any numbers. Please remember that point. Evidences are the only one which direct the jury to make the decision. Correct? So in that case, let us say the court proceeding is over. That means the advocates, favor and against, they have collected the evidences and through their argument presented before the jury. Maybe it has taken some months or days, whatever it is, but the court proceeding is completed. There are evidences now with the jury. Fine. Now it is up to the jury to pass the decision. Now tell me, think and tell me, how many possible decisions the jury can make? How many possible decisions the jury can make here? 2. I'm talking about possible. How many possible decisions the jury can make? Yes. Anybody has a different answer? Between 1 and 3 they are telling. Anybody has more? Totally there are 4 possible decisions. 4 possible decisions. It goes this way. Let me say here H0 innocent, guilty and jury decision innocent, guilty, correct? Don't you think there are 4 possible decisions the jury can take? Suppose let us go by this. Is it visible? Okay. Suppose let us say the defendant person has not committed the crime, really is an innocent person, is really an innocent person. Maybe that person was standing at the site of the crime. When police arrived there, he probably started behaving suspiciously. That would have made the police to arrest him and produce before the jury. Now, the advocate who was arguing in favor of the defendant person would have provided sufficient evidences to prove his innocence. I told you, jury decision is based only on the evidences. If sufficient evidences are provided proving him innocence, naturally the jury left with no other choice than declaring the real innocent person as an innocent person, which will be considered as a correct decision. But if the advocate was not able to collect enough evidences to support his argument, whereas the opponent lawyer would have been by hook or crook collected more evidences to prove his guiltiness, a real innocent person, due to lack of sufficient evidences to prove his innocence and more evidences towards guiltiness, the jury would declare him as guilty. So the innocent person is declared as guilty, which is error in the decision. Agree or not? Same thing is applicable with these two cases. With these two cases. So, the right mark we need not worry. An innocent person declared as innocent, a guilty person declared as guilty, we have no issue at all. The issue arises, what if an innocent person is branded as guilty? Social stigma. More serious, right? Social stigma. And it also be put behind the bars. Correct? He will put behind the bars. So it's a serious error, right? And on the other hand, a person is guilty but left freed. He continued to do the same crime again and again. Both are serious errors. Both are serious errors. So therefore, this kind of error is also possible to commit in our research. Also possible to commit in our research. In which case, we need to be very careful. So therefore, what are the different type of errors which we are going to commit in our research? There are also same 4 possible errors. Yeah. So this is the one which I wanted to show you. Right? Look at there. The error what I had shown, the first E, is known as type 1 error. An innocent person declared guilty is called as type 1 person, type 1 error. Here, a true hypothesis, that means a true hypothesis means, let us say, mu1 equals mu2 is a true hypothesis. That means, right, either you give placebo or your Ayurvedic formulation, the pain relief may be same. You got it? If whether you treat through an Ayurvedic formulation or through a placebo, if the effect is same, this becomes true hypothesis. If this is true, you also conduct a study based upon the data analysis. You are supposed to decide whether the hypothesis is going to be accepted or rejected. So for that, we use t-test for decision. Already told you, we are using t-test for decision. Based upon the t-test, if the data suggests you that you are accepting a true null hypothesis, we consider this as a correct decision. But hypothesis is true, h1, h0, mean 1 is equal to mean 2 is correct. But however, due to lack of proper data. Morning I gave an example. You remember that Novo Nordisk company example? Wrong data, right? A true hypothesis was rejected. Alternative was rejected. Got it? So in such cases, this is known as type 1 error. Other one is called as type 2 error. In research, we don't want to commit either type 1 error or type 2 error. We want to make free of it. But it is a data, not your whims and fancy, where you are making that kind of an error. So again, this type 1 and type 2 error we classify into two, where the causes are possible to identify or recognize, thereby you are able to control it. Okay, I'll give one more example. Maybe you are traveling from your residence to this place by auto rickshaw. If they are putting the meter, let us assume that they put the meter and the fare happens to be 70 rupees from your residence to this place regularly, one side. For instance, someday, if the auto meter shows 80 rupees, regular fare is 70, but someday, if the auto meter shows 80 rupees, you become alert. How come regularly I'm paying 70 rupees today, your meter is showing 80 rupees? When you analyze the causes, see, always remember, any mechanical or electrical or electronic devices are supposed to be subjected for calibration. Regular calibration is always required. Perhaps that auto meter was not calibrated regularly. Thereby, it is showing 10 rupees excess fare. That could have been prevented, right? By getting a calibration done, that could have been prevented. It is called as systematic error or bias. Bias means where the causes are possible to identify and rectify it. We need not worry about that because anyway you can correct it. Rather, if the auto fare shows around 71 rupees or 72 rupees, it is difficult to guess. Suppose some traffic jam is there, correct? There might be some deviation in the route. Police might deviate you, and thereby 1 or 2 rupees would have been increased. That will not happen all the time, isn't it? Our driver may not know the route, not the same driver. Driver may not know the route, or he feels that he is going to take you through a shortcut, but that shortcut would have been a long cut. Thereby, that 1 or 2 rupees is likely to be increased. In which case, we call that as random error. In random error, causes are not possible to identify. When it happens, when it doesn't happen, we cannot guess it. So therefore, in research also, this type 1 and type 2 error, we consider them as random errors. Morning I gave the example of 120 typed as 0, 1200, 12,000. That is systematic errors. That could have been rectified if they had cleaned the data much before. Whereas, if in place of 120, if they had typed it as 122 or 123, it was quite difficult to get it, recognize it. Correct? See, the very big number or very small number, it was possible for you to identify it. Whereas 120 typed as 122 or 123, we would not have recognized it. That is where I call it as random error. Random errors are not possible to identify. We should accept them as a part of our research system. Therefore, they are called as, right, alpha error and beta error. Alpha error is probability of rejecting a true null hypothesis. Probability of rejecting a true null hypothesis. And beta error is a probability of accepting a false null hypothesis. Look at there. Type 1 error is your null hypothesis is false, but you are accepting it. Understand? Your statement is false. That is, mu1 is equal to mu2 is false. If that is false, alternative will show true, right? Isn't it? But that false hypothesis, if you are accepting, you are committing an error, and the chance involved in committing that type of an error, we call it as beta error. Whereas, when the hypothesis is really true, but you are rejecting it, the probability of that is called as alpha error. You know what? In clinical research, we have one more. I don't know whether I have it or not. This is more important in clinical research. 1 minus beta, we refer it as power of the study. So what is this power of the study? How do you go with this interpretation for power of the study? Look at here. What is your null hypothesis? False. Correct? Look at here. Your null hypothesis statement is false. If null hypothesis is false, alternative must be true. They are opposite, they are complementary to each other. So therefore, if null hypothesis is false and you are rejecting that null hypothesis, the other implication is your alternative is true and you are accepting it. That is what we call it as power of the study. It is very, very important for us in the research because power of the study increases chances of accepting a true alternative hypothesis or research hypothesis. That is where in the calculation of sample size, both alpha and beta are taken into consideration. So let us move through the sample size calculation quickly so that you'll also get an idea how to calculate sample size. And this is one other study, one other slide. Now, I said alpha and beta are inevitable devils. We cannot avoid it. We have to accept them as part of our research system. But up to what level shall I allow? In that case, alpha is always fixed at 5% and beta is reduced or minimized. If beta is minimized, 1 minus beta is maximized. For example, by fixing alpha at 5%, if I take beta is equal to 10%, I reduce beta to 10%. What about 1 minus 10% means 0.1, right? 0.1. Then what about 1 minus beta? 0.9. In terms of percentage, 90%. That is where in most of the research, they say that I have 90% power. 90% power means I am ensuring 90% chances of accepting a true research hypothesis. So therefore, in that context, so alternative hypothesis with high power is always preferred. Okay, fine. Now, the sample size calculation is mainly based on these things. The data contains, observed data contains some truth, some bias. Bias, I said, systematic error and random error. Truth is all right, but bias we have to control. That can be taken care, not the random error. And these are the following requirements. Main research question. What is your main research question? Is it that you are looking for efficacy? Is it that you are looking for complications or recurrence? What is that you are looking for is to be taken as main part of it. Then what is the main outcome measure? I had listed out 3 outcome measures in the example of osteoarthritis, sorry, what is that? Rheumatoid arthritis, right? Among them, which one is going to be first? Is the pain, then your sample size calculation is also based on pain assessment. And statistical and clinical assumptions. Statistical assumptions, I told you. I assume that the samples are drawn from normal population. That is my statistical assumptions. Similarly, also have clinical assumptions, right? Clinical assumptions are stated in the form of your inclusion and exclusion criteria. Got it? You state the inclusion exclusion criteria, right? That is your assumption. So therefore, I need to go with both statistical and clinical assumptions. Lastly, there are some study constraints. Study constraints like financial matters. I told you in the morning. See, at least compared to dental students, medical students are better. Maybe compared to medical students, you are all better because you are working in government Ayurvedic medical college, where your investment is very minimal. Correct. I'm very sure because I have seen that in a government homeopathy medical college where their investment is very, very minimal. Since all the investigations are done in the hospital itself, except a very few. Like for example, in one of the case, X-ray was taken exposed by the radiologist here, radiologist technician. Hospital, they had a technician, they expose the radios, X-rays. But who has to give the report? She is from a Chikmagalur girl. Then, while discussing in the ethics committee, I'm also an ethics committee member for Government Ayurvedic Medical College. We had a discussion. She wanted to go and pay some money and get the reporting done because reporting has to be given, right? X-ray is taken, somebody has to give the report. She went and inquired with some radiologists. They said that per X-ray, they are going to charge 500 rupees for giving the report. Probably exposure and reporting will also cost 500 rupees, but that radiologist, he demanded 500 rupees. While talking, that girl said, I just inquired, from where are you coming? She said, sir, I am from Chikmagalur. My mother is also a homeopathic doctor. That was not interesting for me. Chikmagalur was interesting for me. Reason, my student is practicing as a radiologist in Chikmagalur town itself. Immediately I took the phone and called him. I will send one of my students who is also from your place. Her mother is practicing homeopathy in Chikmagalur. I know her, sir, she said. Problem solved. Free reporting was done. Right? So, study was completed. Sometimes it happens. Somewhere in some corner, help comes. But not in case of dental. In dental, let me tell you, many times they get an investigation done or a test done where each test costs around 3,000 rupees or 3,500 rupees. There is one called as finite element estimation, done only in Indian science. 2 times it was supposed to be done. 7,000 rupees approximately. 30 samples. 30 samples. Right? 30 into 7,000. 2,10,000. Now this happened with one of the girl from this Raichur. A daughter of a small scale farmer. He had around 3 acres of land. To make her daughter a dentist, post-graduation, he sold 1 acre of land and sent her to Bangalore. When I calculated the sample size, it came out to 30 plus 7,000. She started crying. sir, I'll discontinue my studies if they insist me in doing this study because I cannot ask my father to sell 1 more acre of land. No, it was a reality which we need to accept it. But unfortunately, sir, with my due respect to our guides, guide was hell bent upon getting that study done because she started saying that no, this is a first of its kind, and if we do this study, we can always go with a good publication. I got annoyed. I said, Madam, are you ready to pay that money? She said, no, I have my husband, my daughter, my son, my in-laws, I have to take care of them. I could not control my anger. I said, hell with your study. You cannot make the student to pay because 2,10,000 is not an ordinary amount. I told principal also, this is unethical. Being an ethics committee member, this is one of the dental college. Being an ethics committee member, I take a first objection. See, guide is not ready to pay. Poor student is supposed to pay. We said nothing doing. Finally, we dropped the study. So, see, it comes to 2,10,000 plus some other expenditure like getting the printing done and so many things. 2.5 lakh is not an easy joke. So, therefore, in such cases, right, the study constraint comes into our rescue. I'll tell you how. So, sample size calculation is based only on estimation or testing. Meaning, estimation means it's a descriptive study only. No comparison, just mere description. You simply estimate and leave it over there. Only one group. In descriptive studies, there will be only one group. That's it. Your sample size required is very small. Whether it's an experimental study or field study, means survey methodology, it is simple, easy. But if this is a testing of hypothesis, the comparison comes into picture, the p-value comes into picture, hypothesis testing, the whole lot of things comes into picture. Thereby, this requires more number of samples possibly because 2 groups are there or more than 2 groups are there. So, this requires more number of samples, right? And look at there. This one example, one topic I did not tell you. If your alternative is less than or more than, when you write the alternative hypothesis as less than or more than, it is called as directional hypothesis. Otherwise also referred as one tail. One tail means, we have seen the normal distribution, right? The tapering ends are called as tails. Either it will be in the left tail or it's in the right tail. Less than is in the left tail. More than is in the right tail. In such cases, sample size calculation requires less. One tail requires less number of samples, and 2 tail means it might be there in both the tails. So therefore, you require more number of samples. So that is also important to decide whether you require to be 1 tail or 2 tail tests. Alpha and beta. Generally, I said alpha must be fixed at 5%. Generally. If you say, no sir, 5% is a very big number, I want to be more accurate, so I'll go for 1%. Your sample size proportionately increases. 5% is the maximum limit which we take. You need some sample size. If by eventuality would like to achieve more accuracy by reducing alpha value, then automatically your sample size increases. Lastly, we have power of the study also, where if beta is less, beta less means I've taken 10%, right? If you say, no, sir, I'll take 5%, automatically power increases. Along with that, your sample size also increases. Imagine alpha is 1%, sorry, not 1%, 0.01, 0.01. Beta is 0.05, it becomes unmanageable. Be careful. Be careful. We should always chew what you can bite. Meaning, I'm talking about feasibility. Once again, I'll go back to the same topic. Feasibility. Morning I told you, no. If I go with a big sample size, you should be able to get in your hospital, right? That many number of patients, you are supposed to get it. When there are no such large number of patients, then where are you going to search for those patients? So all these are considered as study constraints. Yes. If at all you are doing a survey, and one other point which I want to tell you in the morning itself, but somehow it skipped out of my mind, particularly in the study design for a hospital-based study. Either students are using this or PGs are going to do the study. Hospital-based study, never ever use cross-sectional study. Cross-sectional studies are also called as community-based studies. Population-based studies is not based on hospital data. Hospital data has a deficiency, and cross-sectional studies are also called as prevalence studies. Then what is prevalence? Prevalence is defined as number of old and new cases, both old and new cases in a given population in a given time divided by population at risk, and should be well-defined population. Not any population. It should be well-defined population at risk. If you are taking the cases here in your hospital, you have a deficiency of cases. Government hospital, I'm not just looking down. Generally, for government hospitals, upper class people are not coming here. Am I right, sir? Even upper middle class also may not come here. Maybe at the most middle class, lower middle and lower class patients are coming here. The two strata of the society is deficient in your data. Got it? Then how do you calculate the prevalence? Prevalence should represent the whole population as a cross section, which is not possible. And therefore, never use prevalence as a term in your title, never use cross section. So these two must be avoided. So in that context, now coming to this, when you are using P as a parameter, it need not be proportion, it could even be prevalence. This is a formula we are using it if it is a survey methodology or only observational study. I repeat once more. Even in the hospital-based study, this formula can be made use provided it is going to be only an observational study. Got it? Observational study. Only for that, this alpha is nothing but, I told you, alpha is nothing but probability of type 1 error. We take it as usually 0.05. That Z alpha by 2 value, total value is chosen from Z table. Z table. P is the proportion of prevalence or prevalence of a disease. Q is 1 minus of the prevalence, that is no disease. And D is the one which comes to our help in adjusting sample size. If I take D is equal to 0.1, or 10%, it is an acceptable standard value, right? Now, I'll demonstrate. I'll demonstrate through an example instead of going for a hypothetical, theoretical example. Let me say this example. From a pilot study, it was reported that among headache patients, 28% had vascular headache. 28% had vascular headache. Then it was decided to have 95% confidence. Alpha is 0.05, right? 1 minus alpha is called as confidence. So therefore, 0.05, what is 1 minus 0.05? 0.95. Multiplied by 100 gives you 95%. So 95% confidence and 10% desired precision. This D, they have taken as 10%. Got it? This value, when alpha is equal to 0.05, this entire thing, if not square, Z alpha by 2 will be 1.96. Always. It's a fixed value. It's not that if I do the calculation in Bellary, it is 1.96. In Bangalore, it differs. No. It's a statistical measure, a constant value, 1.96. P is 0.28. 28% is 0.28. 1 minus P is 0.72. Denominator, I have taken it as 0.1 because it is 10%. With this calculation, suppose, say, I got the value as 77. Got the value as 77, maybe rounded up to 80. You may say, so sir, it's too difficult to get, right? The vascular headache in our hospital, I can't get 80 cases. Is it possible to reduce the sample size? Yes, I have your suggestion. Instead of using D is equal to 0.1, you take D is equal to 0.15. Tell me how much you get. Do that calculation quickly, somebody. I told you no. 1.96 square becomes 3.8416. You need not square it. Just take it as 3.8416 multiplied by 0.28, you write. You just do it with 0.28 multiplied by 0.72 divided by 0.15 square is nothing but 0.0225. Tell me how much you get. So 3.8416 multiplied by 0.28 multiplied by 0.72 divided by 0.0225, I get 35 cases. From 77, I'm able to reduce to, I don't go beyond 15%. It's not advisable. It is advisable when it is going to be a very rare disease like Alzheimer's disease. Even getting 34 cases of Alzheimer's is very difficult, right? Isn't it? In such case, I'll divide by 0.2. Is a 0.15. I'll go by 0.2. So let us see how much I get. So divide by 0.04. Look at there. I'm getting 20 cases. Manageable. So this is where the study constraint can be made use as a weapon, either to increase. Suppose, let us say, sir, we are getting plenty of cases in our hospital, and therefore my professor says the sample size of 77 is very small. He says he asked me to increase the sample size. Then, in that case, I am neither going to divide by 0.1 nor 0.15 because higher the value, sample size reduces. Instead of 0.1, I'll reduce that value, take it as 0.05. 0.05 square becomes 0.0025, and that gives you, oh sorry, I made a mistake. Wait. 3 multiplied by 0.28 multiplied by 0.72 divided by 0.00. Look at here, I'm getting 310 cases. 310. So the issue here is, depending upon your requirement, you must choose the denominator. But sincere advice, never go for 0.2. Very rare. The disease itself is very rare. You're not getting many cases. Yes, sir. You can go for that. Give justification. Say that this is a rare condition, a rare disease, and not many cases are available in our setting. So therefore, we have used it as a 0.2 as a value of D. This is for general population. Survey methodology. I'll show one formula for clinical trials. In clinical trials, yes, this is a formula we are using it. This is a formula where you must bring in, loop in power of the study. It has to be. Any clinical trial, we must go with power of the study. Got it? So with that, you do the same calculation. I'll show you the calculation for the same disease, right? Only thing is, if I go for 90%, the power increases, sample size also increases. Okay, so this is the way. This is going to be 80%. Alpha is always remaining as constant. When you substitute, you are going to get 47 per group. Clinical trial is not for the whole. It is per group you are calculating. 47 rounded up to 50. That means per group you require 50 patients. So this is how the sample size calculation will be done. So how much time can I use? How much? I need to discuss about testing of hypothesis. Still some more tests are there. If you want, you can take 5 minutes break and come back. Just 5 minutes break and come back, right? I'll briefly tell you about t-test. I'll demonstrate on t-test, ANOVA and chi-square. At least that much I should be able to tell you. Come back soon, come back soon. Because you undergraduate ಹೋಗಿದ್ರೆ ಹೇಗೆ 5 o'clock ಆಯ್ತು PGs ಬೇಕು ಇರಲಿ ಬಿಡಿ ಅವರು ಅಂತ ಸರಿ ಓಕೆ So then come back quickly, 5 minutes break. We'll continue. ಕೊಡಿ ಮಾಡ್ತೀನಿ ಓಕೆ ಶೂರ್ ನನಗೂ ಒಂದು ಬೇಕ್ರಿ ಸರ್ಟಿಫಿಕೇಟ್ ಹೌದಾ ಓಕೆ
ಅಡ್ರೆಸ್ ಕೊಟ್ಟಿದ್ರಲ್ಲ ದಯಾನಂದ ಸಾಗರ್ ಕಾಲೇಜ್ ಆಫ್ ಡೆಂಟಲ್ ಸೈನ್ಸಸ್. ಅದೇನು ಅಡ್ರೆಸ್ ಇದೆ ಅದನ್ನು
Okay, let us start. So now I'll come back to the test I was discussing. The test I was discussing. Okay. Okay. So let us take students T test. The student T test is of two types. Why student T test? First point. If mean is your variable, I mean parameter. If mean is your parameter, the only test that is suggested is students T test, because the T distribution, probability distribution, T distribution is based on mean value. That is why it's called as students T test for testing the mean of a population. And the second one is pair T test, as I said. First, let us take a difference between two means, two independent population, right? Rheumatoid arthritis, treated with Ayurvedic formulation. Other one is, it may be even controlled drug or placebo. Let us go by that. Then these assumptions are very, very important. That should not be violated. See, this is a natural one. Population variance should be unknown is a fact because we do not know population itself. When we do not know the population, naturally we do not know the variance, right? But that's quite natural. But this is more important. If the data follows normal distribution, only then you can continue to apply t-test. There is one restriction on sample size. Generally, we expect that sample size should be less than 30. But however, even for more than 30, even some statistical softwares are also developed only based on the t-test. So therefore, when it comes to mean, there is no other test than t-test, provided this is fulfilled. That you please remember. If this is fulfilled, we go with application of t-test. And of course, independent group, the two groups are independent. Don't you think that Ayurvedic formulation and placebo are independent group? There is no relation, right? Yeah. You don't worry about all this procedure and mathematical concepts. This I've already told you. This part I've told you how to write a hypothesis depending upon what you are intended. This is the one we are going to use it for calculation of t, but that is not important for you since, right, you are making use of software for calculation of all these things. So you need not worry about it, formula. But procedure, you please try to understand. I have one example where I must show it as wait. I think I have an example. No, not this one. I think this one. Correct. Now look at this. 10 regular uses of oral contraceptives was studied to determine if cholesterol levels in such women are significantly different from those of 10 non-users. The mean cholesterol level was found to be 8.96 millimole per liter and 5.74 millimole per liter for users and non-users. Their respective standard deviations are also given. We need the standard deviation. Say, when you look at the formula, it contains mean and standard deviation. I also told initially itself, for any quantitatively measured data, you must compute mean and standard deviation with an assumption that your data follows normal distribution. So let us find out. Look at the way I have stated the hypothesis. I have no idea whether the mean cholesterol is more in case of users than non-users. That is why I have taken two-tailed hypothesis. I need to establish whether the difference exists or not. I need to first establish it. So therefore, the mean cholesterol levels of users and non-users of contraceptives may be same. Alternative, I have no clear idea, hence it is taken as may be different. May be different means it is not equal to. So, calculated value is 2.301. Using that formula, you need not worry about the formula, but the calculated value is 2.301. We make use of this value 2.301 and find out the p-value. Finding p-value, we refer to some statistical table. Right? Then what is this p-value? I'll tell you what exactly I am referring to, the concept of p-value. Look at here. At 5% alpha, 5% alpha. 1.734 is a critical value taken from the T table. From T table, the value of alpha, the T happens to be 1.734. The usual procedure is when you compute the value, T value, if that T value happens to be, I'll take up that example first. Yeah. Look at this. This T value, no, wait a minute. What's happening? Okay. See, look at here. This value is obtained from T table, just like Z table morning I showed, like that. We also have a T table. When the alpha, if you take it as 5%, this critical value is taken from T table happens to be 1.734. The decision criteria is this. If this calculated value more than this critical value, are you following? This is taken from T table. If this calculated value more than this critical value, you are supposed to reject the null hypothesis. So what is our null hypothesis? Mean 1 is equal to mean 2. That hypothesis is rejected. Implies you are accepting alternative hypothesis. Null hypothesis rejected and alternative is accepted. So what is that alternative? There may be difference between the users and non-users regarding the cholesterol levels. But suppose instead of 5% of alpha, if I change it over to 1%, earlier I had taken 5%. Now I am taking 1%. If I take 1%, the critical value is going to be 2.552. Rejection criteria is if it is greater than, we reject null hypothesis. Less than, you are supposed to accept the null hypothesis. We are into controversy now. At one level, 5%, you are rejecting it, and at 1%, you are accepting it. See, in research, you cannot draw this kind of an inference. So I'll accept the null hypothesis at 1% and reject at 5%. He's not a good researcher. Then what is to be done in this case? It is at this point we are supposed to calculate that so-called magic number p-value. P-value is the attained level of significance or calculated level of significance directly from the data. Alpha value, what I have taken as 5% or 1%, is a hypothetical value or arbitrary value. I have just taken as 5%. You may take it as 1%. Nobody can prevent you. Nobody can prevent me. But that is not the right way. The right way is I should find out exactly at what level I am supposed to either reject it or accept it. For that, we call it as a p-value. So p-value is a strength of evidence against the null hypothesis. Smaller p-value means if the p-value is less than 0.05, you reject H0 and accept H1. Anything more than 0.05, you accept H0 and reject H1. That is a cutoff value. I repeat. If you are coming across P less than or equal to 0.05, here reject H0. right? On the other hand, if P greater than 0.05, accept H0. So this is the criteria. And this value can be calculated from the table, statistical table, or you can also find it out from any statistical softwares. You can also find out from the Google. Google also gives you this p value. Is it clear to you? Now, whenever you come across, say, the p value concept, what you need to understand is that the p value is a attained level of significance, not arbitrary. The attained means the actual calculated level of significance at which the null hypothesis is going to be rejected or accepted. Rejected or accepted. That is calculated based on the actual data. So for which we make use of this 2.301. This is obtained by data, right? And this data is from the example given. The mean cholesterol of users, mean cholesterol of non-users, the standard deviation of users, standard deviation of non-users. We have the sample size. Substitute in this formula. On simplification, you get this value. Based upon this 2.301, we calculate the p-value. That is how t-test is applied. Now, next one is pair t-test. Pair t-test is, as I told you, it is applied for single group, but 2 observations. Single group, 2 observations. I'll just take you this example. Look at this example. A drug was administered to increase heart rate. Low blood pressure, right? Low BP or low heart rate. They wanted to increase the heart rate. In which case, a drug was administered. See there, the low, the before measurements are all less than after measurements. Are you able to see that? 58, 66, 65, 69, except in 1 or 2 cases. This type of data, they are all before and after. This type of data should be subjected for pair t-test. Right? I just want to show you one interesting thing. You need not go to any statistician for doing these simple calculations. Rather, you can do it by yourself. One second. You can do it by yourself using Excel. Excel is one such good software. Simple analysis, we can do it. Okay, sir. Okay, I'll just check once. My system is working since morning. It has become, Wait a minute. I will open it. Okay, I'll open some Excel sheet. Wait a minute. Somewhere I have an Excel. I'll open it. I'll check. Yes, I can do this here. Fine. This is what we call it as Excel spreadsheet. Okay. Whatever data I had it, I'll show you what the meaning of p-value. That is why I'm using. You can also do it very easily. I've copied this data here. The data which I had shown on the PPT, I've taken it here, copied it, and then I will be applying how to calculate or how to apply t-test. Okay, fine. I don't need this column also. So this is my data, correct? In every computer, laptop or desktop, this data analysis tool pack will be there. If it is not there, it is already there, but only thing is you need to install it. Installing procedure is very, very simple. What you are supposed to do is go to this file. There's a first icon, file. Click on the file. I've clicked on the file. Come to the bottom, there is what is known as option. File, put an arrow mark, go to option, click on the option. When you click on the option, there is what is known as add-ins. Select this add-ins. Then here is manage Excel add-ins. Click on go. So here is what analysis tool pack. You are supposed to select this analysis tool pack and say OK. So the data analysis tool pack is established, or rather installed. Now click on this analysis, data analysis. See there, lot of analysis, including analysis of variance, can also be done here. Okay. So what I'm doing now is pair t-test, right? So pair t-test, here is t-test paired two sample means. Are you able to see that? Visible to all of you? Paired two sample means. I'll select this and say OK. Now I'm just supposed to bring the data here. So variable 1, I'll choose the entire data, and this is after. Well, the first row in my data is before and after. That is called as string. Excel has certain limitations. I'll show you. Without selecting the sling label, I'll show you. And what are we supposed to type here? Mean difference? 0, right? Mean 1 is equal to mean 2. Mean 1 minus mean 2 will be 0. So type it 0 here. Look at there. If I click OK, it gives you t-test paired two sample for means. Input range contains non-numeric data. Non-numeric means I have taken it as before and after, right? That is non-numeric. Excel always expects data to be numeric. But I have an option here in Excel where there is a box called as labels. Select this. And where do you want to save your output? I want it in the same page. Otherwise, it goes to the next page. I don't want it. So therefore, I'll select output range in my same page. So I'll bring my cursor here and select the cell where I'm supposed to save it. You can just click OK, and the entire analysis is done. I'll just enlarge it for the benefit of all of you. There is something which I want to show you. Look at there. It calculates before the mean is 67, after 70.375. Correct? It also calculates the variance. You can find out the square root. That's not an issue. You can do the square root for finding standard deviation. Then it also calculates Pearson's correlation because they are related observations. Before and after, I told you, they are related observations. Wherever there is a relation between the two variables, you need to find out correlation. See, t value is, you forget the minus sign. We generally don't consider minus because other way also we can do the calculation, right? I don't go for the minus. Yeah, this is the one I wanted to draw your attention. This is p value. How much is that? 0.03. What is the criteria given? Are you going to now accept or reject hypothesis? You're rejecting, right? Rejecting null hypothesis, right? 0.03 is less than 0.05. So eventually you are rejecting the null hypothesis and accepting the alternative hypothesis, which shows that there is an improvement in the pulse rate after administration of the drug. That is a conclusion. Anybody has a doubt here? Since p-value calculated is 0.03, it is not less than, please remember, it is not less than. Whatever you calculated using software, it gives you exact p-value. That means p is equal to 0.03. Exactly at 3%, not at 5%, not at 1%, exactly at 3%, that is the attained level of significance, alpha value. At that level, you are rejecting the null hypothesis. This is what you also find in the literature. Fine? Okay. Now, next we move on to analysis of variance. What is this analysis of variance? Analysis of variance is an extension of t-test, unpaid t-test. Unpaid t-test is designed only for testing the difference between means of two independent population. Example I told you, it is, right? Rheumatoid arthritis and placebo. Scores, right? I have written there. First one. Or it could be the third one. Or it could be the fourth one, quality of life. All are independent, right? Only under that condition you can apply unpaid t-test. What if I have more than 2 groups? Suppose I have 3 groups. Question is, can I apply t-test? No, because t-test is designed only for testing 2 groups. If you come across 3 groups, you cannot apply t-test 3 times. Group 1, group 2, group 1, group 3, group 2, group 3 is not permitted. Because what I want is the whole data, not the split up pairwise groups. I need the whole data. Understand? So there, if I have 3 groups, null hypothesis will be mean 1 is equal to mean 2 is equal to mean 3. Alternative is only one, that is mean 1 not equal to mean 2, not equal to mean 3, for which we are applying the analysis of variance. Once again, normality assumption is very important to be checked. You have to check normality of all the 3 groups separately. All the 3 groups separately. Even if one group is not normal, you cannot apply ANOVA. This point must be remembered. We expect all the 3 groups to be normal. Even if one group among the 3 is non-normal, then we have to go for a non-parametric test. Now, with that assumption, I have some data. I'll once again take you through Excel for calculation and demonstrating how the t-test can be, ANOVA can be applied. Okay. This is my data. In fact, this was one of our clinical trial which we did in KIMS way back to 90s. That last company had approached us saying that our drug is able to improve the iron absorption better than other companies. So we were given some samples. Actually, this was not just 10 values. It was on each group, we had taken 60 samples. That means 60 into 4 groups, 240 samples were treated by the drugs given. They had given the samples. We did not buy anything. It was conducted in the rural field practice area because I am from community medicine. So we were going to rural field practice area. We did the study in 3 primary health centers. I have taken only a part of that data just to demonstrate here. The truncated data, I can say 10 each I have taken. I'll demonstrate with using Excel, right? What kind of analysis we are going to get it from this. So this is our 4 groups data, 4 companies, different companies. And I want to analyze this data and see, right, whether there is any significant difference or not. Or once again, you go to data analysis. The very first one itself is ANOVA. You can see here, the very first is single factor, means there is only one factor, that is iron intake. In analysis of variance, there are 3 types: one-way ANOVA, two-way ANOVA, and three-way ANOVA. That one study also we did in case of physiotherapy. You might have heard of physiotherapy, right? In physiotherapy, for treating non-specific mechanical low back pain, physiotherapy people have different therapies to be given. So what we had done is, we considered age as one of the criteria, because I told you pain perception differ between one age to another age. Younger age have a better perception, means tolerance, compared to older age. So we divided the age group into 3 categories, that is 21 to 30, 31 to 40, then more than 40, because we consider that after 40 there are other comorbid conditions which are contributing towards, right, as a confounders. So therefore we went by that. Up to 60 only we had taken. So 3 categories, right? Age category, 21 to 30, 31 to 40, and 41 to 60. Clubbed it. We had taken 3 occupations: drivers, truck drivers, then laborers, and housewife we had considered, not software engineers at that time. In that study, we did not consider softwares, we considered housewife. Because we had come across many cases where housewives are also complaining of non-specific low back pain. So 3 occupations were considered. So 3 age group, 3 occupation, and 3 different therapies were selected. One is called as IFT, is an electrical therapy. Second is ultrasound therapy. Third one, they call it as TENS. So 3 groups were 3 different therapies, 3 different occupation, and 3 different age group. This is known as 3-way analysis of variance. More than 2 in each case, right? Age is more than 2. Occupation more than 2. Therapies are also more than 2. Thereby, we can apply 3-way ANOVA. So there are possibilities. I'll just demonstrate this example. So I'm choosing one-way ANOVA, single factor. In this case, unlike pair t-test, I'm not selecting column-wise. The whole data must be selected all together. This is the requirement of ANOVA. Again, labels must be selected, otherwise it's not going to give you the analysis. And I want the output should be in the same page. I'll just take it at F and click OK. You can see that the whole data is analyzed. Right? It gives you group 1 summary. The average is given, variance is given, sample size is given. Don't worry about this sum because it's default it gives you. That is not the important table. My important table is down. Yeah. This is what we call it as ANOVA table, analysis of variance table. So look at here, p-value. P value. How much is this? 0.008. That means it is highly significant. Highly significant. Highly significant. That means to say the iron absorption among all the 4 groups differ. Question. That fine, sir, but how do we come to the conclusion that which particular group is contributing more for this? See, mere saying that there is a difference is not sufficient in ANOVA. I wish to know which particular group is contributing more, and that is possible in analysis of variance, what we call it as post hoc test. There's a test called as post hoc test, inbuilt component, which compares the mean differences between any 2 groups, like group 1, group 2, group 1, group 3, 1 and 4, 2 and 3, 2 and 4, 3 and 4. That many combination of mean differences, it compares, then it tells where the mean difference is more, that particular group has contributed towards the increase in iron intake. So a beautiful analysis can be done even in Excel. You need not go till any other software like SPSS or kind of a thing. So this is what I just wanted to tell you. So any other questions, I can address it. Otherwise, I should say thank you. So I should thank, first of all, Madhav, right, for initiating this one. In fact, he called me sometime in February, but I was too busy to come, right? Then I told sir I'll come sometime in March. So first week he called me, I was again too busy, but somehow today I was able to make lying for one of the colleges that I am going here as a resource person through RGHS. Lies only through RGHS, otherwise the whole thing is done, right? Yeah, thank you. Thank you very much. Thank you for all your patience hearing, right? Almost we started at 9:30, and I don't know the time now. 5:30. So thank you. Thank you very much. So thank you, sir. I thank also the madam for giving this opportunity. Bye. Any questions? They are also exhausted. Right. See, role of statistician not only in Ayurveda, in any other field also, mainly it depends, it relates to data analysis, data reporting. I told you in the morning also that any kind of studies that we conduct, unless we report through statistical methods, those results are not be approved. Anywhere for that matter. More so in medical science, I mean, not necessarily Ayurveda, in the entire medical domain, because we are supposed to prove one is better than the other or maybe same, that kind of a concept, right? So, all through statistical approach only. So, there you find the role of a statistician, but must be a qualified, knowledgeable person, half-baked person if you consider you are going to get into a serious problem. Yeah, that is it. So, then fine. Huh? Thank you. Yeah, please.
I just say that for any research work, that statistical significance is very important. So it is considered good. So as a statistician, so what you have to keep in mind.
Good. First of all, I don't have that slide. I just checked. Whether my slides tell you the whole story or not, I'll just verify. Thank you. Please sit down. Please sit down. Yeah, it is there. It is there. This will tell you the whole story. So, it is very important here that the statistician is to be consulted from the day one of the conception of the study till the end. It's not that, sir, I have collected the data, so kindly do the analysis and give it to me. You know what? R.A. Fisher, who is also known as father of statistics from England. Today, what we are talking about, cancer of lung and smoking, he was the first person to establish the cause and effect relationship. He said, taking data to a statistician at the end of the study is like asking a statistician to give a post-mortem report. Only they can do the post-mortem. Nothing is possible. That's why we say that from the beginning till the end, if you consult the statistician, they will be in constant observation how your study is going on. Not only that, before you submit your synopsis, after selecting the topic, discussing with your respective guides, please consult statistician because they should tell you about the PICO, population, and right, intervention and intervention is fine, but comparator, one physiotherapy college, they have mentioned as RCT, randomized control trial, and they have taken two different therapies, new therapies. So I was also a member of, same old, our, Dayanand Sagar College of Pharmacy, physiotherapy. I'm also a member of their ethics committee. So it came up in the ethics committee. I said, you can't do this. They went on arguing. I showed the references. RCT can be conducted only if you're comparing the new therapy with a standard therapy. And if you want to establish the effectiveness of two new therapy, please go ahead. Nobody can prevent you. Bring in one more as a control therapy. Then you have three therapies. RCT can be done. Nobody will prevent you doing an RCT, but you must have one standard control. That is all. Standard control must be there. In dental, they call it as positive control. The patient themselves, they call it as positive control, but control must be there. Without control, you cannot conduct. These kind of things, clinicians are not able to tell you. So for which you must consult a statistician, take their advice. I told you, be careful. Unscrupulous statisticians, there is a possibility of misguiding. So don't do that. Consult an appropriate person who can guide you right from the beginning, and they should also identify what is your outcome variable. I've been telling from the morning, unless you identify your outcome variable, you're not able to decide what kind of analysis can be done. So this is one, planning and designing of the study, and for appropriate method of data collection and analysis of data. So you must consult from the beginning. And yeah, it is always possible to decide which statistical method should be used to analyze the data even before commencing the study. It's not that earlier they used to write appropriate statistical methods will be applied after conducting and collecting the data. No. I can tell you how did I come to that conclusion now. The t-test, z-test, all that is possible because I have identified outcome variable. I have identified the outcome variable. That is why I am able to tell you. And of course, this is the one. It is not enough if you learn swimming, staying on the banks. One needs to get into pool and swim actually. Right? Last 2 minutes I'll take. I missed it, but I'll just go through it. In fact, I wanted to show that somehow I missed it. Not this, not this. Yes, sorry. Just last one slide. Yeah. No, not pharmacy. Yeah. I'll share these slides with Professor Madhav. This is what I wanted to bring out here. How data can be, or what type of analysis can be done for what type of data. So therefore, yeah, this is a slide. I just wanted to take you through. Look at this. So this slide is going to tell you, very important. You don't find this in any textbook. This is prepared out of my personal experience. I have told you what is the meaning of categorical data, right? Qualitative categorical data. One group. Only one group. You have categorical data. There you can use either Z test for proportion or else chi-square test for goodness of fit. Quantitative variable, this is not permitted. Don't use this because variance is unknown. So therefore, we use t-test. Then we have one group within. That is one group between. Here one group within. That is pre and post test measurement. Pre and post test. We have what is called as McNamara chi-square test. Sorry, McNamara chi-square test. Within the group. McNamara is, I'll tell you. Suppose, let us say, that stiffness, right? The stiffness. Before treatment, you make one measurement. After treatment, you make one measurement. Within the same group, but categorical. Categorical only. Or else, we have what is called as matched case control study. I don't know whether you heard of it or not. What is called as matched case control study. That means the meaning of matched case control study refers to, let us say, what is case control study? Say 20 cases suffering from the disease is selected, 20 control not suffering from that disease is selected. That is the meaning of case control. Case control means, case means those who are already suffering from the disease. Control is those who are not suffering from the disease under study. That is what we call it as case control study. Basic approach of case control study is to establish the causes. You are going backward in time. That is why case control study is also known as retrospective study. I'll just tell what happened recently. In Government Ayurvedic Medical College, Government Homeopathy Medical College, is the postgraduate course is not only in government homeopathy, it's also there in other colleges like Father Muller and elsewhere. I don't know whether in this Ayurveda, they have prepared any question bank for postgraduates or not, I do not know. But in homeopathy, they have made it. What they have made, say for example, they have selected 2 drugs, homeopathic drugs. They have given the name, apply case control study for conducting these 2 drugs or testing the effectiveness of 2 drugs. Remember, given 2 drugs, then They're telling apply case control study to, right? Test the effectiveness of two drugs. Effectiveness of two drugs cannot be tested by case control study. It is to be RCT only or quasi experimental study if you are not going for randomization. Like that, erratic questions on cross-sectional study, case control study, cohort studies. Recently, I wrote a strong letter to the principal, and last Monday, they had a board of studies meeting, and the registrar evaluation has agreed to change those questions. See, when we set a question, first of all, as faculty, we should understand and make the student to understand. So therefore, in case control study, you are choosing a group of people who are already suffering from the disease. If you are starting at this point in time, people must be suffering from the disease. For this, you are choosing a control who are not suffering from the disease. Both case and control, you are following them backward in time. That's what we say. That's why it is also referred as retrospective study. And by doing the by following them, you are able to collect the personal details by studying their personal behavior. Thereby, causes are not known at this point in time. When you started the study, causes were not known. The very purpose of case control study is to establish causes. Effect has occurred. Cause is not known. So therefore, I told in the morning, remember? I told about one example about endometrial carcinoma. You remember that? Right? Yeah. I told that in endometrial carcinoma, doctors were examining the women who are suffering from endometrial carcinoma. While collecting the history, majority of the women gave the history that are all consuming alcohol for more than 2 times a day. So doctor formulated the question, it's a research question, does alcohol consumption for more than 2 times a day causes endometrial carcinoma? They formulated a hypothesis. Actually, that example I gave to say that it is a formulation of the hypothesis, not testing. So formulation of hypothesis was alcohol consumption for more than 2 times a day may cause endometrial carcinoma. That is alternative hypothesis. How do you test? So there, will you agree simply if someone says that I am taking alcohol for more than 2 times a day, are you going to decide that, okay, you might have endometrial carcinoma? Will you be able to come to that kind of a conclusion? No, definitely not. Or can you brush it aside? No, there is no relation between alcohol consumption and endometrial carcinoma. You don't worry, you continue. Will you be able to advise like that? That is where, please remember, medicine is evidence-based. Evidence-based. Irrespective of your domain, whether you are an Ayurvedic person, somebody is a homeopathic person, or an allopathic person, or Unani, whoever it is evidence-based. We need to gather the evidence right. Then how can I gather the evidence here? So, this is where I'm talking about case control study. So what I do is, I'll select a group of women who are suffering from endometrial carcinoma, another group who are not suffering from endometrial carcinoma. I speak to these people about their behavior, about the alcohol consumption. Got it? Now, there is one interesting thing. When you start collecting the data related to the disease, is not necessarily by alcohol. We try to collect as many causes as possible. Multiple causes. What are the other causes of endometrial carcinoma? One is PCOS, PCOD, irregular menstruation. Any more else is also there. You just collect the data and try to bring out an association between alcohol consumption and endometrial carcinoma or any other causes also. This is an important design where for a particular disease, this is already fixed in your mind, but for a particular disease, there may be a possibility you have more than one cause established. This is case control study. But what we are talking about is unmatched case control study. I mean unmatched. For a case of say 40 years, I'm not choosing a control of 40 years. It may be 50 years, it may be 30 years, it happens like this. Sometimes this also alter our result. Like classical example I tell you about the matched case control study. Suppose a heart attack patient, coronary heart disease patient, who is a 55 years old person, a male, sedentary worker, alcoholic, and smoker with no physical activity. If I choose a control, a woman, right, around say, let us say 50 years, and doing strenuous work in the field, in the rural area, they can do that, right? That's not going to be a proper control. That's not a matched control. You have a control, but not a matched control. Matched control means a person, if that person is a male, 55 years, alcoholic, right, smoker, physically inactive, control must also be a person, right, not having coronary heart disease, but all other things are there. That is the meaning of matched case control study. Advantage is the so-called confounders are possible to take care of. That is where this McNamara chi-square test is applied. So anyway, so categorical, two groups, categorical, Z test for proportion, chi-square test for independence, quantitative variable, again, T test. But more than that, we go for analysis of variance. I'll show you. So in ANOVA, we have this, right, ordinal data, non-parametric. There are some things which you can read because time factor, I was not able to cover up all these things. Thank you. That's it. Correct. Yes, sir.
Sir, as a beginner, which are the books to refer inside?
Please refer to C.R. Kothari by Research Methodology. C.R. Kothari. And there is one book by name P.S.S. Sundar Rao and J. Richard. Those people are from CMC Vellore by the name Biostatistics. The other name, I don't know, that person is stopped. I don't know whether the book is available or not. Otherwise, the name is Health Statistics by N.S.N. Rao and N.S. Murthy. These three books I would like to refer.
Anybody want to have feedback? An opinion? From group photo. Yes. Feedback. Feedback. Anybody want to tell? Come. Yes. Come to the stage. tell your name and all.
I'm Dr. Shanmugapriya from Shalyatantra Department, PG first year. Actually, I would like to thank Dr. Madhav Dikari sir for arranging this innovative session. And I would like to thank Dr. Ganga Boraya sir also. From morning 9 o'clock till now 6 o'clock, you are very much means like enthusiastic to teach us, and your teachers are very good. Like we are knowing these things in our UG. We wrote means we prepared for our exam perspectives, not for our like we could have chooses like these things, and we could have applied these things in many manner like that. But you taught us a very good and innovative class from morning to till now. We all are attentive, and we got many good points, and we will sure we will use these things for our research synopsis topic and for our examinations, everything. And once again, thank you so much, sir, for this innovative session. Thank you.
Good evening, Dr. Gangaburai sir and Dr. Madhav Dikari sir, and good evening all. So firstly, I would like to thank Dr. Gangaburai sir as we first year scholars. Now we have to do synopsis, sir. Like we have like little bit idea, but we are very worried about like what to select, what to do, what all the problems we'll face. Like you said today, inclusive criteria, exclusive criteria, and that exclusive criteria is the most important. Sampling and then selecting drug and then thinking about it. So by attending today's seminar, we got a little idea like how to proceed further. Like you just said today, all basics are like from basics, we got a good hold on this mean, median, mode, standard deviation, and all things. Like I think sir has completed today whole syllabus of statistics in one day. Right, guys? And today, your last slide was you can't swim like standing on bank. So we have read this, like listened, read. Now we have to go and
Put into practice.
yes, put into practice. And thank you so much, sir. Thank you for giving your so much valuable time. Thank you. It means a lot, sir. And next, I would like to thank our resource person, Dr. Madhav Digavi, sir. I think we are fortunate, very fortunate, guys, because he is the person. Like, if I go him approach like sir, like this, he'll give a full like detailed description. He brings out the scientist in you, and it all depends on you. Like, you want to woke up your scientist or keep it dead. Thank you so much, sir, for arranging this Paryashana 2024. Thank you so much, sir. And lastly, I would like to thank our classmates for carefully listening. Thank you so much.
Group photo. Fast. Close. Lekin ಏನು ಮಾಡುವ ಚಂತೆ ಅಂತ ಹೇಳಿ ಮಾಡೋದು ಬ್ಲಾಕ್ ಚೇರ್ಸ್ ಹಾಕ್ಬಿಡಿ ಸಾಕು ಇನ್ನೊಂದು ಗೊತ್ತಿಲ್ಲ ಅದು ಆಫ್ ಮಾಡಿದ್ರಾ ಇದರ ಕಮ್